Good morning. I see today we have a full house from the government employees medical scheme. There is an objection raised about me chairing the hearing on the grounds that I once acted for GEMS. I don't know, it was 2012 or 2013. We've considered the objection. We believe there's no basis to the objection. We've rejected it, but I thought we should announce it in case anyone wishes to say anything. GEMS is here, everyone is here. We will give our reasons in due course, but my colleagues may want to add their assent to the ruling.
I concur in the ruling.
And I also concur in the ruling.
Thank you. We shall then proceed to the GEMS presentation. We should start off by introductions and also a sense of who will be speaking on behalf of GEMS, because those speakers will have to take the oath.
Good morning, Chair, and to the members of the panel. My name is Dr. Stan Molwabi. I am the incoming Principal Officer of the Government Employees Medical Scheme. I will be one of the presenters today. So we have a few presenters that will need to take the oath, and I will be guided by yourself, Chairperson.
All right, let's do the following. Are you going to be speaking?
I am also going to be speaking, and a number of speakers will be speaking.
All right, let's take the oath then. You will tell me who else needs to take the oath. Let's start with you then. Will you take the oath or the affirmation?
I will take the oath,
The oath is
Chairperson.
okay, all right. So will you say after me, I, and your full names?
I, Stanley Molwabi,
Do hereby swear
do hereby swear
that the evidence I shall give
that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing else but the truth.
and nothing else but the truth.
If so, raise your right hand and say, so help me God.
So help me God.
Thank you, sworn in. Who else will be speaking? Okay, Dr. Good. Will you also take the oath or the affirmation?
I'll take the oath.
Oath, yes. Will you then say after me, I, and your full name?
I, Convent Gulab,
Hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing else but the truth.
and nothing else but the truth.
If so, raise your right hand and say, so help me God.
So help me God.
Thank you. Who else?
He will be followed by Mr. Ishmael Mohapi.
Mr. Mohapi, yes. So will you also take the oath?
I'll take the oath.
Yes, okay. Say after me, I, and your name.
I, Ishmael Mohapi,
Hereby swear
hereby swear
that the evidence I shall give
the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please raise your right hand and say, so help me God.
So help me God.
Thank you. Is there anyone else?
Dr. Soli Mutuba.
Dr. Mutoba? Yes. All right. Will you say after me, I, and your name?
I, Solomon Mutuba,
Hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If so, raise your right hand and say, so help me God.
So help me God.
Thank you.
Mr. Frank Wilshire.
Mr. Wilshire. Okay. And will you also take the oath?
Yes.
Yes. Okay. Will you say after me, I, and your name?
I, Frank Wiltshire,
Hereby swear
hereby swear
that the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
nothing but the truth.
nothing but the truth.
Please raise your right hand and say, so help me God.
So help me God.
Thank you.
Mr. Nias Ibrahim.
Mr. Ibrahim. Will you also take the oath or? Yes. Will you say after me, I, and your name?
I, Niaz Ibrahim,
Hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Please raise your right hand and say, so help me God.
So help me God.
Thank you.
Ms. Anita Dutoy.
Ms. Dutoy, are you not an attorney?
I am, yes.
In private practice?
Yes, I am.
So are you
I'll
Get-
take
making
the oath
submissions
as well,
or- all
because
right,
we have
because
some, I have some
factual issues?
operational-
All
yeah.
right, no, that's fine. Let's take the oath then. Will you say after me, I and your full names?
I, Anita Retoy,
Hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth,
So raise your right hand and say, so help me God.
so help me God.
Thank you.
Ms. Lynn Gitter.
Skitter. Is she the last?
Two more.
All right, Ms. Skitter. Will you say after me, I and your name?
I, Lynn Geeta,
Hereby swear
hereby swear
the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If so, please raise your right hand and say, so help me God.
So help me God.
Thank you.
Chair, we also have two independent experts who are statisticians and actuaries, Mr. Craig Gass.
Mr. Hess.
Mr. Craig Gass.
Oh, Gas. I see. So, Mr. Gas, will you take the oath?
Yes.
All right. Will you say after me, I and your name?
I, Craig Gates,
Hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
So raise your right hand and say, so help me God.
So help me God.
Thank you.
And Chair, last but by no means least, it's Professor Emeritus Paul Fati.
Thank you.
Professor Fati. So will you also take the oath?
Yes, yes, sir.
Would you say after me, I and your name?
I, Libero Paul Fatty,
Hereby swear
hereby swear
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
If so, please raise your right hand and say, so help me God.
So help me God.
Thank you.
That those will be largely our presenters, Chair.
Thank you. So you direct us about what structure or format you want to follow in your presentation. You would have seen these proceedings. We ask questions and we don't wait for you to finish. So you let us know how it's going to be presented. So it's largely up to you.
Thank you, Chair. At this stage, I'm going to hand over to my colleague, the Principal Officer, Dr. Guni Gulab, who will do the first part of the presentation.
Dr. Gun.
Thank you, Chair and the panel. So I'm going to give an initial introduction to GEMS to give some background, and then Dr. Stan Malwabi will follow to give the context of GEMS' response to Section 59. So that's the first part of the presentation. Dr. Malwabi mentioned that he's the incoming PO and I'm the outgoing PO, and it just happens to the panel that it's in this week. So at the end of this month, I exit from GEMS, and Dr. Malwabi takes over.
We should welcome the incoming PO
Yeah.
and congratulate the outgoing one.
Thank you. Thank you, Chair.
Thank you.
Okay. Our slides have been provided, and I will go fairly quickly through them. But as you've indicated, we have been watching the proceedings, and we are aware that the panel would want to ask questions. So firstly, the mandate of GEMS is as part of a cabinet mandate that the state as an employer seeks to ensure that there is adequate provisioning of healthcare coverage to public service employees that is efficient, cost-effective, and equitable. The vision of GEMS, and I'm just going to focus on that, particularly around its intention to be a driver of transformation aligned to the principles of universal healthcare. And there's two components to that. Firstly, about addressing the inequalities of healthcare in our country. GEMS is absolutely committed to that. And secondly, transformation in terms of broad-based Black economic empowerment. In terms of the Medical Schemes Act, the Medical Schemes Act defines the business of the scheme as a scheme undertaking liability for claims in return for contributions. I'm not going to go in further detail. The panel is fully aware of that. On the next slide, this is going to touch on that GEMS is a restricted medical scheme. We are a relatively young scheme. We became operational at the beginning of 2006. And currently, we have 6 options that address the needs of our membership base. From the main impact, and we'll touch a little bit more on this, Dr. Malwabi will go into some more detail on this, but GEMS, through its existence to date, has covered in excess of 1 million beneficiaries who were previously not on a medical scheme. If we look at the journey of GEMS since its inception, as I indicated, it was initiated as part of a cabinet mandate in 2004. We were registered as a medical scheme in 2006 and became operational, 2005 and became operational in 2006. In the early period up to 2014 was characterized by a rapid growth period, and again, Dr. Mulwabi will be talking to it in more detail. I think a key point where we'll be going into more detail, in 2016, the scheme faced a particular high level of claims exposure, and it was heavily publicized in the media, and it's defined how the scheme is operated in the period subsequent to that. If I go to the next slide, then this highlights just our current strategy period from 2017 to 2021, under which we're operating. And as a consequence of that experience in 2016, which subsequently became known that it was a broader industry experience, the focus on GEMS was to focus on its sustainability and particularly its financial sustainability. And we'll be able to demonstrate how the scheme has effectively addressed this. In the current phase, which is the phase 2, we're focusing particularly on simplifying our products and services, very much in line with the health market inquiry, where GEMS has made substantial contributions. And we're pleased to say that we've introduced a product called Tanzanite 1, which is converting Sapphire into Tanzanite 1, which specifically we believe is a benchmark product for the basic benefit package. We also extensively have made submissions to both the health market inquiry and the NHI bill and the MSA bill, and we believe that we want to be an active contributor towards the changing of the healthcare reform in our country. And all of this aligned towards the journey towards NHI, which is official government policy. Then on the next slide, very briefly, just to show some of the deliveries to date under the strategy. As I indicated, we're now in the second phase. From a service point of view, we now, in 2019, have had some of the lowest number of complaints, and our membership has grown substantially during this period, and Dr. Mulwabi will talk more to that. From a governance point of view, and I'll touch on this a little more in detail, but we've had a consecutive 13 years of unqualified audits, which in the current environment in our country we're very proud of as an organization with the name Government Employees Medical Scheme. From a healthcare point of view, we've demonstrated consistent improvements in healthcare indicators as measured both by the Council for Medical Schemes and an independent organization, the HQA. And lastly, from a financial point of view, while it's not yet audited, the 2019 December period, we're now ahead of the statutory requirement of 25% by a significant margin. We then move to the next slide, which addresses the issue of transformation. And what this slide seeks to demonstrate is that GEMS, since its inception, through its service provider model, has been an active promoter of broad-based black economic empowerment. I'll give two statistics just to reinforce that. If you take our own employees reflect the demographics of our country. And then if we look at our procurement, both our current procurement in 2019, but also our existing service providers, all of them largely are level 1, 2, or 3, and mainly level 1 and 2. We then look at the manner in which the scheme...
I ask you about the issue of transformation.
Yeah.
I mean, I obviously accept that GEMS is a transformative organization and that it's doing a lot more than other industry players. But you would also accept that transformation is not just a question of ownership. It's also the transformation of your practices outside in relation to your engagement with stakeholders such as doctors.
Yes, absolutely.
And that if there are accusations of racial discrimination, even at the level of outcomes, GEMS would be at the forefront of investigating and stamping them out.
Agreed.
And so what we are finding very difficult to understand is that these allegations of racial bias in the way in which black doctors have been treated are as old as 2014, 2015. But what we are not finding is any consistent pattern by medical schemes, particularly by GEMS, to proactively engage with the discussion around racial discrimination and to show us that once the allegations surfaced publicly, these are the steps that we took. So on the one hand, your claim to transformation is a valid claim, but I struggle to understand why it's not matched by consistent practice over the years.
Yeah. So, Chairperson, the first comment I would make is that we have extensive engagements with all of the leadership of the healthcare providers in the country. For example, IPEF, SAMA, etc. And these are regular and scheduled meetings. And I can assure you that at no stage has there been any accusation systematically of GEMS being party to this kind of process.
No, I understand, but you know, the allegations around racial discrimination are old allegations. The council only investigated them last year. If GEMS is right in its claim that it's at the forefront of transformation, I'm not saying this is an accusation, but I'm just saying any reasonable person would have expected the organization that embraces transformation to be at the forefront of investigating and dealing with the racial discrimination allegations. Now, why do I not find anywhere where you say, look, these things came up, this is what we did, we asked the people that we work with, deal with this, give it priority. I take it, there are meetings obviously, but I just don't see any tangible steps that you have taken over the years. What I see is a lot of rebuttal that there is no racism, but the fact that you've investigated this only after the CMS investigated it is really a problem for me.
No, and we accept the point. In Chairperson, the best way I can attempt to articulate it is that our position is that if you speak to all of the leadership of these organizations, including the ones who have recently raised the matter, they will communicate to you that GEMS engages in a very fair and progressive manner, and their accusation is less against GEMS. I think one issue that we believe that has put GEMS into the forefront of this debate is our list that has been there historically since 2013. And no one has talked about it since 2013 until there was an accusation on the SABC, and as a consequence, the introduction of the panel of this. So our position would be that the general view of healthcare professionals is that GEMS is not party to this kind of behavior.
But what is
I
your
don't
response to the list?
So our response to the list is that at the time that we introduced it, the medical scheme, our priority is our members. We have, as part of the Medical Schemes Act and its regulations, taken the position that where we introduce termination of direct payment, our members need to be aware that if they go to that provider, they can go to that provider, but if they go there, they've got to pay and reclaim, and our members were asking, please provide us that information. So that was the basis of that list, and it's been in existence since 2013.
I don't follow this. I mean, and there's not a criticism. We're trying to really get to the bottom of the problem, and there's no one is being blamed for anything.
Sure.
You see, we get Dr. Gumede coming here with a list of more than 60 practitioners coming from GEMS as being the target of the investigation. He calls it the blacklist, and it's true, it's the blacklist. And I see your presentations, I read all of these things you've submitted to us. You don't engage with the blacklist.
Chair, so the way that we have specifically responded is that the independent report will provide some of the additional information that will bring clarity to this definition of racial profile.
Can I just ask a question on that point? Have you met with solutionist thinkers and the National Healthcare Professionals Association?
With both associations, including the majority of the people, Ishmael, Dr. Stan, myself, with both NHCPA and solutionist thinkers on 2 occasions, and then outside of that on a regular basis, Ishmael and the organizations.
And what has been the outcome? Because you see, they were here, they spent the whole week with the complainants. We didn't get any sense that there is any progress that has been achieved in the same way as you are presenting it, that they have accepted that GEMS does not engage in racial discrimination. Otherwise, there would have been no point in giving us the blacklist.
Chair, I'm under oath here. I can say that I've been personally in these engagements. I will say that the leadership of both organizations have appreciated and acknowledged the manner in which GEMS is going to engage with them post the proceedings on an ongoing basis. I'm prepared to be on record on that.
Thank you. You may proceed.
Thank you. If we look at the governance of GEMS, we have a board consisting of 12 board members with the requisite subcommittees of the board that oversees the strategy and implementation of the strategy of the scheme. In terms of the affairs of the scheme, all of these are undertaken in line with the Medical Schemes Act, and GEMS also subscribe to the King principles. The board then appoints and oversees the work of the scheme through the principal officer, and there's a full management team that is under the principal officer, and as I've indicated to you, that Dr. Malwabi will be taking over from the 1st of February. In terms of the governance features, we have an extensive set of policies that govern the work of the scheme, and all of these policies are aligned to ensure that we do not in any way support discrimination, and as I've indicated previously, that we have a consistent track record of unqualified audits as a scheme. So just as the initial part, and a number of these areas will be elaborated further, both by Dr. Malwabi and other presenters, our position is that GEMS is in compliance with the Medical Schemes Act and its regulations, including Section 59, but we'll go into that in more detail during the presentation, that GEMS, by its design, is a transformative organization, and that we believe to date we have a track record of demonstrating good governance. Chair, I'm going to hand over to Dr. Malwabi.
Thank you.
Thank you, Dr. Kudi. Thank you, Chair. Chair, the next part of the presentation of the submission, which I am going to present, tries to set the context to the response that we have submitted, just from the context of the membership of GEMS and the financial aspects of the scheme. Throughout our presentation, we will refer to the fact that GEMS is the second biggest medical scheme in the country. We are a restricted medical scheme which covers government employees largely. And Chair, we basically have a very broad definition of who can join GEMS. And as a result of that definition, about 1.18 beneficiaries of GEMS were previously uncovered, have now been covered over the past 16 years of our existence. We have the broadest definition of a beneficiary in that we can have, at any point in time, 5 generations of a family belonging to GEMS. The significance of that is that that has enabled access to healthcare with the products that we have. So we basically, with 65% of the GEMS membership were previously not on any medical schemes. And we believe that without this, they would not have been able to access healthcare. We have paid over 15.7 billion in 2018 to these families who would otherwise not have accessed healthcare. Just to put some context to this broad beneficiary definition, we want to share with you the story of Thandi, who was one of our first members who joined the scheme in 2006. She earned at that time below 6,000 rand when she joined the scheme. She currently has about 8 dependents, having started with about 2. She was not on any medical aid before GEMS came into being. In 2018, Thandi benefited to the tune of about 223 in claims that we paid on our behalf. And over the period that she has been a member, to the tune of 1.9 million rands. This is just a demonstration of the benefit to those members based on the product that GEMS is. We just the examples below are examples of families. One of the families has 11 beneficiaries on the scheme, where we have those various relationships being covered. If you look at the extreme right column, the member has actually covered only grandchildren. So it's a combination of how this broad beneficiary definition has actually benefit those who are on GEMS. We, in line with the mandate of GEMS, GEMS focuses on registering employees who are defined as salaried 1 to 5 employees. These are typically the employees who earn between 8,000 and 500 in the state. In the GEMS environment, the GEMS population consists of 33.8% of the GEMS population is made up of this low-earning employees of government. And then the rest of the bar chart actually just shows the rest of the composition of the GEMS beneficiaries. Chair, this is the first slide where we actually refer to race classification, albeit hesitantly. However, we thought it is important, and this will become significant later in our submission. So when a potential member applies for membership, they are not specifically asked to submit what their race classification is. However, there is a section that says you can voluntarily say it or not. So as at August 2019, 51.1% of those members who had joined had indicated what race they belong to. And we have used a race classification in very broad terms here. We said black, it's 91.35 of those 51% that have actually entered that field. And then only 8.65 are white or non-black, as the term that has been used in the report that we reviewed. It's also important to point out where GEMS members are. We think this is important. GEMS has the eligibility of GEMS members is in about 240 government department or entities that also employ government. The KZN Department of Education is the lasted employer group with about 57,000 members of GEMS. We have a very large representation in the rural areas. In fact, if you look at the geomap in terms of those dots that are there, which represent clusters of members, every nook and cranny of the country, there is a GEMS member, even in the remotest countries, and this talks to access to healthcare services. As I indicated earlier on, Chair, GEMS is the largest restricted medical scheme in South Africa. We just thought we should share with you the numbers that are depicted on that slide. In 2014, we had more than 687,000 members, covering 1.838 beneficiaries. By 2019, this had grown to 621 members, covering 1.892 beneficiaries. The contribution income has grown from 26 billion in 2014 to just around 40 billion by the end of 2019. GEMS is a big business. We process a considerable number of claims, and in terms of the claim lines, in 2014, that was 91.6 million at the end of the year, and by the end of 26, that had increased to 95.8 million claim lines. The reserve ratio, which is...
Dr. Mawai, sorry to interrupt. Can I just ask you a question before you move too far away? I can't see the number of the slide, but it's your statement that members who voluntarily share their race information equate to 51.1%. So are you saying you only know for sure the race of your membership in relation to, you only know 51.1% of your membership, you know the race?
Based on the definite factual information that we have on record.
So you don't know the race of your full membership?
We don't have it 100% on record of our membership because we don't have that entered into the membership application forms.
And have you made any attempt to determine the race of your whole membership?
As in maybe via a survey or a...
Yeah, do you know? Or you accept you don't know the race of your whole membership?
Well, it is simply
The race
because
classification.
race has never been...
Sorry, it's not an accusation. It's just do you
No.
know or don't you know? You don't know.
No, we don't know the 100% composition. We only have that 51%. Andre.
I mean, what I don't follow with this, I mean, I read this when you submitted it to us, I think last night or something. What I don't understand about it is that GEMS is a restricted scheme. You know the membership base from which you are drawing members. You know the racial composition there. And to come and tell us that you only know 51%, I mean, I just don't follow that.
Chairperson, as I explained that earlier on. Yeah.
Anyway, yeah,
It is
thanks.
because race is not really a factor in how the scheme is run. I think that is
No, I
really
mean,
the basis.
as my colleague says, this is not a criticism. I mean, it's just that it's baffling to me that to say that you don't know the composition of government employees from whom you draw your members.
Okay. Okay, Chair, let me continue. So in terms of the reserve ratio, in 2014, we will notice that the reserve ratio was 10.03. I will mention now, but even in subsequent slide, we all know that the statutory requirement is 25%. At the end of 2019, that is December, that figure now has risen or improved to 31.29. This is an unaudited figure. We are just 1 month beyond the end of 2019, and that process is still underway. Chair, I think this is important just from the perspective of how we process claims. And this slide talks largely to the complex interpretation of Section 59 of the Act. So we're also taking this from the fact that during the public hearings, some of the healthcare providers and the societies submitted that the medical scheme should be in a position to fully validate, and I just want to emphasize validate claims within 30 days period provided for in Regulation 6. So just to indicate what happens on a monthly basis in the GEMS environment, we receive about 268,000 claims daily. On a monthly basis, that figure is about 8.1 million claims. Every month, we pay about 7.8 million of those claims. That translates to 95.7% of claims that are paid within 30 days. The balance of about 4.3 that is not paid could be for various reasons. It could be those that are identified as possible fraud. It could be those that are not in accordance with the scheme rules. It could be those that are not in compliance with the Act where there is a need for further clarification and validation. So,
Can you just explain this to me? Because in this slide, I mean, it is obviously very relevant to the work of the panel. What is the mechanism that you have for the validation of claims within 30 days? I mean, in your slide, all you say is that at best as possible, GEMS adjudicates all claims within 30 days beyond validating it against the requirements for a valid account provided for in Regulation 5. But how do you actually implement Regulation 5 internally? What happens? A claim is received, you've got 8 million of these things, and
yes.
you must decide whether some of them are fraudulent and others are genuine.
So I'm going to respond in very general terms. If there's a need for any technical information, I may have to refer to.
No, sure.
Yeah, so in essence, we have the majority of claims are received electronically. And there is a very small percentage of claims that would still be received by means of paper. These claims would then be received by our administrator, and through the existing systems, the claims would be put through the claims validation systems, and those that would have been validated to be correct in terms of the rules, in terms of the Act, and the clinical rules, protocols would be paid. those that would be picked up to be having any form of queries would be that remaining 4.3. And these are systems are set up to basically detect the validation based on the rules that have been set in the systems.
What is that validation system? What does it look like in practice? Because the problem is that it's this validation system that is faulty, that leads to payments that should not have been made, which then requires GEMS to try and claw back the money after the 30 days.
Yeah. So it is this, at this stage, Chair,
it's too technical.
It is
Okay.
very technical
All
in
right.
terms of, and I've given the broad
Yeah,
outlines in terms of the rules of the scheme, clinical protocols, the act, and all. Those are the broad outlines. But if we need to go to the technical, I would have to
All
refer
right.
to the
No, that's
technical.
fine. We'll come back to it. I mean, I don't want to disturb your flow of presentation.
Okay.
Sorry,
So-
Dr. Malabi, and someone will be then addressing what happens after the 30-day period, the outside of Regulation 5,
Yes.
the Regulation 6 part of.
So in our submission, in the legal part of our submission, we actually go into more details about Section 59 and the interpretation of Regulation 5 and 6. And that will be as a part of our submission later today. So as best as possible, Chairperson, we adjudicate, and I underlined validation earlier on. Now I'm using the word adjudicate. And we are saying we adjudicate all claims within 30 days. But adjudication does not necessarily translate to payment, right? So those that are validated would be paid, and that is the 95.7.
Can you explain what you mean by adjudicate in that context, as opposed to validate?
Okay, validate is that the claims are valid. Adjudicate is that we have gone through them, we have checked, and some of them are valid for payment. Some, the 4.3%, we need to do more work depending on what the reason is. We could be as simple as informing a member that you have exhausted your benefits, we are not going to honor the claim.
That's what you mean by adjudicate, is you
Yes.
inform the member the claim will not be paid.
It's an example, advocate. So it is our view that the parties that made submissions that schemes generally do not pay the claims, it's not true. Basically, simply on what I've tried to tell you, the majority of claims are paid within 30 days. What has been the impact I have alluded to the reserves earlier on, and I did indicate that we are required to hold 25% of our annual contribution in reserve. In 2016, our reserve dropped to alarmingly low levels, and it is our submission that there are instances of fraud, waste, and abuse, which played a role in once this media reports came to the public domain. There was a lot of panic amongst our members. They were not sure if the scheme is sustainable, and we had to do something. And that's something I want to talk to.
Dr. Mwabi, sorry to interrupt. This event in 2016, you say it's your submission that instances of fraud, waste, and abuse played a role. Why do you say that?
We are basically saying attention then became drawn to GEMS, and there are various things that could, and I'm going to allude to the various contributors to what could have led to the lowest reserve ratio.
So there are a number of factors that
There are a
led to
number
low
of factors,
reserves
but
in
one of those could be-
2016.
That's right.
Okay, thank you.
Okay. So what happened is that just showing the trend in that table that we are, is that in 2014, GEMS had a reserve ratio of 10. In 2015, it went down to 9. As I indicated, in 2016, that was the lowest we have. And this is probably what we could say was the year of reckoning in terms of our reserve ratio. It drew attention, and we had to look into why we are where we were at that stage. And earlier on in the presentation, Dr. Gulab showed a slide which shows the strategic journey that GEMS has traveled. that slide, which is slide number 9 on the presentation, it basically shows that the emphasis from a strategic thrust point of view was growth, and we achieved growth at the beginning. Then it was promote access, and it talks about quality, talks about reduced non-healthcare cost. Those were the strategic thrusts. It is possible that as we are concentrating on these, right, there was a lot of claiming that was happening. We landed there, and it drew attention, and we had to introduce another strategic to actually look at the thing that drew focus, which was our reserve ratio. And
Dr.
so,
Mwabe, sorry to interrupt again. Just so you understand what I'm trying to explore. I understand you're making submissions on your reserves and that you're in a difficult position clearly from 2014, in particular in 2016. And the impacts, well, the various factors that may have impacted on these reserves. And of course, we accept that this is an issue for the scheme. I mean, you're not meeting the statutory minimum, you're financially vulnerable, we can see that. But I want to understand, if you were established in 2006, were your reserves ever over 25% between 2006 and 2014?
no.
I think you had an exemption then which
No.
allowed you to build your reserves or something
so
like that.
in terms of the Act, Advocate, through you, Chair, the scheme is established, and once it is registered, it is allowed, it has submitted a business plan. And generally, the Act will then allow you to build your reserve over a 5-year period. You are expected to reach that 25 by 5-year period. So if you don't, you then report regularly to the regulator why you haven't reached, and the regulator scrutinizes the business plan and then monitors you. And we were under monitoring during that period by the regulator.
Thank you. I had some vague recollection of that. So to understand, in 2018, you reached 24.7, which is close to the statutory requisite for the first time.
That is correct, sir.
Thank you.
That is what I'm going to explain. Just
to understand this slightly different point of focus. You see, we had the Competition Commission to present to us at the commencement of this inquiry. They gave us the interim report then of Judge Noble. It's now been made final.
Yes.
What he finds, I mean, it's a long report, but you could be patient to read it. What he finds is that one of the biggest cost drivers in healthcare is hospitalization,
that is correct.
which is unnecessary hospitalization. Now, what is your experience about that? Because, and yesterday we also had this debate with one of the schemes, I don't want to say which one it is, and when I actually look at the numbers, I just found that the biggest consumer of money is people going to hospital when they shouldn't.
Yes.
So I just get, surprised when you suddenly say, well, we dropped from 9 to 6, it must be fraud. What about the fact that actually where the money goes is hospitalization?
Okay. So, Chair, the subsequent slides will answer the question about fraud, whether it is fraud or not. We do have a slide, and I don't know if you can allow me to just quickly go through. That
Sure.
will address that question. And then the question about hospitals is also alluded to subsequently in terms of the measures that we have taken to start looking at those cost drivers that are mentioned in the health market inquiry. Chair, at this stage, in 2016, there were media reports, and I'm not going to go into the details. There was a lot of public discourse about the fact GEMS is said to be financially unsustainable because of the low reserve ratio. And at that stage, the Claims Management Forum was established. And the Claims Management Forum is going to talk to those interventions, including fraud, waste, and abuse. We had to take action, establish the Claims Management Forum, and the aim was to also focus on fraud, waste, and abuse, but it was not the only thing. We had to look at the data analytics that are performed by our administrators, our managed care organizations, actuaries, to actually identify where the problems are. At that stage, when the Claims Management Forum was established, the projections were that we were going to post a loss of 1 billion rand at the end of 2016. Having implemented the claims management, it was starting to have effect, and by the end of the year, that loss had actually...
And the loss was due to what?
No, that was a projected loss. based on our actuarial models, the claims trends in the previous years. So these, because what happens...
But where does the loss come from? What's the loss? How do you calculate loss? Based on what?
The loss would be based on the net healthcare result in terms of the claims incurred against the contribution income.
So it could be just the high cost of particular services.
And that, I think it is the next slide that is going to really talk to those issues that contributed to that performance. If I can...
Before you move on, I would just like some factual, very, very specific factual information around the Claims Management Forum and what exactly they considered then and today.
So we are in 2016. We have a very low reserve ratio. There is public discourse about. We then set up the Claims Management Forum. It has terms of references, and the service providers. The model of GEMS is that is that we have the principal officer, the executive team, and the staff that is directly employed by GEMS. And then we have a lot of these services are outsourced, and we oversee the outsourced services, which is administrator, managed care organization. So led by the principal officer, we established the terms of reference. And in essence, the terms of reference of the Claims Management Forum was to establish where are we incurring these high claims, and are these claims really being incurred, and are they being paid appropriately? What is it that we can do better that we were not doing at that stage? So in summary, that would be what the Claims Management Forum was established on.
So if you had to list the levers that you use to manage your claims, what are they?
Sorry, if I have to list...
If you had to list the levers, I'm hearing you that you're saying one of the levers are fraud, waste, and abuse, but there are others, but I do not hear any of the others.
I was going to talk to that later, but I'll go to that slide. I'm on that slide. It's slide number 3.
So can you also give us the report of this Claims Management Forum that was produced in 2016, which then told you exactly what the cost drivers were?
Chair, can I just confirm that? Are you asking us to submit a full report?
Yes, I mean, what you've just testified about, which is the CMF gave you the cost drivers.
Yes.
Because you wanted to know where you were losing money.
Yes.
And they gave you a report.
Yeah.
So we want the copy of that report.
Okay. Okay. We will submit the CMF findings. So, but in a nutshell, the Claims Management Forum was looking at those areas. Under the column focused interventions. Up until 2016, before the formation of the Claims Management Forum, GEMS was not underwriting. And underwriting of new members it's provided for in the Act. However, in terms of the mandate that had established GEMS, and the strategy was that we want to increase access as best as possible, so GEMS was not strict on underwriting. So underwriting was one of the areas of focus. We then looked at also the protocols that determine what should be paid or not, what should not be paid. We had to look at whether they are up to date, and these had to be reviewed. Hospital was mentioned earlier on, Chair, and we then also enhanced our in-hospital case reviews from a case management perspective. And then there is fraud, waste, and abuse. We had to establish initiatives to look into the initiatives that look at fraud, waste. And then the MPL is basically what you call the medicines price list. Those were reviewed. And then also in 2017.
So can you explain the figures?
The triggers for each one of these.
Well, not for each, but just what do you mean by FWA initiative 272 million?
Oh,
and then
okay.
In 2017, naught in 2018.
Okay, I will explain that column. So these interventions, these are the areas that the Claims Management forum focused on. And EVO is emerald value option. Before I go to the next columns, I just want to explain that one of the things that we did, we looked at how we can improve on how patient access healthcare. So emerald value option is a sub-option, what is normally referred to as efficiency discount options that are approved by the regulator. We also introduced EVO in 2017 and showed that if we change the way that members access healthcare and we influence that, we could also influence the downstream costs, and we call that care coordination. And in the rules in establishing this efficiency discount option, we set rules that were approved by the regulator, which were saying you have to choose a doctor, do not go to many doctors. For you to access a specialist, you have to be referred by one of the network doctors, and you have to go to a network doctor. And the columns in 2017 depict what were the savings from these initiatives. That's what those numbers are that are depicted. So that those, in each of those initiatives, we have the savings that we realized during 2017 and the ones that we realized during 2018.
Okay. Can you just go back to slides 29 and 30, because I just wanted to ask you a couple of things. I know you've moved on to slide 31.
Okay.
But maybe slide 31 is better understood if we understand 29 and 30.
Okay.
So in 29, okay, well, you just take us through 29.
This one?
Yes.
Okay. So in essence, we basically saying that we looked at the various claims patterns in the country, and we established that the claims pattern in KwaZulu-Natal are about 18% higher than, on average, the rest of the country. The various provinces have got various influences, whether it be the burden of disease and other behaviors of providers. But what was significant is that the KZN was a significant outlier in that it was 18% higher from a claiming perspective. And also the admission rates were significantly higher in KZN when compared to the rest of the country.
Yes, now that's what I wanted to understand, that as early as 2016, GEMS had identified that the problem where the loss is in KZN, it's a geographic problem.
I am confirming that we had that information by at that stage.
And now, once we locate the problem, you've even redlined KZN here.
Mm-hmm.
It's fair to infer then that you would focus your so-called intervention at KZN as a province.
There is a more focus on where we identify the problem in KZN, but it doesn't mean in the other areas.
No, I understand, but yes, you would spend your money in KZN in order to plug the holes where you're losing money.
That is reasonable, Chair, and that's really what happened.
Yes. Now, the 4.5 billion per annum that is lost as a consequence of admissions, how much was lost by GEMS as a result of admissions? Because this is I think this is a generic cost to medical schemes, but what is the figure for GEMS?
So, as you can see, it says the estimated, and I think that's...
What is your estimate?
So, within GEMS environment, I cannot give you the figure off my head at the moment, but we have estimates, I think, in the subsequent part of our submissions, where we talk about fraud, waste, and abuse.
Now, you see, that's what I don't follow. So, sorry, because you see, at 31, page 31, in hospital and FWA are separate items. And yet, hospital is part of waste and abuse.
Check, and I was just trying to get the slide you're talking to.
Yes, at 31, right? Okay, that's fine.
Yeah, it's this.
See, FWA is identified separately from in-hospital case reviews.
Oh, yes, okay.
Now, and And the problem is that waste and abuse includes hospitalization.
Oh, okay. So, Chair, let's look at hospital case reviews. We talk about length of stay, we talk about level of care. And at the level of case management, when we interact with the healthcare providers, we have case managers who interact and say, if I can make an example, appendectomy, you should be in hospital for at least 3 days. When we see a trend that, but why is it that this doctor is keeping appendectomy cases for 5 days? We would then go and engage and say, but the average, the standard is 3 days. So a case review that results in those savings could be because of inappropriate length of stay, inappropriate level of care, which means a doctor who keeps patients in ICU for longer than they should be. Maybe they should have been moved into high care and then a general one. So those interventions would be provided for in the in-hospital case reviews. They are not necessarily
They're not
fraudulent.
counted as waste and abuse.
They are not necessarily fraudulent in nature.
Or waste or abuse.
Well, it could be inappropriate use of healthcare, and it could fall into the abuse category, but we classify them as those that belong to managed healthcare interventions.
Is there a benefit to the doctors who increase the length of admission? Or is it just the hospitals that benefit?
If you have a patient in hospital, you normally would see them every day, so that would mean 2 extra consultations. And this is in general terms. So there would be a monetary benefit.
And where does the money go to? I mean, if we are just speaking in ordinary terms, since this is a public forum, the money for hospitalization, let's face it, goes to private hospitals.
Doctors get paid consultation fees for seeing patients. So there is the payments that go to the doctors, and then there are costs that are paid directly to the hospital to the benefit of the hospital business.
And have you worked out how much you are paying private hospitals?
Yes.
Which is contributing to this 18%.
We do have those figures in our financials. I am not going to be specific, but the hospital part is the highest in terms of the pie charts that we pay in terms of healthcare costs. The hospitals is the highest. It's generally above 30%. It could be closer, anything between 35 and 38%. It is the highest cost of what we pay for.
Well, that is what is in the health market inquiry, that the money actually goes to private hospitals. The big money goes to private hospitals. Now, what are you doing about that problem?
So,
since in 2016 you knew that 30% of these costs are actually going to private hospitals.
Mm-hmm.
What have you been doing about that problem? Because that's what's going to help you to save a lot of money.
I've already mentioned, Chair, if you look at the slides, it is slide 31, I think, the one that we have. That EVO is an example of the interventions of. So what we have done at GEMS is that we established this as, and now we are actually having a second option, which is based on the same principle. The EVO option was registered and started working in 2017. It is basically premised on care coordination that I explained earlier on, and it is the GP, it's the first point of care. For you to see a specialist, you must be referred by a general practitioner, and those then the specialists within our network, and those that we are talking to join the network, would then be use only hospitals that are on the network. And the hospitals on the network we have contracts with. And our experience in the EVO environment is that the costs of hospitalization have actually reduced by about 17% as a result of that care coordination resulting in less admission into hospital. So this is an example of the things we do. The other things that were pre-existing before this.
Have you investigated whether private hospitals do not give bad incentives to doctors to increase rates of hospitalization?
No, we haven't specifically investigated.
I mean,
that.
why not? You see, the market inquiry says, look, you know what, 35% of this money goes to private hospitals. I mean, why would a doctor just put someone in hospital when they stand to benefit nothing?
Chair, the question would be, and I think that is why we started the presentation where we started. We started with what is the business of a medical scheme, and we really try to operate within the lane, to stay within the lane. We are required to ensure that we disperse payments for healthcare services, and we are prudent about it, and we always act in the best interest of so the investigation
Outside
part
your
sounds
scope.
loud. It's will be operating outside our lane.
Thank you.
Chair, so the CMS has been approved. The CMF, the Claims Management Forum, has been approved. We are in constant.
Sorry to interrupt again. You just before you move off that last slide, there's still that dash in next to the FWA initiative. You haven't explained the
Okay,
figures
Chair.
and what
Okay.
what
So-
you're presenting here.
While you answer that, I'm looking at these figures. Are you saying that as a result of the intervention called FWA initiative, you saved 272 million in 2017 and nothing in 2018?
Well, yeah, and we had to look into this very. So what we do is that we, in the Claims Management Forum, there, as we indicated, there is constant reporting. In fact, the Claims Management Forum meets on a monthly basis. It's such an important forum for the scheme. And in our constant reports of what was saved as a result of those interventions, 2016 it starts, 27 it has the highest impact. In 2018 we actually record nothing in terms of that intervention. That's basically what I'm confirming what you asked.
There was no FWA took
the-
place in 2018?
No, the efforts were there, the estimates were there. We have what we estimate is due to fraud, waste, and abuse. We then have what we call a 10-10-10 principle, which is within the CMF. We're saying if this is the estimate of fraud, with the activities, we think by the end of the year we will make this amount of savings in that year, because those savings accrue to the scheme. If we don't, and for lack of a better word, we don't force that they should happen. We follow a process, and sometimes it yields results, and sometimes it didn't. So it is reasonable to say we had the biggest yield in 2017, and then in 2018, we didn't have anything that we recovered, that we saved on. But that initiative is continuing even as we speak within the GEMS environment. Chair, I think my colleague wants to also.
All right.
Through the chair to the panel, I think the two comments I would make is that when you look at these numbers, all of these numbers, we assisted by our actuaries. And I want to say that, I mean, this is not a perfect science, the way that so the way we do it is it's a stepwise calculation. So we first allocate to underwriting, then the remainder in the subsequent ways. That's the first comment on it. The second one is that in terms of the hospital admissions, and that GEMS has made extensive submissions to the health market inquiry, particularly around this issue of supply-induced demand. We're able to demonstrate that with the work we've done through this Claims Management Forum, our hospital admission rate is stabilized and lower than typically the rest of the industry. So we have had a significant impact on both specialists and hospitals in terms of spend. And I think many of our submissions have translated into the recommendations of the health market inquiry. And I think, Chair, your point around the relationships, I think to the extent that the health market inquiry could look into it, they did. I want to talk specifically to the fraud, waste, and abuse. So the way that this, in the way we're presenting, we identify through various mechanisms what we define as people that are outside of the norm, through what Dr. Steen said about the 10-10-10. Then we engage with those providers. So in the first 2 years, on the segment that we identified, so it's not the total number of healthcare providers, we were able to show a difference. But what is as well is that those that we didn't contact, their net result was higher than on the ones we focused on. And I want to emphasize these are not mathematically that they'll all add to it, but what we can clearly demonstrate working with the actuaries, each of these initiatives that we've introduced, many of them have contributed towards the gain we have. but it's not a perfect science, you know. And particularly,
I think we all
when it comes
accept
to-
that these
yeah.
numbers, I mean, it could be 260, but it's written here as 270, that's fine. But what is difficult to understand is why do you have 0 for 2018? Does that mean that you saved no money, you recovered nothing, or what exactly does that mean?
No, so the recoveries then that we measure separately, this is very specifically around behavior change in terms of at the start of a year, we work out on outliers what's their typical utilization. We track that, but the net result on the others that we weren't resulted in a net 0.
Is that is that what you call the FWA initiative? Is that
Yes.
what's involved?
Within the claims management forum, yeah.
Because maybe we don't understand
Yes,
enough
I think- I
what
think
you
you're
mean
using
by
the broad approach.
FWA
Yes,
initiative.
yes.
Yeah.
Can I make a suggestion? Because we also have a fair amount of knowledge in relation to this, as you know, because our expert has engaged with you how your processes work. So perhaps you can say how the Claims Management Forum works to start, to confirm we understand correctly, and then explain how that data fits into that, because I'm still not understanding the basics of that. Like, does the 272 million mean you aimed to save that much in relation to FWA for that year, or you did save that
Through
much?
behavior change of that set of specialists that we understood as outside of the norm.
But
We
again,
need
that-
you to unpack that a
Yeah,
bit
it-
more
that-
for
yeah.
us. So that FWA initiative, what does it involve? How do you identify the outliers? What behaviors do you look at, and how do you influence a change of behavior?
So let's be clear. So it's just to help with the understanding, we understand it's the Claims Management Forum through the actuaries on the Claims Management Forum that look at their, I don't know what, you'll have to tell me, and says, look, there's a problem in this discipline potentially. And then you go to your analytics, you go to the IBM system, I think it is, and look for outliers. So just, there's a difference between actuaries looking at their own data and saying, look, there's a problem here, and then going to your analytics, which is
Okay.
your IBM system, as I
Now
understand
your
it.
point is then clear. So I would think about the Claims Management Forum as more just about a more gentle contact to alert the healthcare professional about the difference. In terms of the specific fraud, waste, and abuse, that follows our policy. So there, based on what you've described now, analytics in that would be dealt with very differently. And that's what we will go on later into the discussion.
Okay, so we'll drop those facts from our head for the moment, and now can you please explain what you're saying with this gentle touch?
So-
Okay.
Okay.
No, thanks. We had indicated that we'll submit a report relating to the CMF, and we will address some of the things that you have raised.
My understanding is that the base number that you start from, is a thumbsuck. You just hope to save X. If it is not a thumbsuck, give us the scientific basis for getting into the base number.
So and is it specifically with regard to fraud, waste, and abuse?
Sorry, this item, this 272.
Oh, okay. So we are all aware of the various estimates in relation to what fraud, waste, and abuse could be costing the healthcare funding industry. These are public documents. So we would have drawn from those to say what would be a reasonable estimate. So figures are quoted that it could be anything between 5%, some go up to 25%, some go up to 20%, but we say, let's be conservative, and we would then base it on somewhere in the middle. We would say we pay about 40 million. If 15% of that is fraudulent, these are estimates, then that 15% of 40 million would translate to 25, I think it's about 25 billion. And then based on that, we had that 10-10 principle that we used to say it is an estimate. So we recognize the fact that we can't say it's fraud until you prove that it is fraud. And we're basing our approach to try and identify this on these estimates. That is really the general approach in how we first determine what is it that is possible, and then we then start tracking what we have actually saved, and that led to that figure.
I'm still not sure if I understand the figure. I mean, it's still an estimate based on industry practice.
Yeah.
The numbers vary. I mean, we've been told it's 15% and it can be as high as 25%.
Yes.
And even that number, when we interrogated it, is apparently an international benchmark based on the United States.
Yeah.
It's not any study that has been conducted in South Africa. But I could understand this if we were looking at this prospectively. In other words, we have no experience of it. But you've got experience from all of these years since you introduced the CMF. What have been your actual numbers attributed to fraud, waste, and abuse? I mean, you've got those numbers now because over the years, you've been exposed to fraud, waste, and abuse. Has it been 1%, 2%, 3%, 20% of specifically GEMS?
Okay, I would have to go and check the exact numbers, Chair. But suffice to say, in our section on fraud, use, and abuse, we do try and demonstrate that process of saying we identify what are the things we do that leads to us I mean, they are going to talk about the recovery, how we do it, and what are the processes that are involved in us actually recovering. And then the exact figures we would have to come back to you to submit to you, Chair.
Thank you.
Chair, I am going to go to the last few slides. Basically, we have spoken a lot about some of the things that actually are addressed. This is really what the intention of the Claims Management Forum is, and this was also a plan. The CMF came up with what it intended to do, but we also had to submit a business plan, which was approved by the CMF, and then, by the CMS. And in essence, by the end of 29, we reached a reserve ratio of 31.3. That was about 3 years ahead of what the approved business plan was. Chair, this is just another way of actually just demonstrating the same point and saying the scheme, as a result of the Claims Management Forum, managed a financial turnaround that we're talking. While all of that was being done, Chair, I think it is important to say we continued to pay claims that we regard as being valid claims. And just to demonstrate the extent to which GEMS pays claims. In the 2018, this is for the 2018 financial year, more than 43 members of GEMS had claims being paid on their behalf in excess of 3 million. The claims that were in excess of 1 million was paid on behalf of 1,300 members. And then the claims that were paid on behalf of, that were in excess of 500,000 were on behalf of 6,400 members. And then for those members, for claims that are in excess of 100,000, we paid on behalf of 63,000 members. These are massive numbers, but we do continue to honor the claims of our members in terms of the business of a medical scheme. So just to conclude this section of my presentation, Chair, there is a lot of, and we did discuss a lot around the fraud, waste, and abuse. And the estimate that we spoke about, this was also published where it was said that medical aid fraud accounts for about 22 this was one of the adverts by government. At GEMS, we're saying fraud is a criminal offense. Obviously, we know that it's got to be proven. It robs members of funds to access healthcare services when they need them most, and we all know that's when members are very vulnerable. We follow a legal route in everything what we do, and we're going to talk to that in the subsequent part of our submission. It is important to just submit that we don't incentivize recovery, so we don't pay when there is a recovery. We don't pay when you recover 100, we don't pay somebody for that. There are set fees that we pay for those services that we are, irrespective of what the recovery is, and this is very important. We don't use hidden cameras. This is part of the public discourse, and we thought we should submit that we don't use hidden cameras. Chair, the next two bullets. The one that we sincerely believe we are in compliance with Section 59 will also be dealt with in the subsequent part of our submissions. And in our approach to fraud, waste, and abuse, we pursue sanctions that we believe are in terms of what we are allowed to do. And now our emphasis is really, it's not punitive. We try as best as possible to rehabilitate those health care providers to the extent that we are able to do it within the ambit of the Medical Schemes Act. At this stage, Chair, I am going to hand over to Dr. Soli Mutuba to do part of the next, part of.
Can you just, I can't remember what your answer was. Is it that the issue of the blacklist will be dealt with by your experts?
It is dealt with under the legal section of our presentation.
Thank you. Thank you. Is it the next presenter now?
Ishmael, Mr. Ishmael Mahapi, Chair.
Mr. Mohapi, that's now you. All right. Are you just continuing from the next page? Yes, of course you are. At 37.
Thank you, Chair. I think from my section, I will also be assisted by Ms. Lynn Gita and Dr. Solimutuba. And for the simple reasons that you've heard that GEMS actually have service providers that administer the scheme. And our fraud risk management is outsourced to Metropolitan Health. And Dr. Solimutuba is from Metropolitan Health and Lynn Gita. All right. My principal have indicated that obviously the scheme has several policies, and one of the policies that governs fraud risk management is the fraud policy, which has been approved by the board, and it's mainly for the simple reasons that as much as we want to deliver the best possible health care to our members, there is a need to mitigate the risk of fraud, waste, and abuse. And I think it is an accepted concept that there is fraud, waste, and abuse in the industry. And from a GEMS view, we have noted through our investigations that it is not all healthcare providers who are responsible for fraud, waste, and abuse. But we will demonstrate also via examples that there are specific individuals and also groups of individuals that commit.
Mr. Mkhabe, can I interrupt? You said it's accepted in the industry that there's a problem with fraud, waste, and abuse. I think we've heard evidence that I think everyone accepts there's a problem with fraud, it being a crime. And you certainly don't have to persuade us of that. But I think there's some contestation around waste and abuse. I think conceptually everyone agrees one shouldn't waste or one shouldn't abuse. But the nature of what the schemes and administrators are saying constitute waste and abuse, and the nature of what the providers saying constitute waste and abuse are different. Would you say that's a fair comment?
I would say it's a fair comment, and also with the engagement that we have had with some of the associations that you have mentioned previously, that when we do meet and agree in terms of the irregularities that are noted on a specific provider's claims profile, one can argue, is this waste, is this abuse? And one look at whether the clinical nature of the claims, yeah.
And is your team prepared to engage us today on some of those subtleties?
We are, Chair. All right. I think my colleagues also would like to add in a comment around that issue.
Sure.
If I can give you an example just on what we regard as abuse. So fraud is pretty clearly defined, but as abuse would, for example, be where a provider, if I take an anaesthetist for example, is claiming a nerve block with every procedure. So in addition to the anesthetic and the consultation, he's also providing and claiming for a nerve block. It's not necessary, clinically necessary, but it's in case, and the scheme's going to pay. So that we would consider abuse.
And perhaps, I mean, unless you want to return to it at some other point, accept that that's absolutely where the space of contestation is, and the anaesthetist might say, and I don't know if they would in this situation, that it's not for the scheme or the administrator to determine the nature of the healthcare or the service provider.
Yes.
So how do you respond to that?
So our response is that we agree. Clinically, it's not our position to dictate to the healthcare provider what is clinically necessary or not. But what we do from our perspective, if we look, we compare the anaesthetist to his peers, and if there are outliers, we say, look, we understand it's your call, but you're so far from what the norm is in your peer group, and we need an explanation. There may well be a valid explanation. But yeah.
Thank you, Chair. If I may proceed. The next slide basically indicates the principle in which our fraud policy is founded on. It's mainly just to create a culture of ethics, intolerance towards fraud, waste, and abuse.
Sorry, just to go back to your colleague, the discussion that they were having. You see, you submitted, I think this came from James, a policy dated 2015. So I don't know if you've got your own bundle at page 521. The definition of fraud is at 523 to 524. It's quite an extensive definition. I think it's there. It's there. Yeah. And I didn't see the definition of waste, but there is a definition of abuse. But what I wanted to just bring to your attention at 524 is medical aid abuse is defined as providing services or products that are not medically necessary or that do not meet professional standards. Now, if we stick to the first one, medically unnecessary, that requires a clinical assessment. Now, the problem that we've had with the doctors that have come here is that you allow people that are not clinically trained to make those initial assessments. So it seems that the assessment of whether or not something is abuse is whether it is medically necessary. You would accept that the assessment of medical necessity is something that must be done by someone who is a clinician.
Yes.
So where do these investigators come in assessing abuse who have no medical training?
Okay. So we do consult with experts. So the investigator that may be asking the provider for information may not be an expert, but we do engage with subject matter experts around that. And obviously the question is, so in some cases we may specify and ask about a particular case, but sometimes there are too many cases and we want an explanation on more general terms as to why he's so far out from the norm, and not on a case-by-case basis.
At what point is the medical expert consulted? Because one of the explanations given to us, I mean, GEMS might have its own unique practice, is that because there are so many of these cases, it's not practical to have a subject matter expert sitting in each investigation. Mm-hmm. And these are typically done, if it's done by Metropolitan, they're not done, but it's not as if Metropolitan appoints doctors for this. Sometimes even when they're done by MedScheme, they don't appoint doctors for this. Now the doctors that have come here complain a lot about this, that they have to account I don't want to be derogatory towards policemen, but they have to account to policemen.
Okay, I just need to state, Chair, that it is not the case in terms of GEMS. So we have indicated. I will introduce, I think in my next slide, we'll talk about the composition of our team. Also that we have medical advisors in our team and who are readily available. And even when we do provider engagement, it's medical advisors who goes out and engage with their peers. And we also involve and regularly consult with the provider association and discipline association around those issues. So when in each specific case, especially around the complexity, if there are those clinical issues, we make sure that a medical advisor assists in those investigations.
So you're saying that in each investigation, there is a doctor that goes with the investigators?
Chair, no, I said the doctor is available, and when we do send out letters of anomalies, that is shared with the medical advisor. Even the medical advisor, when he looks at the provider's claims profile, he will also indicate to say, these are the issues that I have, and he will engage with a specific provider. And if maybe the issues that we have raised, especially of an anesthetist earlier, we can engage the society, and the society will advise us that is not clinically appropriate or not. But
No, you see, I mean, I don't want a general answer. You see, if I'm Dr. X and there are investigators in my practice, is there a doctor there or not? People that are asking me questions. Because that is the practical objection that we are facing from the doctors.
Okay, we do desktop investigation. Maybe I think on my next slides, what Metropolitan does is that they do desktop investigation. They're not physically at the provider's premises. Engagement with the provider is via electronic means. And when we do field investigation, and when we send out field investigators in that respect, they also will have a medical doctor on standby if a case there is clinical issues that will come in. Just to answer the question, that's not in all cases where we do field investigation that a doctor will be together with the field investigators. That is not the case.
Yes, but isn't that where the objection is that the people who are asking them questions about why a certain clinical decision was taken have no expertise to understand the exchange. The fact that there's someone else who is available on the phone or may not be available does not seem to be a proper answer to these doctors. Your own definition obliges you to make a medical assessment, which they say is made by non-clinicians.
We do. I just want to state, as my principal has indicated, I'm under oath. We do make sure that wherever there's clinical issues that are contested, there is a medical advisor's opinion. And I think in the bundle, we have shown example of where a medical advisor would have given information in that respect. Yeah. That is contained in the bundle.
So are you saying you have a specialist in every discipline available to you to engage on every investigation?
We have specialists in that respect, and also we have access. Where we do not have a specialist, we will engage the society. That is the expectation.
And how will you engage the society? I mean, some of the correspondence that we've seen from the societies are equivocal.
Okay. All right. Obviously, the engagement with the society, we will present the issues, maybe the anomalies, and we will also present what the provider would have, the response that he would have given, and we'll ask them for guidance in terms of resolving an issue. Remember, those are clinical issues which will determine whether there is effect of waste and abuse. And based on those two findings, and based on the response that we receive from the society and the provider, that issue goes into a sub-forum, which I will later explain, where we debate that issue to say what appropriate action should be taken in that specific matter. So the investigation does not even end at an investigative point of view who will make a decision in terms of an action that needs to be taken. We have processes to say we have collected all the information, we've heard what the provider said, we heard what the society has said, and we heard we do engage. And in that meeting, we have clinical people to say what action needs to be taken.
No, you see, I mean, I know you said, look, you know, we always have doctors. When I ask you, are the doctors at the investigation, you say, oh, well, they're a telephone call away. The problem is someone needs to decide. There is a claim, someone suspects that this claim is not correct, it's fraudulent or whatever. They must then decide extra information to corroborate the validity of the claim. That's the practical scenario we've been faced with here. That call, the doctors are saying, is not made by a clinician. They say to this guy, but this information is unnecessary to establish whether or not the consultation was 2 hours or 3 hours. And then the quote-unquote policeman, with respect to them, insists on me providing the information, and I don't want to provide it. I think that's the kind of practical example that I have. I don't want someone sitting in the office who may or may not be available. In real time, there is a cop knocking on the doctor's door, demanding information which the doctor says is unnecessary from a clinical point of view.
Chair, could I just assist my colleague here? The issue is, I think the question is, are doctors always available in this environment? So you did say you don't want a general answer, but when we look at the operations of a medical scheme, we have access to doctors in various areas of the work that we do, and they are used to different, and I'm going to be specific to answer. So, for instance, when we take decisions about funding, we have medical advisors who would help the administrators to ensure that what we pay is clinically appropriate, which is one of the words that we used. It's also in the Act. So there are protocols which guide what is clinically appropriate, what is not clinical. And these protocols are applied at the claims level. In this case, we are talking about a decision that would inform the Fraud, Waste and Abuse Forum or sub-forum. We have sub-forums within the scheme, whether these claims are inappropriate because the doctor is not claiming for the right thing. So, for instance, they would come across an outlier, which is a doctor who is prescribing one expensive medication more than the other doctors, right? That would trigger the analytics to say, probably there's something wrong here. They would then consult within the fraud, waste, and a medical advisor who would either confirm or say, would either confirm that, yeah, this looks fraudulent because this is abnormal in terms of medical practice and all of this. So they have access to doctors to assist them in deciding whether something is possibly fraudulent or not, in the processes of deciding whether the outliers should be engaged further to try and establish fraud and waste and abuse.
Thank you. You may proceed.
I would just like to highlight, obviously, that these are the principles of the fraud policy, and this is in terms of the new fraud policy that is also included in the bundle, and it does define waste and abuse. I just want to locate it. We're also responsible for making sure that we detect fraud, waste, and abuse, and that we do investigate it and we take appropriate section. So that is the principle that underpin our fraud, waste, and abuse policy.
But where does it define abuse? Because the policy doesn't define, it doesn't define waste. It defines abuse and fraud.
Yes.
So
no.
Where is waste defined?
I just want to locate it in the bundle. It was submitted. The policy that we included, that we mentioned, that was in 2015,
yeah.
And we have recently have a new policy that was signed by the board, and which amended that old policy.
All right.
Yeah.
Can I just, I want to close off this last issue. So you've indicated that as far as possible, you will access a medical advisor to advise you on, let's say, contested issues, such as the over-servicing that was described by your colleague. I mean, another contested space is the coding, where you might have to have resort to the associations or other practitioners, your own advisors. Can you just explain to us how you deal with those coding disputes? And if I assume if you've been watching the proceedings, you understand what we know about coding, so you don't need to explain that to us.
Thank you. Yes.
So the question is how we deal with the coding disputes. There's a section of our submission also that's going to talk about coding.
I'll happily wait until that. Then my last question on this is, I understand your evidence in relation to resolving these disputes. Well, it's not clear to me I understand your evidence. Whose view prevails, your medical advisors or the doctors involved? How do you resolve an impasse when there's proper contestation around, was this or wasn't this over-servicing? Was this or wasn't this the right code? How do you resolve the impasse?
All right, thank you. As I've indicated, that we will look at both parties. Remember, we have at least the benefit of consulting the societies and also the health HPCSA in cases where we don't get into an agreement in terms of whether that practice is waste and abuse. And also, it relates to what is our expectation going forward with that service provider. If the provider is constantly charging a specific code, which we deem that this code, it might amount to waste and abuse, obviously, and the provider is adamant that I'm in the right, and the society also will have to be engaged for guidance. We will normally even take the matter to HPCSA so that they can advise us going forward.
And in that circumstance, I get that the coding is very complicated. Is the problem that let's just say the doctor is charging for a service that she did not provide, or that the doctor is charging for a service that was provided but should not have been provided, was unnecessary?
So that's where we talk about the clinical inappropriateness or what is unnecessary service. It was provided, but it was not necessary. Is my understanding correct?
How do you deal with the two different situations, is what I'm asking.
So if it's simple, if service have not been rendered, obviously the provider will have to reverse those actions. And that will be dealt with in terms of our fraud, waste, and abuse processes, because we didn't render service which we are claiming for. So that will take. But where in a case where it was not clinically appropriate, yeah.
Stop there for a moment, because isn't that itself also complicated? Because the codes, for example, time-based codes, if there's a dispute over that, the doctor will say, well, I did consult for that period of time. And the dispute is whether the doctor, in fact, did consult for that period of time. How does that get resolved?
Thank you, Chair. I think that was an excellent example. We deal with a lot of time-based analysis, and we do find in instances that the codes which have been claimed amount to hours which are not available in a day, which is like 35 hours in a day. And we speak to a provider to say, yes, members have confirmed consultation, but how is it possible that you would have consulted with people for 35 hours? So the length of that consultation becomes the question, so that we need to get to a point to say, how do we correct that? Because definitely we don't have 35 hours in a day, and we have those specific examples. So in that respect, there is that engagement where we will even give the provider to say, here's the list of the claims that you have submitted, and you've indicated you've sent these people for this number of hours, but it's humanly impossible. Did you have an assistance or not? And normally in those instances, a one-man practice. There were no locums. You just saw them all at once, and one has to make a decision around that.
You just confirm that the standard operating procedure, which is at page 600, at 602, contains the definition of abuse, fraud, and waste. Is that the... So that seems to have been updated since 2016, and the last update was in May 2018.
Yeah, that is an SOP, but I just wanted to direct the panel to the correct fraud, waste, and abuse policy that has been signed by the board,
Yes,
and which basically defined that. Yeah.
No, I appreciate that. The one thing that I do want to understand is the definition of fraud in the SOP is not the same as the definition of fraud in the policy. So I don't know which one actually applies. And in fact, the same as the definition of abuse. So what is the status of the SOP versus the policy, and which one do you actually implement?
So the policy will prevail.
All right.
The policy will prevail. So for the purpose, I think we will submit the signed policy. All right, if I may proceed.
Yes,
Chair?
thank you.
Okay, thank you. All right, That is basically our investigative team, who we have contracted. And as I've already indicated, that it does consist of a multi-skilled team, which includes medical doctors, nurses, psychologists, legal people, investigators, some of which have 10 years medical experience. And that is the organogram in terms of that. If I'm allowed to go to the next slide. The next slide, I think, is also quite important. I've already indicated that obviously the scheme's investigation of fraud risk management is based on 3 principles. Is that we do prevent, we do detect, and we also respond. From a preventive point of view, I mean, we're looking at clinical risk management, authorization protocols, provider engagement, member advocacy. From a detection, we have 2 ways. We do prepayment detection, post-payment, and then from a response point of view, we engage and then we investigate cases. We've got a case management system where we record all the cases. They've got a specific log number, and we do take action in terms of whether we recover, sanction, and we report. And if there is controls breaks, we will also need to go back to the system. Right. The next slide, basically.
Before you move on, I think your colleagues has alluded to the fact that you would present on this, but on slide 41, would you mind just confirming how the investigations, well, the providers are identified for investigation, who performs that role, and further then how that the provider is then, let's say the investigation is followed up. Just practically, how does it work between you and Metropolitan? I understand that there's some complexity in that space that we need to understand.
Okay, thank you, Chair. So we have contracted, there's different sources of our investigations. So one is we got an independent hotline service provider who's not contracted to Metropolitan but only to the scheme. And on a daily basis, members do engage those hotline and make unanimous tips, and those reports comes into the scheme and also to the administrator, and they get assessed. So that is one form of investigation.
What percentage of your investigations come from tip-offs or whistleblowers?
Yeah, I think there's a slide which will just indicate, but I would say mainly, but more than about 50%, and
50%.
yeah, around there. And then our analyst also will just be able to give you that demonstration at the later sales, about 50%. And the other source of our investigations, obviously, is based on industry tip-offs, behavioral analytics, which is done in terms of system analysis, in this instance is firms. And then also we have various reports, which I will also demonstrate in the next slide, if I may be allowed to go to. This is sources of investigation, and then I can go into what goes and who makes decision in terms of who gets investigated.
Yes, please.
Right.
Proceed.
Yeah.
I mean, I saw in your submission there's actually a couple of these sort of whistleblowing companies. What I couldn't work out is if you've outsourced the function of FWA to Metropolitan, what's then the role of these entities that seem to receive complaints from whistleblowers?
It's only one company that we have actually outsourced to do our hotline complaints. And
okay, I'll see. I thought there was a list.
No.
It's only one, all right.
Yeah.
So what's happening is that the hotline, as it were, is one company, and the rest of FWA is Metropolitan.
Yes. So,
so what happens to the information gathered by the hotline? Do they give it to Metropolitan?
They give it to the Metropolitan. It also sends us to the scheme. We have yeah. And maybe the list that you are talking about is a list of our service provider network. So those are other service providers. So they are also sources. When they do claims adjudication, let's say we have an administrator who's responsible for ambulances, And when they see irregularity in terms of claims that are received before they can adjudicate, they will also share that with the Metropolitan, who will then do a desktop investigation. Remember, Metropolitan, they oversee the whole fraud risk management, making sure that they manage to see what cases get reported so that they can be allocated a case number to make sure that we have one central point where we can coordinate the activities of fraud risk management.
Now, can you just explain this relationship with Metropolitan? Firstly, how much do you pay them per month, and how do you structure the financial aspects of the transaction?
Okay.
Chair, we can submit those figures. We have a confidentiality agreement with, in terms of what we pay for, but we can submit that to the panel in terms of the exact amount we pay. That's about payment. I think the other thing you are asking is how do we structure the relationship?
What is the structure of that payment? What do they get paid for?
So there is a requirement by the regulator that whatever you pay the administrator, you should stipulate for what services. So there is the amount for the contract, and then there are the stipulated services, the categories of services that breaks down, but in very broad terms. This is for this service, this is, and that is a requirement by so they invoice on that basis.
And on the FWA, what is the structure of the payment, specifically on FWA? Do they get paid a set fee? You don't have to give me the figures. A set fee per month, or do they get a percentage of recoveries? What exactly is the structure?
Certainly not the latter, Chair. They get paid a set fee. We don't incentivize recoveries.
And when you do recover, when you do make recoveries under FWA, where does the money go?
Goes into the general pot of the scheme funds.
And does GEMS have medical savings accounts?
Yes, and we have to specify that, and that's a very important part. We do have one option where there is a savings account.
So in cases where
Chair, that is a very technical area, and I don't think we specifically dealt with it. And if the panel really wants us to look into this, we can come back on that. And I think it's an important one. Suffice to say, as I indicated, that the recoveries in general go back into the scheme funds pool.
if you could provide us with documentation that shows us how that money is received and where it goes, please.
Okay.
Yes, just another aspect on the relationship. I mean, I still want some financial details, but you say that that's all confidential. We will see once we receive them, and then maybe it will be clear. But how do you monitor this relationship with the Metropolitan?
Thank you, Chair. By way of a service level agreement, it is included in our agreement, and it's one of the documentation that we will provide. And I think we have in our initial submission to the panel, we have attached that page of in terms of this, what are the services that they're supposed to do in terms of doing fraud risk management for the scheme.
Asking about monitoring.
Yes.
I don't want to, the services are clear.
Yeah. So from a monitoring point of view, if I may be allowed to continue, is that we receive weekly reports, we receive monthly reports, we receive quarterly reports, and we engage with the administrator on a monthly basis. So that there are different forums that we have in terms of our fraud policy. We have what we call a claim risk forum. And in that forum, we get reports in terms of how many cases have we received, how many cases have been closed, how many cases have been investigated. And also, the scheme also plays a very significant role in terms of the sanctioning, and in most cases also in terms of the decision of investigation. So there is constant, we are actively playing a role, because the administrator in certain decisions that they are unable to take, they will request schemes to intervene or request approval. So monitoring happens consistently, so weekly, and there is official reports which comes to the scheme.
And who at GEMS is responsible to monitor Metropolitan?
Okay, my executive, a chief compliance officer. I'm a senior manager that I respond, but the role is basically my responsibility to make sure that the administrator is basically performing in terms of the service level agreement.
And do all of these reports come to you only, or do they get shared within a team at GEMS?
They get, there is a weekly principal officer's report, and also to myself, and the executive is copied in also on those reports that we get, and the monthly reports also are shared to me, and also which are discussed, and there are also quarterly reports which are shared, where in that claim risk forum we have a scheme executive that attends, and we have representative from other service provider network, and also independent legal people that comes and sits to assist with terms of.
And how many times a month do you actually have a meeting, a direct meeting with Metropolitan?
So on a monthly basis, we set out, at the beginning of the year, we set out a calendar. We sent out invitation because of the complexity of the industry. We have bi-weekly meeting, which is part of the claims management forum, and where the administrators sit, because there's a work stream which I'm responsible for when we're talking about the fraud waste initiative, where we operate it. So we meet on a bi-weekly basis, and there's also monthly meetings, and we have what we call a claim risk sub-forum, where we sit and debate investigation, where we need to make decision in terms of sanctions that needs to be implemented.
And in these meetings that take place twice a week, what is discussed?
So, so in those meetings, we would have a plan of action. And in that respect is that we have not only the administrator there, but I have other role players, your ambulance service provider, your dental management service provider, your optical management, because we look at the number of risk. So it's not only, and there we discuss outliers, changing behavior, emerging risk, controls that we can implement, and we feed back to the broader claims management forum on a monthly basis in terms of activities.
So the Metropolitan will come there and say that we've got an outlier in KZN. And what are you expected to do as GEMS?
Yeah, so, okay, so they would have identified an outlier and probably said there's an emerging risk. This is what the provider has done. They would have done an investigation, and then they would have made the recommendation of an action that needs to be taken. Those cases will take to the claims sub-forum, where we do make decision in terms of the fraud policy to say, are we going to sanction that provider, or what controls are we going to implement to
Can
mitigate
I
risk?
interrupt you there? Because you're giving evidence that contradicts what was said to our experts. So I do need to warn you about that. If you'd like to just give that some thought, because now we've got two different versions from you on record.
I would like to clarify that because what...
Are you saying Metropolitan is driving the investigation process? They identify the outliers and come to you. That's what you've just said.
Yes.
Okay.
Now, so they've done the identification, they've done the investigation, and they've come to report. What are you expected to do as the scheme?
Okay. In terms of the fraud policy, obviously we've got a sanction document. They would have made a recommendation. And in that, we sit, and there's a meeting that I chair, where, if I can mention the representation or the composition of that forum, the scheme is represented. We have our legal panel members who also, and we have clinical people in that meeting, and we have operational people, both from the GEMS side and also from the administrative side. And they are there for purpose of looking at the controls if there's been a control breakup. And we make decision to say, these are the recommendations. The service, Metropolitan would say the provider has submitted claims for services not rendered, and we recommend that we terminate direct payment, we reverse irregular claims, and we report that this behavior to the regulatory bodies. And I think that is some of the examples that we have indicated in the policy.
At this point, you know the service provider, who the service provider is.
At this point, yes, they would have presented this fact in terms of a PAC and a case report which outline. If the panel would like to see, it has not been shared, but we are willing to share an example of what the case report looks like.
Now, so we now know that they've done an investigation and they've presented you with a recommendation. And what you are deciding is whether to sanction their recommendation or whether to put a service provider on direct payment. How many people work at Metropolitan who are responsible for drawing up all of this investigative data versus the people at GEMS who are reviewing the data?
Chair, if you allow me just to direct you to slide number 41. It indicates the composition of the Metropolitan Health Investigative Unit. We have the acting head there, which is Dr. Eugene Becker. We have investigation sites. We've got 6 managers there and senior technical specialists. We've got 17 investigators. We've got client and forensic provider engagements, who's the senior manager, and then we've got an analytical team and data intelligence. We've got a senior manager and we've got analysts. So those are the figures that we have.
On your side, I mean, you have only, how many people sit in that meeting that looks at what they have done? So it will be you and who else from GEMS?
Okay, from GEMS, the Claim Risk Forum is chaired by our executive. Myself, I'm there to support, and we have operational people who are from our operational team, that's from GEMS, and we have also a senior manager who's coming from a network management perspective, who's dealing also with provider engagement. And obviously I've got support of my team that I've got a manager and a coordinator. That is the representation basically from a scheme perspective. And then we would have the legal panel members. And then we would have a clinical person, obviously, from one of our contracted service provider. And there are about 2, and then also there will be an administration person, maybe from a claims engagement, from a claims division, also coming from an administrator.
Now, at that stage where Metropolitan identifies an outlier, what is the role of GEMS?
The role of GEMS is to look and make a decision in terms of the recommended sanction.
No, I accept that.
Yeah.
That comes later.
Yeah.
But I'm just talking in real time. At the time of the identification of the outlier, is there any role for GEMS?
Okay, at the time of the identification of outlier, no, there's no role, because the identification maybe
no
is, there's an analytics that would happen at the administrative side.
Yes.
Yeah.
And at that stage of the investigation about whether there is a validity in the claims about an outlier, is there any role for GEMS?
It will depend on case-to-case basis. Sometimes the provider would say, I would like to meet with the scheme. And in that respect, then...
And let us assume they have not decided to meet with the scheme.
Yeah, so if the provider does not, we don't, there's no role.
Again, there is no role at all.
Yeah.
And at the time of the recommendations about the appropriate course of action, any role for
No,
GEMS?
there's no role for GEMS.
So you really come at the tail end of the process?
After the case has been finalized and there's recommendations, so that before we can implement the next step of sanction. That's correct.
Thank you. That's been very helpful.
Okay. All right. If I may, I think, Chair, I don't know if I've answered the panelist members' question.
Well, she was going to,
Yeah.
she was going to put to you the contrary version that
Yes.
was given by GEMS to our investigator, which contradicts what you have
Yeah.
been saying to me, so that you have a fair chance to,
All right. No,
to comment. But you
Yeah.
can continue with your
You can
presentation.
continue, yeah.
It will be done in due course.
Okay. All right. I think I've indicated this is one of the sources of our investigation. These are one of the analytical tools that we're using. I have deliberated on that. And I think the assessment criteria, which was one of the key issues that was mentioned, to say what do we look into before we even make a decision of assessment. And this is also done at the administrative side. My colleague Lino can elaborate on that. This slide is basically an indication on the number of allegations that we have received as the scheme.
Yeah, I mean, I was interested in this slide because of the numbers. Gauteng is at 3,000 and KZN is 2,900. That's like roughly the same. Especially because In your CMF report of 2016, according to this PowerPoint presentation, you identified KZN as an area of specific risk. Did GEMS decide that there would be a focus on KZN for purposes of FWA?
Yes. Yes, I would confirm that it was one of the areas in terms of focus for scheme in terms of FWA.
And what was that based on? Was that based on your earlier slide about in-hospital admissions?
That's one of the reasons. That's
But that
correct.
doesn't count as FWA in the way you report it.
No, remember, one of the reasons that if you have hospitalization, there might be providers who are actually driving the cost and putting members in there. We have actually cases and examples of which indicates hospitals that we had to take drastic action against in KZN. And it was as a result of fraud. And we have criminal cases that we open and against hospitals and their directors.
Yes. Now, this decision that KZN is going to be an area of focus for FWA, when was it taken?
So if I just take the Claims Management Forum, and you were shown by Dr. Mawabi that KZN was an outlier. But I just want to clarify that when we look at the practitioners, we look at it on a national basis and look at them as outside of the norm. When we did do that, you then do find that a significant number of those that are outlier providers are
The
from
question
KZN.
really is a specific one.
Yeah.
He has just confirmed that KZN was identified as an area of focus. When was that decision taken?
It was part of the Claims Management Forum based on the information that we...
2016.
Yeah.
Now, we don't have that decision in our bundle. Can you, will it be part of that CMF report? Now, was that sent to the management of GEMS to endorse, or was it just a CMF decision?
The CMF is run under the auspices of the scheme.
No, I accept that,
Yeah.
but I just want to understand if at the level of the executive, GEMS specifically endorsed that decision.
Yes.
Now, was that decision also communicated to Metropolitan?
They were part of the process.
I see. Thank you.
Skip this slide because there's going to be a demo on this one. The next slide talks to the sanctioning of providers. In terms of the land sanction document, in line with the GEMS sanction document, the following sanction may be imposed on providers where evidence of fraud, waste, and activity has been found and include, but are not limited to, reversal of irregular claims, issue of final warning, termination of direct payment, monitoring claim submission, longer claim payment cycle, just to allow to more adjudication, placing provider under review or removal from the network by the network management, terminating of the network agreement where applicable, and also reporting service provider to the relevant regulatory bodies. And we can also do recoveries via civil litigation.
Mr. Mohapi, there is a request among the panel members to take a short break. It's 12 o'clock. We've been going on for 2 hours. so maybe if we can break for 10 minutes, I'm sure you would also appreciate a break, I have no doubt.
Thank you.
All right, thank you. All right, it's for today.
Thank you, Chair. I've previously indicated that we have what we call a sub-forum, where recommendations have now been made in terms of a case report, and decision has to be taken in terms of the sanction document. You'll see in the sanction document we have clarified certain conduct in terms of fraud, waste, and abuse. And normally the recommendation on the case report will have indicated to say the transaction meets category 1 or category 2 or category 3. And all these categories, they have different types of sanctions, which I have indicated there. We can either terminate direct payment, we can reverse the irregular claims, and we can even report the matter to the relevant professional body. And we can also do recoveries, and we can also recommend proceeding with a criminal case. And that leg also, when we do make those recommendations, the scheme will make that recommendation. We have a panel of forensic investigation services provider who are, by instruction of the scheme, will be requested to conduct further investigation on a matter to test if there was any instance of criminality for purpose of reporting that matter to the South African Police Services. So also, once they have also completed their report, they will share it with the scheme with recommendation, and it will also follow the same process of the sub-forum. I need to indicate that the proceedings of the sub-forums are minuted, and all decisions are recorded. And also from a sub-forum perspective, if there are further action items, if a report comes and we do request that we feel that the provider might not have been afforded enough of time, or we feel that the provider must be first engaged, we will send the report back with those recommendations, and then we track even the implementation of sanctions through an action or deliverable item on the sub-forum. So the sub-forum meeting is fully minuted. And these are mainly sanctions that might apply to a member, also where we might terminate the membership, report to a member to the employer, we can recover losses, we can even
Do you have a
proceed.
clearer copy of page 551 to 553?
Yes,
That's where all of the sanctions are set out.
yes, we do. We do have one. We can make it available to.
Yeah, if you don't mind.
Yes, we'll do that. All right.
Just to pause you there on slide 49, you say a sanction which may be imposed on a provider is reversal of all irregular claims. Can you explain what you mean by that?
We do find in most instances where we have found instances that some of those claims were submitted fraudulently. And I would say we might reverse all those claims. And I'll give you a specific example. We have a service provider who says, somebody is using my practice, all these claims, please, I do not know them. And we will reverse those all those claims. There's also instances where the service providers who say, look, there might have been a mistake in terms of my switching bureau. Please reverse those claims. We will do that. So it depends on each and every case where we will reverse all those claims. But that process also we involve the provider. But so it will depend on the merits of the case. So
If you look at page 551, which is the actual sanctions policy, here it doesn't talk about fraud, which would entitle you to reverse all irregular claims. What it says is unacceptable human error, second repetition of an alleged administration mistake, and then the sanction is a reversal of all irregular claims. So and none of those 1 to 6 speak to fraud. It looks like even a human error can result in the reversal of all irregular claims.
The example that I've actually indicated, this will be in an instance, so if, when you reverse the claims where a service provider has indicated that they've actually submitted claims on an incorrect membership number, please reverse all those claims relating to the specific member, then you will do that.
Oh, but I mean, you see, if you look at all of the items 1 to 6, because that just shows the extent of the discretion. Unacceptable human error, irregular profile versus the norm, duplicate claim submission, deviation from coding. So for coding, you just reverse everything. Now this is where a doctor has rendered the service, but has entered the wrong code and is entitled to payment. And what you do as a sanction, you just reverse all payments.
Okay. So if you look at the keyword, then we say reverse all irregular claims. So if the service provider says I've used an incorrect code, you will have to reverse that claim from a claim processing system and allow the service provider to resubmit the claims in terms of the correct claim. So that is the process, because remember, this is once a service provider submits a claim, it basically creates a medical record on a member. So you need to correct that process by reversing and allowing the service provider to submit it in correct claim. So it will depend in each and every case.
I understand, but when you were asked by my colleague, when would you be entitled to reverse all claims, the first example you gave was fraud. None of those 6 items speak to fraud.
Yes, I mean, it was an example that I gave, I admit, but we can also include in these instances. I mentioned fraud as one, but even under waste and abuse, we can reverse claims.
The one thing I'm not sure I understand here is this is put as a sanction, and my own employment law understanding is that that comes after some kind of a disciplinary process. But there is no process that is followed here. It's just an engagement between the scheme and the practitioner, and thereafter the scheme reserves for itself the right to impose a sanction. There's no independent adjudicative process. Even in instances where there is a dispute about whether this was a correct code or not, the power is all concentrated in the hands of the scheme.
Maybe one is interpreting sanction in the literal meaning, but what I would say is that in our instance, the process, the administrative process, is the investigation that would have ensued in that particular matter, and where a provider also would have been afforded an opportunity. So we call it a sanction document, but basically it's a remedial document to say what remedies are we going to implement in terms of a particular conduct. Maybe the word sanction might sound too severe, or one could say, can we use it as what remedies is available? But in our instance, is that before you do any action in terms of this policy, there is an action that precedes this.
So you see the one of the examples, deviation from coding scheme rate. So we've heard a lot from the complainants about the different codes that apply, and service providers work with different schemes or submit claims to different schemes. So if they were to submit a claim using coding that is not coding that you use, that would be irregular. How would you deal with that? What codes do you use? I mean, we've heard about all the different types of codes there are, and then schemes themselves have their own codes, which just contributes to the confusion, and it makes the whole system vulnerable to incorrect claims, which is not necessarily FWA, but it results from this confusion in the coding system. But the sanction, if you were to have made an error in your coding, is a severe one. Is that right? You're looking at Dr. Malua.
I just want to, this first part, But I'll also ask my, so there's coding, there's tariffs, and I think that distinction is very important. We indicated earlier on that there's validation of claims, and we say, we tick the boxes. Is it in line with the rules? Have they charged according to our tariff? And is the coding appropriate for that service? It's all those things we check, and then there is payment. However, should through this process it be found that a code is not appropriate for a service, whichever way we found that out, then that could lead to a reversal, and that's part of that 4.3% of claims that either are not paid within 30 days or sometimes even subsequently reversed. And then there's a whole process of fraud, and it's not always fraud, wasted abuse. It is the whole entire thing of validation of claims. And then the sanction would be those that should it be identified as part of the fraud, waste, and abuse part of the 4.3. Yes. So it's not all the 4.3 that are reversed that are fraud, waste, and abuse. However, those that follow that process that has been describing would be subject to the sanctions ultimately.
So my question is about I hear you about the difference between coding and tariffs, but would you agree that there is confusion in the industry about how claims should be submitted and what codes should be used at times? Would you agree that there is confusion?
I do agree that there's a lot of education that is needed, and confusion is a fair description of some of the problems that we are having in
Who should be educated?
the entire industry, but in this instance, it would appear that, and I'm going to I'm going to say this, which I didn't say earlier, that having been a doctor who was in private practice myself, I'm fully aware of the issues that relate to sometimes how colleagues may not be aware of issues around coding, tariffs, submission of claims that is appropriate, that is in line with the Act, so that you are paid appropriate. And all those things are part of the problem that leads to what we are dealing with. So there is confusion.
Shouldn't there be a uniform code and tariff system?
Until 2010, I think it's 2010, we used to use what is called the reference price list. And then there was a court ruling that the reference price list, which was used by industry in general, is invalid. And since then, almost each and every scheme has got their own tariff file. And there has been a widening of the difference between the different schemes in terms of what's in their tariff file. And that, again, has caused complications in the industry.
Quite serious complications, it's caused.
And they have market inquiry also
has
talks
found
about
that.
that.
And
talks to
the
that.
Commission has recognized that they were incorrect in those rulings that they had made in 2004. So is the industry now going to do something about this confusion and all the splintered type of codes to create a uniform system?
We depend on the regulators as well, because sometimes you can, as the industry says, but we are a very regulated environment, and a lot of what happens is in line with what's in the Act itself and the attendant regulations.
Isn't the problem from the doctor's point of view that if a doctor services patients from Discovery, GEMS, and MedScheme, and Discovery has its own coding different to GEMS, but you punish them for being wrong on the code?
Chair, punish is a very strong word.
The deduction of someone's payment is severe punishment, especially where they depend 90% of their income on GEMS, depending on their location.
Can I just, in answering, Chair, the various medical schemes have different approaches on this issue. And I'm going to just use one example. Some medical aids, if you submit a service that you've rendered, and they say we pay you 220 for that service, and then you submit 221, and they send the money to the patient. We don't do that. We pay you the 220, and then you can negotiate the difference. So the issue of how the industry general responds to those intricacies that are related to the various tariff file, it's different from scheme to scheme. So while, Chair, you are saying it is punishment, I think the things we do in response to whether we think a coding is wrong or whether we think something's wrong, all these things are aimed at trying to act in the best interest of the member, doing the right thing in terms of our interpretation of the rules and the act. The focus is not on punishing the healthcare providers. If anything, we want to pay the healthcare providers for the services that they render.
Thank you. Mr. Mohape, how long is this going to be?
Just two more slides, and if the panel will allow us, if we want to demonstrate why we have an example, otherwise, yeah.
No, proceed.
All right. I think one of the key messages that we want to drive from a GEMS perspective is that, that was slide 51, is that we also report matters to the healthcare HPCSA and the South African Pharmacy Council. And I think the HPCSA have also indicated in their submission previously that they do receive our complaints. The other one that we have made in our initial submission in July is also the figures, which we have not included in the slides. And my apologies, is that we have reported about 231 cases to the South African Police Services. And also, I would like also just to commend the regulatory bodies. We are seeing traction in the number of cases that we have reported, and we have, regular, and one would say quarterly engagement with the bodies, just to make sure that they get assistance in matters that we have reported. So yeah, so those that is what I'm trying to drive on the slides.
Mr. Mogabi, sorry for the interruption. It's just the nature of this particular beast, but I have to take you back to the previous slide because I don't think you've actually addressed all the issues that you need to on reversing irregular claims. Please, can you explain how the amount is calculated when you reverse?
All right. Okay. I just want to indicate that it will depend on the analysis and the investigation. So we would have identified particular claims which needs to be reversed. We have given an example, I think, in one of the bundles in terms of where, in the case of a physiotherapist, where he would have submitted claims and he did not apply a certain modifier in that respect. So by applying a modifier on those claims, effectively making sure that it will reverse some of those claims and so that we can resubmit with the correct. In that instance, it can be all. But in an instance where...
So on that example, the scheme decides which modifier the doctor should have applied and reduces the amount accordingly.
It's not the scheme, but it's in terms of, obviously, coding and tariff.
In terms of the scheme's rules,
Yes.
as per your policy. In other words, the scheme decides its rules, the scheme applies its rules, and the scheme therefore decides.
No, that will be, yes, in terms of the tariff, yes, it's tariff, yeah. And it's an accepted tariff by the industry. And that is one example. The next example,
Sorry,
yeah.
It's an accepted tariff by the industry. It's this.
Scheme tariff file, yes. So say for certain claims, especially in physiotherapy, and even supported by the society, you need to apply certain modifiers to certain claims.
As per your policy, you talk about the scheme's rules. Is this what you're talking about?
The scheme rules, yes.
Yeah, they are. Do you have your own reference price list?
No, we have a GEMS tariff file.
Okay.
Yeah.
And does that include the procedural codes as well as the associated tariff?
That is technical, but it does. If you need clarity...
So what is wrong with what I'm saying?
No, it's just
sounds
technical.
like I'm accurately capturing exactly what you do.
Yeah. No, sorry, Chair. Yeah. All right.
So please can you confirm that is correct?
That's correct. Yeah.
Is that the one at page 574 to 575? Is that the example you're talking about?
Let's see. Correct, Chair. You see?
And how did you calculate that 45,000 rands?
So,
Because that annexure that you refer to is not actually included in the bundle.
do you want to go into modify?
If I can just explain, without going into too much detail, but the way that a modifier is applied in physiotherapy claims, it's dealt with in the rules of the GEMS tariff guide, but also the industry also deals with those rules. And modifiers that we are talking about, particularly modifier 0008, applies to modalities, which they call modalities, which are certain treatments. And the codes for each of those different tariff codes for each of those treatments. And in terms of the rules, the first tariff code or treatment is paid at 100%. Thereafter, modifier 0008 must be applied, and it reduces the fee that is paid for that tariff code. And there's a maximum of 3 modalities allowed per treatment. So what we did to calculate that amount was then where the modifier wasn't applied, we applied it. So we gave the provider the benefit of the doubt by saying the most expensive tariff code or treatment is the one that is paid at 100%, and thereafter we apply the modifier and calculate the difference.
So it's entirely within your discretion to apply it in the way you think is correct.
In terms of the rules.
Thank you.
Correct.
So are you going to give us that Annexure B, which should have been included in this but was not?
We will do so, Chair. If we may be allowed to proceed?
Yes, indeed. Thank you.
All right. I think we've touched on the issue of reversal of irregular claims. This slide basically demonstrates prior to 2017, GEMS reversed all claims it deemed questionable or irregular in instances where providers failed to respond to anomalies, identify, and where explanation provided were not suitable to address fraud, waste, and abuse findings. And then we can indicate that in 2015, mainly they were largely due to the group practice physician and clinical psychologists and registered counselors. And I just want to stress that this process was not done by the administrator, without the approval of the scheme. It was something that was sanctioned by the Claim Risk Sub-Forum. So those are the figures that we just wanted to indicate.
Yes, I mean, we've got one example that came from you, not as part of the complaints, on how you calculated the amount to be reversed. What is the standard procedure that, well, we've got 2 examples. There's another one, I think it's Mr. Mavunda or something. Yes, at page 568. So, I mean, you've asked for all sorts of information from him dating back to 2016, which is more than a year old at the time of the letter. And then we have the other example, you referred to the example about the modifier, which is at page 574.
Yes.
Now, the one at 574, you've given an amount, and then the one at 568, you haven't given an amount.
So, yeah, Chair, maybe I just want to indicate the context of that example, and I think we can provide a better one. But in that example that we submitted, if you can look at that Annexure 27, if you can look at our main submission, this is an example of the information which is required at the point of when investigation is initiated. So there would have been analysis that was completed on this investigation, and actually I'm aware of this matter, is that the provider was even engaged, and even we visited his premises just for the purpose of identifying all the anomalous claims. So in this instance, you will not see this, but this was just to paint the picture in terms of what is an example of our letters when we do request information. So you would see on the second page, 569, we asked a certain question: operating hours, facilities with which you operate, the equipment that is registered to. So that was one example. The other one example, I think that you have indicated of page 574, it was mainly of what an anomaly letter looks like.
So what were you trying to demonstrate by 568? The type of information you seek?
Yes, if you can go to your main submission, yes, the type of information that you will normally request at the initiation stage of an investigation.
My understanding from your testimony is that although this is on GEM's letterhead, but this is really a job done by Metropolitan.
Correct.
And it's them who then make these determinations. I mean, that's why I was asking those questions initially.
Yes.
They make all of these determinations, and virtually everything that is here is clinical.
I agree, Chair.
All right.
Okay.
Yes, you may proceed.
Yeah, all right, so this slide talk to recoveries, I think is, I still have more slides that I have to attend to, probably about 2 or 3. So, recoveries in our instance, we had a legal panel that assisted the scheme. Once we have identified some of the irregularities and maybe we have reversed the claims, they created that in terms of the provider profile, and we would initiate, civil litigation against those service providers. So that's one way of doing recoveries, and the process has actually evolved, and also there is instances where providers, after you have probably done reversal, for instance, we can take the example that we have just mentioned of applying modifier 0008. Once you apply that modifier, you find yourself that the provider might be indebted to the scheme to the tune of maybe 100,000.
So what are those figures? Is that 812,000 at page 52? 1.1 million, or what are those numbers?
Okay, yes. Okay, this values is basically amount, if you can look at the graph, the one in green is the amount that were reversed.
But what is the amount? Is that 812,000 rands?
Okay,
When it says amount reversed.
Yeah, I just want to get to...
One,
the first one in 2012, the value is 812,000.
All right, no, that's fine. And then it goes up.
1 million.
Is the one in 2016 86?
86 million.
Is that 86 million?
86 million. And that related to a specific group of service providers.
And the one in 2015 is 68 million.
68 million. Also, that it related to
12 million and 4.4 million.
Yes.
And 377,000.
Yes. So yeah.
And what is the explanation for this variance in 2015 and 2016 that you were able to recover 68 million and 86 million? And then, I mean, they jump from 1.6 million to 68 million. It's quite significant.
Yes. Maybe I would just need to indicate, Chair, that that does not indicate actual recoveries, but it indicates reversals that we did, and these are system reversals. Whether the amounts where eventually we managed to recover, I can provide you with the specifics of each and every case relating to those amounts.
So when you say a reversal, is what is claims submitted but not paid?
Yeah, yes, the claims went through the search engine, the provider was paid.
So then what
and
did you
then
reverse?
after the investigation, remember, we need to correct the action because those claims were irregular and invalid claims. So you have to reverse those claims. And essentially what it does, it creates a debt on a service provider.
Okay, so this is just an internal accounting thing. Is that from one book it shows you've paid, from another book it shows that you have noted that you should not have paid?
That's correct, Chair.
And then the recovery would take place through deductions from future claims.
Yes, the recovery will take through future claims or either by way of an agreement.
AOD.
Yes.
So what's the explanation then for jumping from 1.6 million to 68 million of what you now say we should not have paid?
Yes, and in that instance, it was mainly a specific case. In 2015, we uncovered a group of service providers. I would not use the word syndicate, but we uncovered a group of service providers who submitted a regular claim. It was based on an investigation on that group. And also we are actually suing them in terms of to recover those amounts, because after our investigation, they stopped practicing and they just, yeah. So we are initiating, civil litigation against that group. And in 2016, also largely, also there was a group of service providers in that respect.
And how did you find these groups? I know you don't want to say syndicate, but they're operating like a syndicate.
That's correct.
And how did you find those syndicates in 2015 and 2016?
Through the analytics that were implemented at the time, and also tip-offs that we received from members. So there were members who complained that they received claims and we have not, this is the service that we have not received, and also from analytics. So
And the 86 million in 2016 is a different group is a different syndicate, or is it the same?
oh, it's a different
different.
one.
So you say you're going to institute a civil claim still?
No, we are in the process.
You're in the process
Yeah,
already?
in the process.
So
yeah.
that's public, right?
That's public because we can share the information to say at which stage whether summonses have been issued. I think on one matter, summonses have been issued.
If you haven't issued summons on the other, then it's prescribed.
No, we're managing that process. No, we're managing that process.
Well, then you can tell us about it.
Yeah, no, we're managing that process. We have a fraud that process in terms of these matters, and our legal panel is actually handling these matters. But I can assure you they have issued summonses on those matters.
And where are these doctors from?
KZN.
Yeah, all right. Surprise.
Since we are on that, can I just take you back, sorry, to slide 47? Are these allegations received in 1 year?
All right. This was actually from 2012 till 2019. This was in line with the panel's request.
This is 2012 to 2019.
Yes.
And KZN, you said KZN had been targeted for investigations. I just want to know, off that figure, the 2,962, how many of those came from tip-offs and how many from Metropolitan?
Thank you, Chair. If I may direct the channel to our submission, page 66.
The submission or the presentation?
The submissions.
Yes, we've got it.
Yes, if you can look at those, you have on the first table on 11.63, it's actually a total of all this 10,441, which is mainly our sources of allegation, and 11.6.4, you will see it is indicated as analytical tool, and you'll see KZN in that respect. I think we have it from a yearly in terms of 2012 till 2019, and you can see the number there is 272. That is basically from an analytical tool. From a business referral total, also using same analytical tool, you would have 196 as a total. If you go to an HIU initiated investigation, that is from Metropolitan Health, in 94. We got tip-offs from the industry relating to KZN, about 22. And then we got also from the media, we did not receive any, but from members themselves, we received about 7. And then from the scheme initiative, I think 73 things that are referred to the scheme and which are referred to the Metropolitan. We would do that because some members, they go to our business centers, and we have what we call client liaison officers. Client liaison officers visit members at their different employer group, and from there they can also collect information to say, please, we have this problem. They will send it and we'll forward it to
Can you just tell me, thanks for that explanation, in relation to the two syndicates, which is where the biggest reversals took place in 2015 and 2016, How did you identify these syndicates?
Okay.
What actually happened practically?
Chair, if you allow me, I would have to get into the case management system so that I can correctly state what was the actual source of those investigations. We have the data available.
And were they hospital groups or what type of service providers you were
So,
talking about?
One was a hospital related in terms of it's a rehabilitation center for mental illness.
Because I mean, what-
And then in 2015, one, if you can see, it was a physician, but it related to him relating to the hospital and a physician.
Yeah. Because what we know from your CMF report of 2016 was that the specific problem in KZN which resulted in management focusing on it was excessive use of hospitalization.
That's correct.
Yeah. Now, how were the hospitals involved? I mean, that's the facts we just do not have because that's the biggest spike. And you say once you cracked the syndicate, then the numbers went down.
So, yeah, in that instance, I mean, not to give you too much detail as I don't have the initial case report, the hospital involved were Sanctions and they actually stopped operating because of the model in which they were operating. They actually stopped operating once we started with the investigation. So, and the other one, I think which was one of the biggest reversals, was an individual who was operating in a specific hospitals. And it was driving, obviously, cost in terms of admissions. So even in that instance, but we can share the case report with the panel.
And what we are really interested in is how did you identify the syndicate? Was it just
Yeah, we'll do that.
one of the members of the syndicate coming to report?
Yeah, we will provide that information, even if it's before the end of today. We can have. Yeah, thank you. Chair, maybe also, as part of our policies, obviously when we have sanctioned service provider, we would also reinstate. There is a process where we have an SOP in terms of when we will reinstate a service provider when they would want to be back on direct payment. And that request is also a formal process, and which also will be decided upon by the sub-forum, which we meet on a monthly basis. And this is just a graph indicating that from 2014, we have actually increased the number of providers that we have reinstated.
Dr. Mukhapi, could you just explain something to me, because it's used, there's a term that's used in different ways by different schemes and sometimes differently in your own documents, and that's direct payment.
Yes.
When you're talking about direct payment, are you talking about direct payment to the service provider, or where direct payment is made to the member and the service provider claims?
Yeah. So is Chair, you're
And is it a consistent use of the phrase direct payment?
So-
What do you mean by that?
Yeah, so for us, from a scheme perspective, and as you would see also on our sanction document, we use the word termination of direct payment. So we terminate direct payment.
Meaning you terminate direct payment to
Yes,
the service
to the service
provider.
provider. That's correct. And this is an indication of providers that we have actually reinstated. That's, I think, concludes my part in terms of the governance process. If the panel will allow us, I mean, we have specific examples that we'd like to share with the panel.
Yes. I do want to just ask two things which are part of your the main submission. So if you go to page 101, so that expands on the reversals. The category that you have, I would say, that is indebted to you the most, because now I thought the reversals meant money is actually paid to you, but apparently not. It's just that you enter them as a debt. Is clinical psychologists. That's like your largest risk pool, if I can put it that way.
Yes,
Yes. Now, that was already in 2016,
yes,
and they are then followed by general practitioners and registered counselors. Is that correct?
that's correct, Chair.
Now, what we know about the province of KZN is that because it presented you with the greatest risk, you focused on it. Did you also focus on clinical psychologists from 2016? Because they are clearly a risk area.
Yeah, Chair, I've indicated that those clinical psychologists in 2016 were situated in KZN.
Yes.
So yes, we did focus because this reversal.
And were
that
they
is-
part of the syndicate? Were they part of the syndicate?
Chair, yes, it was a syndicate. So this is the
Now,
group that
we
I
know
talked
there
about.
was a syndicate. I mean, the
Yes.
question is whether these clinical psychologists that accounted for the spike in 2016 were part and parcel of the syndicate.
That's correct. Yeah.
Now, did the company take a decision to focus on clinical psychologists as a specific area of risk?
Not necessarily. We look at all cases. It's just this is one of the cases which was significant at the time.
Yes.
But we look at all disciplines, yeah.
Yes. But in 2017 and 2018, clinical psychology was not identified as a specific area of vulnerability.
Chair, they would have been, because what also does is that, okay, I don't have the slides here relating or information around 2017 investigation, the disciplines that we looked at, but they would have. And I need to indicate one of the reports that I've highlighted earlier was of preventative blocking. As we sit here today, I can attest that there's a service provider who's registering a practice number at both healthcare funders linked to that. We do not stop, and I think there will be slides if I can show you that map.
Yes.
That is a syndicate I'm talking about. But this is a specific example that we're talking about. The web is growing, and I'm saying this with fact that every claims run, the link, they continue to do that. And this matter is with the police at this stage. So this is one of the examples that we're going to show. We just redacted the names for the purpose of the panel, but we are more than willing to share this information with you.
So I just want to make sure I understand this, because I think the last answer you've given is that they would have, clinical psychologists would have been an area of focus. I just want to know as a fact if they were an area of focus.
I think not necessarily. It's not a fact because of, I think we are guided by what the outliers show, so the emerging risk. But this syndicate itself, obviously, when we're using preventative blocking, when it comes up, then we will do investigation. So we would not necessarily target a specific discipline. We would be guided by the risk that the analytics would have shown us.
I understand, but I mean, we know the risk in 2016. It's
Yes.
clinical psychology.
Yes.
And how do you respond to that risk?
Yeah. No. Okay. All right. So, I've indicated, maybe by way of an example, I've shown that there's a tool that we use which is a link practice. So we have that tool which will manage this risk, so that we don't just forget about it. So before every claims run, we can see whether there's any emerging service providers that might have been linked. So it's still a focus. It's still a focus.
I just want to know factually, because if I'm running a business,
Yeah.
and I know schemes are not meant to make a profit, but who knows what happens. But if I'm running a business and I know that the greatest area of vulnerability is clinical psychology, it seems to me logical that I would focus on stamping out FWA in clinical psychology. And that is why I'm testing this proposition with you.
Yeah, and I think from a strategy point of view, it would not have been a recorded decision that we strictly focus
To
on
be
that.
an understanding.
Yeah.
Okay, now I just want to ask you something else as well about there's another graph. It is at page 105.
Yes, I've got it, Chair.
Yeah, now that records recoveries for 2018. Recoveries are different from reversals. Recoveries are monies actually received.
That's correct, Chair.
Yes. Now, the problem is there is a clear outlier here. It is Tranquility Lifestyle Center. Is that correct? I mean, they seem to have paid back something like 12 million rands.
Chair,
Oh, I suppose I should not have mentioned the name. All right. Whoever has listened must put their... All right. There is a...
but I can confirm, Chair, what you just have said.
All right. Where are they located?
KZN, Chair.
Now, are they part and parcel of the problem you identified of a syndicate? Because the syndicate apparently seems to have continued in 2017 as well.
Chair, that's correct.
And they are predominantly black, all of the names on this list.
That's correct, Chair. In terms of the definition we've had from Dr. Kim outside, they're black, yes.
Now, yes, that's the one part of the issue. The other part is where are they from, where are their practices from? I mean, that's information you all have from the CMF. I
Yes.
mean, there are a number of Indian-looking surnames, but I don't want to assume
Yeah.
that Indians are in KZN.
So locality in KZN,
Yeah.
Chair, in terms of the suburb or?
No, doesn't matter, just a provincial one.
Oh, no,
because
they are
I'm
KZN.
trying to draw the link between the
No,
strategic...
they're in KZN.
KZN, I see. Okay. Now, this is all known to GEMS. I mean, this is obviously information that emanates from your service provider, Metropolitan.
That's correct, Chair.
Yes. But this is known to GEMS.
That's correct, Chair.
Yes. So what we can say for sure is that in 2018, the monies you've recovered are monies recovered almost exclusively from black practitioners. Because we've got the list here.
Yeah, so, Chair, maybe,
Would you did agree with me that these are black practitioners, right, in the board?
in terms of the one that
The
was,
names,
the name,
judging
the
by
name
the
which was,
surnames.
yeah.
And you are going on the same?
No, I'm talking all. Now
Yes.
we're looking at the
we
list.
can,
Actually,
yes,
I
you
was
can look
looking-
at all yourself, take your
Okay.
time and go through them.
Okay.
I think the number is probably 99.9%
Yeah.
black.
I can't, yeah.
Yeah. Chair, maybe without being controversial, in terms of my own personal,
Yes.
explanation of whether this name constitutes black or not, I would rather that the scheme has got a position around the definition of what
No,
is
no,
black
no,
and not.
no, that's fine, I understand.
Yeah.
What you are saying is not binding on GEMS. I mean, you are a senior person
Yes.
who is respectable in your profession. That is why you've been asked to give evidence here. Just look at the names yourself and just tell us. I mean,
Yeah.
I'm putting to you, I've
No,
looked
no.
at the names. This is
Yeah.
99.9% black.
No, based on my interaction, because I'm involved in this process,
Yes.
I can say, yes, they are black. I mean,
Yeah.
if you ask my personal,
No,
view.
I understand. I mean, it's
Yeah.
not personal in the sense that, you are now going to be personally liable. But
No.
the reason I say you are a respectable person in your profession is because you sit in the CMF.
yes.
The people who investigate put these things to you. This is information that you know for sure that 100% of the recoveries of 2018 were from black doctors. I mean, this is as simple as that.
Yeah.
And now the reason you know this is because you've looked at the surnames, correct?
Yeah. So, Chair,
Just answer that part first, you can then give an explanation, is that correct?
I just need to correct the statement
right,
of
so-
the 100% recoveries in 28 were all black. I need to correct that. I mean, it was not all black, you know. So, I mean, we have. yeah.
What was the percentage, if not 100?
I don't have the figure, but yes, we can provide that information.
No, what, we've got the names here.
Yeah.
This is what you've provided. And I'm just saying to you, look at the names
Yeah.
you've given us.
It says the value of recoveries for 2018,
Yes.
and then all the names of the service providers from whom you recovered.
Yeah.
And we've already agreed with you that they are
Some
all
of
black.
them, yes, are black, yeah.
No,
But,
no?
I would not. I would use the word predominantly, not instead of 100%.
All right, let's say 99.9%, so that we give you the benefit of the 0.1%. But just answer the other question that I'm interested in, which is relevant later. Then the reason you know this, that you and I cannot disagree, is because you've looked at the surnames.
Yes, I've looked and personal knowledge of
Yes.
some of the matters. I think
Yes.
that's.
Now, that is
yeah.
even better, that you also have personal knowledge
Yeah.
because you are in the CMF.
Yes.
Yes. Now, if we then move from that understanding, now GEMS also knows this because you are the GEMS representative at the CMF. Correct?
This information obviously is shared here at the Claims Management Forum in terms of recoveries.
Yes.
Yes.
Now, when GEMS says that they don't know the race of the practitioners, that must be false.
I think, yeah, Dr. Stan.
No,
Yeah.
just
No,
answer, because we're doing
No,
well
I
so
don't,
far.
no, I don't want to say it is false.
Yes, but from what you have,
Yeah, but
anyone who can say they don't know the race of the 2018 recoveries, that person is lying.
the race in terms of the practitioners that you have dealt with, you would know it because you have personal experience of it. But in terms of who in the whole entire system, and I'm talking about 36,000 service providers, would you know this one is whether is it white or black? I mean, in this instance, you've got the name Tranquility Lifestyle. When you look at it from a surname perspective, would you say it's black?
No.
Nobody would
we'll
say
deal
that.
with the companies. I'm just
Yes.
talking the individuals, which
Yes.
is what my colleague was asking about. I'm saying if anyone says they don't know the people that are targeted for investigation and from whom we recover, they don't know their surnames, that is just a lie.
Yeah.
Correct?
So, and I think that point, Chair, without maybe debating it, I would leave to our expert that we have appointed in this respect, so that they
No,
can
just
they
from
can
your
advise your
own-
position.
From your own perspective, let me not use the strong word like lie,
Yeah.
because maybe that is what is creating discomfort. Let me withdraw that word. But you would not accept any testimony that this race is not known, because you've just showed us and you've just agreed.
Look, Chair, maybe also, whilst this issue has erupted, I mean, I have my view, especially
No, that's
around
fine.
classifying of race in terms of surname, and which I say it cannot only be that fact. I mean, and historically,
Why? Because Tanga Velu might be white.
I've got Vili Peterse.
No,
who's
that's
black.
fine. We're going to
I've
deal
got
with the
Nokolo,
outliers.
I've got Grootboom, which
Yeah,
is.
no, we'll
yeah.
deal with
so,
the
so,
outliers.
so you would not necessarily use the surname.
No,
but-
we'll deal with
yeah,
the outliers.
yeah.
I just want us to finish the line I was pursuing with you.
Yes.
I'm saying that we've now agreed on all of the premises, right? That we've looked at the names, we've
Yes.
concluded these are black surnames. You even gave me the geography, black surnames from KZN. Now, anyone who says, I do not know, I'm not saying anyone who disputes, I'm saying anyone who says they do not know, you would not agree with them. If somebody from GEMS came here and said, well, sorry, I don't know the race, because the GEMS representative, sorry, ma'am, can you
Yeah,
please
yes,
not
yes,
speak to the
yeah,
witness?
yeah. All right, yeah.
Because she's giving you whatever
No,
instructions, but
it's
I
fine.
don't understand. We will ask her questions.
Yeah.
So anyone who, you sit on the CMF,
That's
anyone
correct.
who, and this is what you know from the CMF, also from personal interaction. So anyone who says, I don't know the race from whom we recovered in 2018. That person would not be correct.
No, I disagree, Chair.
Okay.
I disagree. Hence I say, I'm in this position and I know this fact because I've been involved in this matter. And if I ask maybe, for example, our audit exec who sits maybe in that meeting from an oversight perspective, or maybe it's a CFO who has never dealt with any of these matters, and when you present this name, that person would not know whether this person is black
But
or
I'm
white.
saying you as a representative of GEMS at the CMF, would you not accept that at the very least?
No, I mean, I would accept it if they don't know. That's my view.
But if they asked you, you are the representative, the information you would give them is exactly the same you've given us.
Yeah.
Correct?
If they ask me about this one,
About the
obviously,
race, yes.
then they will know from me.
Exactly. Now, you remember when I debated earlier with the GEMS representatives, I said, GEMS says to us, they are the champions of transformation, and we accept that. If there is an allegation of race, they will champion the investigation. It seems to me, and you can tell me if I'm wrong, it seems to me that one of the first things they would have done if they wanted to know the race is to come to you, because you've just explained this to us, and most likely they did come to you, and most likely you told them exactly what you told us.
Chair, you would remember I deal with outliers, so which forms not even the whole number of service providers that are on our database. And if you look at the numbers, I would not know each and every person that is there, but I know the race that you have indicated here, all the cases that I've dealt with, and the one that I would have personally been known.
No, I appreciate that. All I'm saying, and this is just the last question, and there's again no fight here, and all I'm saying is that if GEMS seriously wanted to interrogate the race of these people that are subject to investigation, the most obvious source is yourself. And if they had done that, you would have told them exactly what you told us.
I'll be one of probably the sources relating to a certain number of service
Yes.
providers that I
You
deal
would
with.
agree with the proposition?
With the service provider that I deal with, to
Yes.
say, maybe from my analysis from dealing with Dr. Sitlangu, I've
Yes.
seen Dr. Sitlangu,
Yes.
he's black like me.
And you would accept that?
That information, I mean, that's fair, that's one is fair. I mean,
That's
I
fair,
cannot
all
argue
right.
with that.
Thank you. You can move on. There is another slide. All right. There's another slide I'm just interested in. It's the one at 106.
Is it, okay, we're on the, yes, the
Now,
submission.
the reason why this slide is interesting is because it takes the discussion beyond 2018 and it now tells us the picture of 2019.
That's correct.
Yes. Now, again, I'll give you, I mean, one of the things that interested me is there is one person there, that's Dr.
I'm not
Okay, you
mentioning
said
their
there
name.
are no names, no names to be mentioned, fine. So there's one person there that seems to, like it's about probably 2.6 million. Is that the correct figure? For that one individual? Because it seems
Okay,
to...
the one that is actually,
Yeah, the highest.
the highest.
Yeah, yeah. So is that in excess of 2.5 million?
it appears so, yes.
Now, that's fine. And so that means that that's the amount that he has paid GEMS back, correct?
No, it does not mean
It's
that.
simply, it's a debt raised against
It's
him.
a debt that has been raised, yes.
Yes, no, I thought when it says recoveries, but I see at the bottom there is
Yes.
an
Red line.
explanation.
It's an explanation,
Yeah,
yes.
there's an explanation, but
Yeah.
that's the amount you expect from him,
That's
if they pay.
Definitely, yeah.
Now, just tell me this, these names of the debtors, call them the debtors.
Yes.
I've looked at these names now beyond 2018. These are again black surnames, except of course for the companies. Let's say the majority, I'm not saying every name, but the majority.
That's correct. Yeah.
The overwhelming, more than 90%. All right. And the discussion we had in relation to 2018, you would accept also applies here.
That's correct.
Thank you very much. It's been very helpful. You may proceed with the rest of your presentation.
Chair, I would allow my colleague Lingita just to, if allow.
Before
me to
you
do
finish, then a
demonstrate.
more
Yeah.
mundane question. Can you please just look at page 53 of your slides? I don't understand your AODs and how the amounts are calculated for your AODs.
We're on the correct slide, recovery of regular claims.
Yeah, it's
Yeah.
under 2016.
Yes.
And 2017, you enter into AODs in order to recover. How are the amounts calculated in your AODs?
Yes, okay. The first point is obviously you have to determine the irregularity. So the AODs, it will be based on actual the claims that have been identified as irregular. So it will be an amount that you can confirm. And in certain instances, if the amount is not determinable, basically from a claims line perspective, that's where the provider will be allowed maybe to have a negotiated settlement.
And does Metropolitan give you that information in the information from the data in terms of what is, you said they are identified by way of the claims that are irregular. Does Metropolitan give you that number?
So that's form part of the claim risk sub-forum. This information is packaged and tabled at the claim risk sub-forum, yes.
So does Metropolitan give you that number?
That's correct.
And is that the number you put to the provider?
Normally, the engagement, yes, that will have been done even maybe by Metropolitan themselves.
Okay, and how does Metropolitan calculate that number?
They will base it in terms of an investigation, maybe also a way of examples that we have is that they would have looked at the provider's claims profile, and I think my colleague Lynn has indicated in terms of the modified 0008. It might be one of the examples in which one would have come to that number.
Can we get a more detailed answer on that, perhaps, when your colleague gives evidence?
We can do that. Thank you. It's not
Thank you. Will that be all from you, Mr.
I think that will be all from my side. I would like to hand over to Lynn Gator.
Thank you very much.
Okay, and yeah.
Thank you, Ishmael. Thank you, Chair, and the esteemed panel. My name is Soili Mutuba. I work for Metropolitan Health. I'm the Chief Commercial Officer of Metropolitan Health. Metropolitan Health is a medical aid administration company that is accredited in terms of Section 58 of the Medical Schemes Act, number 131 of 1998. We provide medical aid administration services to the government employees' medical scheme, and the administration services that we provide incorporate claims management. An integral part of the claims management process entails fraud, waste, and abuse in terms of management of fraud, waste, and abuse. And I think you've embellished enough on what that stands for, and I think we're all in agreement in terms of our understanding. And the services that we provide and our process flows are informed by the Medical Schemes Act. We ensure that we do not flout the rules in terms of the requirements of the Act, or we do not contravene the Act and its requirements. We also ensure that we do things in line with the regulations, specifically Regulation 18 of the Act. And of course, we have an administration contract with the administrator, which is underpinned by a service level agreement, which is very stringent and punitive. And the services that we also provide are actually guided by policies, procedures, and processes as set and approved by the scheme and the management team, as well as its board of trustees. The scheme, as I said, uses the SLA as one of the monitoring tools. So basically, the way we're going to be presenting is, with your permission, if we can ask for your indulgence, is to allow my colleague, Lynn Gita, who will take us through the process and in how we actually deal with fraud, waste, and abuse in our claims management system. And she will be supported by our colleagues, Frank Wiltshire and Nias Ibrahim, as well as Dr. Eugene Berger. And I must just be upfront and say Dr. Eugene Berger has not been sworn in, and if and when there's a requirement for him to come in, we would like to ask for your guidance as to how we can sort of have him participate. Over to you, Lynn.
Thank you.
Chair and the panel. Perhaps I can just start with answering two questions that were referred to me to deal with. So the one is to deal with the calculation of the anomalies, that will be then the provider would be engaged around. So it would really depend on the case and the anomalies that were identified during the investigation or the review of the provider. The example that we gave earlier was relating to a physiotherapist that had not applied modifier 0008 to the claim lines, to the modalities, and we then applied them in terms of the rules of the tariff guide, and that's how we calculated the...
You know, the example you've provided, I mean, I think I'm relatively satisfied that it is a scientific example that tracks to the extent as possible 59.3 and regulation 6.3, because it's focused on the amount. And of course, it does use approximations because you can't really be exact. But at least its principle is the amount. I think the main question that bothers us is that what we've seen from other methods of recovery is that schemes are not specific as to the amount. And so what they do, they calculate an amount for 1 year or for one batch of claims. And once they've calculated that amount and they say it would constitute 10% of the overall claims you've made for that month or for that batch, they then use that to average backwards, sometimes by 3 years, sometimes by 2 years. The only question is really whether GEMS is also one of those service providers who do that.
No, we don't do that. So we do it on a claim basis, and you know, depending on what the anomalies are around those claims, and we apply it specifically. So we don't sort of extrapolate.
Can you just give us an example? Because I'm trying to understand then if you are investigating one claim, many claims. I mean, does your system spit out a outlier in relation to numerous claims?
Correct.
And then do you investigate each and every one of those after the system has spat it out as an outlier?
Yes, so we will, so when we identify a provider or a practice as an outlier, we will extract every claim for the period of review, and then we will analyze those claims. And we identify the claims where we consider there to be anomalies. We'll engage with the provider, ask for certain information, because the anomalies may be plausible. Or, you know, we'll revert back and say, based on your response, you know, these are the issues that we still have. This is our calculation of the anomalous claims.
And how long are those periods of reviews?
It really varies depending on the response time from the provider.
No, the period under review for the practice.
I see. So it will normally be the previous benefit year and then year to date. So if we are reviewing a practice, let's say September 2019, we'll look at 2018 claims and then the claims from January to September 2019.
So let's say 2 years. And then so does your reversal or your recovery happen in relation to all the claims in that full 2-year period?
Right.
And do you investigate each and every one of those claims? And when I say investigate, go beyond your analytical system.
Not each and every, only where we identify that there's an anomaly.
So if we can go to page 568, maybe then we can get more specific of your submission. So there, you see, we have the example of Mr. Sorenso. And what we know is that your statement is correct insofar as you go back one benefit year.
Yes.
Because this is May 2017, and if you look at the data you requested, you see it goes beyond to, I'm sorry, it's not, well, anyway, correct or incorrect is a different issue. But the first thing is, it goes back 2 years into April of 2015. So this one benefit year plus whatever period, you know, doesn't seem to be entirely correct. So would you accept that?
Yes.
Now that's largely what, as a result, I mean, why do you have one information, which is we use one benefit here, but your service provider implements something different.
All right, I think, Chair, the question is directed at myself. Look, I think when she started, she said it varies from a case-to-case basis. And if you can look at the discipline which we were looking at and where the irregularities might have surfaced, this matter deserved to go back 2 years. So in principle, they would say a year and 6 months, so that not to overburden the service provider. But in this instance, if you look at the nature of the allegations that they were looking at, it deserved to go back 2 years. So it depends from one case to the case to another. But it's not just prescriptive in terms of how far back you can go in terms of investigation.
No, I mean, I understand that's what you're saying now, but there must be something wrong where someone senior at GEMS is asked by the panel, what is the period? And they undoubtedly say it is one benefit year, but the evidence shows the contrary. And only when it's interrogated do we then get an explanation. Is it because this is not widely communicated? Or, as you say, it really just depends. It can be 3 years.
So, yes, it can be even 3 years. I mean, it will depend on the nature of the case. I mean,
So this idea of one benefit here is just not an issue.
no, it's as a norm, they will do that. And sometimes when the matter even it comes to the claim risk forum, we can request that you extend the period to a longer period just to see the severity of the irregularities. So they use it as a norm from their side, a year and 6 months.
You see, the reason why this is an issue is not to point out contradictions, because that's not our function. It's because doctors have come here to say, listen, you are asking for information that goes back a long, long time, and that 3 years is unreasonable. We don't have it because we don't have a storeroom. So we see patients, they go, and we get paid. And to ask for me 3 years ago, I don't have that information. And that's why it's crucial for us to understand what is the practice per scheme, so that we can assess if the doctors are manufacturing the complaint. So that's why I'm a little bit concerned about the apparent inconsistency, not because I'm trying to catch anyone. The other thing I want to understand about this is that if you now forget about the timing issue, just look at how the money is then calculated and deducted. Remember, we asked how do you, and that one example of the code, I mean, I think I get the point there that GEMS tried in that instance to be scientific. But let's take this example of 568 and 569. So you've given the doctor specific names of patients, 12 patients. When you finally recover, are you going to recover all of the claims paid to those patients? Or how are you going to recover?
In this instance, let's say the provider has not,
Yeah, let's say the provider
Yeah.
says, I don't have the information, it's
Yeah.
too long ago.
or either I didn't even render the services. Those claims were not supposed to have been submitted. I didn't do the X-rays. We'll definitely recover. Remember what I said, is from an accounting perspective and also from a medical record perspective. It is one, if you look at the member's profile, it will say you've done X-rays and you received this type of treatment, whereas in actual fact you have not. You need to rectify that. So definitely we will recover everything.
So you'll recover everything here.
If services have not been rendered in this instance, our
I
findings.
mean, for instance, look at the second accusation. It says high fees are charged on tariff code 39300. So services have been rendered, but the amount is excessive.
Yeah. So in this instance, and as I said, there was development on this matter, and I think it forms part of the complaint, which we duly responded to. The provider was out of sync, or was an outlier based in terms of the fees that he charged. So the accepted norm would have been set, and there would have been engagement to say, can we in future change your claiming behavior? Because I think the norm is here. So it might not even be a recovery. It can be something that can be noted and one we look at for future. Remember, one of the sanctions that you can request a provider to improve his claiming pattern. So it's not that in every case that we investigate, you will actually have to do recoveries. Where you cannot quantify it, you don't recover.
I have another example to put to you, I'm afraid, to test the same line of questioning that came from my colleague. And it's at page 3433 of the panels bundle, not yours. If you can try to locate that, and if not, I can assist you. 3433. Okay, sorry, the Secretariat is telling me that it's at 870, the letter that I'm referring to, page 870 of the panels bundle. The pagination has gone awry. 870.
We have 870.
But that does not look like what I'm referring.
Yeah.
Is that a letter? Is that
So the
GEMS
letter is 871.
Is it dated 3rd April 2019?
That's page
That's it.
871.
871, okay. So this is a letter written to a service provider in which you inform the service provider that you will no longer be paying the service provider directly, that any members who go to the service provider must pay upfront, and that you will reimburse them, right? And you say that all of this, and there's a long letter, and you say the decision is made on the basis of an outcome of an investigation that found that members disputed the services from the service provider and no x-rays were taken to confirm blah, blah, blah. And then you say, kindly note the outcome of the investigation will result in recovery of irregular claims and other things, criminal investigations, and so on. So this is also a variation on what you've explained would be the process. The process that you explained earlier would be that you look at specific claims, that you would identify anomalies, you would put that to the service provider, and there would be an engagement with the service provider, and then there would be a recovery of the amount which ultimately you determine is the amount that's owing to the scheme. I just want to understand then how that works. How do you explain this letter?
All right. Remember, this letter is right at the end where a decision has been made by the Claims Risk Subforum.
So this is not the first time the service provider is receiving a letter?
No. There would have been an investigation that would have been conducted. There would have been engagement with the service provider. So this letter is just a notification just to inform the provider of the decision of the Claim Risk Subforum. And then they would have also, part of this thing would have indicated the claims that are in questions, especially the ones where we say no x-rays were taken to confirm the need for filling on members and the member disputes. So the provider would have had all this information. So there would have been an initial step before this.
Why are they still talking about investigating him at page 872? Because it says, kindly note the following, The outcome of the investigation will result in recovery of irregular claims. It looks like what has happened here is that the Metropolitan has contacted members and then got some information about x-rays. It's only now that they will be speaking to the doctor.
That's not a fact.
Do you agree or do you disagree?
No, I disagree with
do you
that. yeah.
disagree?
Yes.
Then what are they still investigating
Okay.
when they say the outcome of the investigation will result in recovery of irregular claims?
So, what is part of the sanction document? I said that sub-forum will also, when the recommendations are made by Metropolitan, they can include to say, report this matter for further investigation. Remember, they are responsible for a desktop investigation that they would have done. So in this instance, we can appoint field investigation who will also further validate and test if there's criminality. I've indicated it earlier, to test if whether there was any criminality on the part of the service provider. And from that, we'll get a report, and then we will either sanction and say, we approve this thing, there was criminality on the part of the service provider, please go and open a criminal case. So added to this, we have 5 forensic...
Sorry, the investigation here is not just to investigate whether there was criminality. It was for the purposes of recovery of irregular claims.
Yeah. No, this is what I'm saying, to say that, and may lead to criminal charges. I think that's what we're saying.
I think this is the first part that is a cause for concern. I mean, the impression it creates is that you are still going to investigate the practitioner.
Yes.
But your point is that the practitioner has already been investigated and consulted. The only problem is that we don't have any information, but this was given to you to respond to.
And this letter says nothing of that. This letter doesn't refer at all to any previous contact, engagement, or investigation.
Okay.
It simply says, in fact, it starts off saying, several challenges continue to face the medical schemes industry, including non-compliance with basic scheme rules and so on. In order to better manage this risk, GEMS, following a non-discriminatory zero-tolerance approach to non-compliance, has taken the initiative to implement various systems and mechanisms. And then after that, it goes on to say, you will now be placed, you will no longer, your patients basically now must pay out of pocket and then get reimbursed.
Chair, we are willing to share the specific of this case in form of a case report and all the information. Maybe also one has to accept the context in which this letter was submitted to the panel. Even if you can look, I mean, this was a complaint where the service provider, if you look at page 870, it was just an email to say James has blacklisted me. But the provider has not indicated to say what process has unfolded. If we are afforded an opportunity, as we have done previously, we would like to come back and give you all the necessary information relating to this matter.
This was provided to you last year.
Chair, if maybe then we can go to specific of what our response is.
You want more time?
No, we don't need more time. We can go back to the bundle where we responded to these matters, and I think that will be included in our response. We have fully responded on this, and hence I said we can look at the specific of this case and maybe have in regard to what was our response there. And maybe I think
I mean, your general evidence is that your typical practice is that once you pick an anomaly, you contact the medical practitioner. A sanction is always imposed after you've consulted.
That's correct.
And that a letter that suggests that you didn't do that would be a deviation from your standard practice.
That's correct.
Yes, all right. And you will give us proof to rebut what appears prima facie from this letter.
Yes, we have the information. I think it is contained in our response to this allegation. I'm happy.
That's fine. If you just refer us to the page references where we can find it, that would be sufficient.
That will, all right. Thank you, Chair.
All right. I think let's proceed.
I still was not getting an answer to my question. If I can just continue with Ms. Gita, is that right? Can I just ask you, what I'm trying to understand is how the amounts recovered are calculated in detail. And I wanted to then perhaps to assist in answering the question, take you to GEMS' SOP at page 603 of the GEMS bundle.
have that.
So if you go down to paragraph 4, that sets out the recovery framework. And the second paragraph, second sentence says, and now it's referring to meetings between providers and I don't actually know if it's a mix of GEMS and Metropolitan or just GEMS, but it says all meetings must be minuted and the calculation of the amount owed by the service provider or member must be documented and provided to the scheme for approval. The calculation must be made available to the service provider to confirm that the service provider is aware of the repayment amount per month. The calculations will be made in line with the model approved by the scheme. What is this model?
You answer on the AOD. Sorry, so that's in terms of once there is an AOD process.
Correct.
In place.
Correct.
And the negotiation, so not the calculation of the amount, but that, my understanding is that refers to how it will be repaid. Model, not actually the calculation of the amount that is to be repaid in total.
But it says the calculations will be made in line with the model. I'm not sure how else to interpret that.
Okay.
So we can clarify that, yeah.
Yes, please.
Yeah,
No. You don't know now?
No, actually I do know, but and I think I'm ready to respond to it. I mean, if I direct you further down to what you have just read.
See, there are various techniques using the data, I imagine. This is what I'm trying to get to. There are various techniques using the data, and then there's actual losses experienced by the scheme. Which one is it? Is it techniques using the data?
It's actual loss.
So, how do you determine the actual loss over those 2-year periods? Do you go through claim by claim by claim?
So
claim line by claim line.
claim line by claim line. And you remember a claim line for a member, let's say a member, there might be various or different codes. And maybe I can give you, I'm not clinical, but dental, let's say dental claim. Certain tariffs that were not supposed to be
all I'm
charged
checking
from-
is you can assure me that you only recover losses that are experienced by the scheme.
That's correct, that's correct.
Thank you.
Thank you. I think let's proceed. We will limit our interventions at this stage.
The other question I'll just address is the question around how the mental health facility in KZN was identified, that we referred to earlier with regard to the reversals. That was identified by one of James's SPNs, which identified a trend in the facility of admitting James patients for James members for 21 days at a time and depleting benefits of approximately, it would vary, but approximately 200,000 Rand at a time per stay. And they passed that on to MH, to the Health Investigations Unit, to investigate further. And now I just want to take you through a few examples of investigations, just very briefly, and a high-level overview, so not going into too much detail. The first example primarily relates to 36 pharmacy practices. Initially, complaints were received by members informing the scheme that claims had been submitted against their benefits, but no services had been rendered, and they or they didn't know of the practice. During our investigations, we identified various anomalies in the claims profiles of these pharmacies, including acute medication that had been claimed on children that were too young to have received the dosages that were claimed. Also, the lack of corresponding consultation claims by the referral providers who had supposedly issued the prescriptions that the pharmacy was claiming against. And some of these referral providers had also been investigated and sanctioned by GEMS due to significant irregularities. Thereafter, we identified several linked practices to these pharmacies, other pharmacies that were registered and opened and claimed on, utilizing these practices to circumvent the sanctions that GEMS had imposed on those initial pharmacies. The next slide is just a geographical representation of all the pharmacies that were linked to these initial investigations. Our second example relates to primarily 66 psychology practices. The initial complaint indicated that, so it was a complainant that reported a tip-off and indicated that a healthcare provider was submitting private claims whilst employed full-time by the Durban University of Technology. During our investigation, we discovered that the psychologist was enticing newly qualified psychologists with a monthly salary to enter his employ. And then in turn, he would open a new practice under then the new psychologist's names, often unbeknownst to them, and submit claims on those practice numbers for services that were not rendered. The psychologist and his accomplice, which was a general practitioner, were arrested in December 2017, and they were released on bail. The case is still on the court roll. Subsequently, further practices opened, which we identified as linked to the psychologist, which we believe were opened and claimed through in order to circumvent the sanctions that were imposed on the initial practices. So the next slide is just an article in the media around that. We've blocked out the names just to protect the identities of the service providers. And this slide is just an illustration of all the practices that are linked to that psychologist, the more immediate links, and how they are linked. So, by...
It's illegible, this slide.
Yes.
Maybe that's the intention.
we have crossed out all the practice
Make it
names
unreadable.
to protect the identity, and it's more just to illustrate the extent of the problem. The third example relates to a private hospital. Initially, the scheme had concerns Initially, the review of the hospital claims indicated an unusually low cost for pathology and radiology compared to the admissions in the hospital. Additionally, we received an anonymous tip-off that indicated that there were unnecessary admissions or the length of stay was extended unnecessarily. On review of the claims, a number of identified. These include that the owner of the private hospital, who was a GP, was the top admitting provider. There were irregular claims identified in the admitting provider's own practice. A dietitian was submitting claims on the in-hospital patients without a referral doctor. And their facility was admitting more patients than they were licensed in terms of bed capacity. Okay. Our fourth example relates to a registered nursing practice. Initially, the scheme had concerns around the qualifications required to do home dialysis. There is a nephrology certificate that is available for nurses, an additional qualification. And there were also concerns around the dialysis equipment that was used and the servicing and calibration thereof, especially considering the amount of travel that was involved. And the provider initially claimed 1,500 Rand for equipment hire per session of dialysis, and this was in addition with the prescribed tariff for home dialysis, which is 901 Rand and 70 cents. Within a short space of time, the charges on the claims escalated on the equipment hire, and during October 2018 to February 2019, equipment hire escalated to between 70,000 and 88,500 Rand per session. Sums of 70,000 Rand and 83,000 Rand were sometimes claimed more than once per day. So, as an example, on the 27th of October 2018, GEMS received 3 claims for 3 members for services on the same day for 70,000 rand each for equipment hire, totaling 210,000 rand. for
And what is the
services.
benefit that GEMS provides in relation to that service? So what would the member have been entitled to? This would have been outside of what the member would have been entitled to.
Yes.
So GEMS would not have paid this in any event, isn't that so?
Yeah. So we'll get to, so some claims were inadvertently paid initially because of the equipment hire is a broad code that doesn't only apply to dialysis machines, it applies to any equipment that a nurse may hire out. So the limits on that code, weren't restricted. The limits in terms of I'll get to the tariff and the rules around it and that govern that tariff code.
That govern this example in particular?
Exactly. And this obviously needs to be, so the claims for the charge for the equipment hire needs to be viewed in the context of the replacement cost of the dialysis equipment, and that's because it's in terms of the tariff, of the actual tariff and the rules around that tariff. But the estimated replacement cost of the dialysis machine was 160,000 rand. So in one day, the provider claimed 210,000 rand, and the replacement cost of a new machine would have been approximately 160,000 rand. So now I'll get to so tariff code 302 is in the nurses billing tariff guide is for equipment hire, and it's governed by GEMS Rule 06. And the Rule 06 states that equipment hire should be 1% of the current replacement value of the equipment per day, that the total charge should not exceed 50% of the replacement value, that the description of the equipment must be supplied. The payment is at the discretion of GEMS and should be considered in instances where cost savings can be achieved. And then it is also by prior arrangement with the scheme. During 13 days between the 3rd and the 15th of February 2019, the provider claimed 503,700 rand for home dialysis and equipment hire for one GEMS member. During 10 days from the 4th to the 13th of February 2019, the provider claimed 406,750 rand for home dialysis and equipment hire for another GEMS member. Due to the inflated and excessive claims, GEMS Risk Claims Subforum made a decision to terminate direct payment to the provider and demanded repayment of the excessive amounts that were inadvertently paid, and that has not been repaid as yet. There has been a history of litigation. So the provider made 3 applications to the Competition Tribunal. The first was withdrawn after a meeting with GEMS and agreement to resolve the issue. The second application was abandoned to be refiled, and the third application was then dismissed. There was also an urgent application to the Constitutional Court, which was dismissed, and an urgent application to the Western Cape High Court, which was also dismissed with costs. The last example is a psychology practice. The practice was investigated and sanctioned, so direct payment was terminated in 2012. Member refunds continued to, members kept claiming member refunds. And a review of the member refunds revealed irregular claims. It was a single provider practice, so only one psychologist working at the practice, and the practice was claiming more than 24 hours in consultations per day, on a day. during the period 1 January 2013 to the 31st of December 2017, a total of just over 25 million rand was paid by GEMS in member refunds. 96% of that, which was about 24 million rand, was for ICD 10 code F32.2, which is severe depressive episode without psychotic symptoms. A sample of member profiles were responded to the CMS. GEMS responded to CMS on a sample of them, and it revealed excessive charging of the ICD-10 code F32.2.
So part of the reason I was asking at the beginning, what exactly is the internal process to implement Regulation 5? Is precisely this, because, I mean, to pay 25 million rands over 5 years, and then on the 6th year to say, I want it back. I mean, just, you know, from the doctor's point of view, I mean, just like, makes no sense, because why did you pay it in the first place? Because you should have stopped it at the Regulation 5 stage.
Can I'm not, so I'm not a legal expert, but just in terms of member refunds, we need to consider that we may get a member, and in terms of identifying the anomaly on how many hours per day the member is consulting. One member may submit a refund a week after the actual service was rendered, and others may wait 3 months. So only after 3 months may we get an idea of how many consultations were supposedly performed on that day.
This covers a period of 4 years.
Yes, yes.
This is not just months.
No, sure.
I mean, that's exactly the point, is, you know, you've got to have a mechanism that is robust to implement Regulation 5. That's what the Act gives you the power to do. You can't just let money go out and then say, I want it back after you've paid it.
I can also ask a further question on this one, and I'm assuming you're close to the details if you're presenting it, but the allegation was that the practitioner was working more than 24 hours a day, but that allegation didn't prove to be correct. And in fact, something else.
That was a finding.
I thought the allegation was the practitioner worked more than 24 hours per day, and the finding was that he or she was charging for severe depressive episodes excessively.
Yes. The finding was that the practitioner was consulting or purportedly consulting for more than 24 hours a day. So the provider wasn't claiming, but via the members. The members were claiming a member refund. But we did confirm that that was correct. Not on every day, but there were days where.
But the 25 million is made up of the use of the F32 code.
Yes. Yes.
Yeah.
Yes.
Or the 24 of the 25. Yeah.
Yes, correct. And then, so this is an example.
Not on the hours.
That's correct. Yes.
So what happened to the excessive hours? Was that the 1 million?
No. No. So we didn't quantify. We haven't in here quantified the excessive hours. So we're saying there were excessive hours, but in terms of these quantifications, the total we paid for that period of 5 years, I think it is 25 million. Of that, 24 million related to the ICD code for severe depressive
I think the point really we're trying to test here is that, you know, so somebody comes with a big allegation that there's a doctor that is working more than 24 hours. I mean, I think this is the third time I've heard this, just on the GEMS presentation. So we would then expect, well, where is the money associated with the excessive 24 hours? We'll look at the detail. No, there's no money. This is just the incorrect or the abuse of a code. It's not fraud, it's just the abuse of a code. So that is the point we are trying to understand, is that what you've moved from the allegation to the finding, they do not mix. Because we see, if you look at bullet number 2, 24 million of the 25 is because of the wrong usage of the code. But what you accused him of at the beginning is that you don't sleep, because you're always working.
Yes.
So that's really the inconsistency that's being brought to your attention. If you have an explanation, you can give it. If not, fine.
So I think the initial identified issue was around the time, but during the investigation, we identified this issue around the ICB.
Sure, but then
codes.
what happened to the issue of the time? And did
Yes.
you recover? If you found, if it was true, and if
Yes.
it was in fact the case,
So,
then
Chair,
did
with-
you recover the funds?
So, Chair, with your permission, yes, maybe also if we look at the modus operandi, I think what we're trying to demonstrate here is the refund scam. The service provider was investigated. We terminated direct payment, and thereafter, because we allow members to submit claims if they pay cash and request a refund. So in this instance, is that the service provider continued with his claiming profile, but in this instance, provided fictitious receipt that these members have actually paid 10,000 rands of a consultation. So we're just demonstrating a refund scam in this respect. So members, they have other providers that they could go to, but they elected the service provider and they were paying 10,000 rand for that consultation and they were requesting refunds. So when we did an analysis, and this is one of the reports that we actually, I would say the administrator developed to look at member refunds, because this was one of the cases that we're seeing, that as much as you've put restriction and you wanted to mitigate the risk of fraud, waste and abuse, the provider found a way to collude with members in terms of getting this thing. And this is not an isolated case, so we have more examples of member refund schemes. So this is what we were trying to demonstrate in this respect.
You've provided, this is the fifth example now, you've gone through all these examples of quite startling cases of fraud, actually. There's nothing less than that you are describing here. Is this typical of all of your FWA cases? Is that why you're giving us these examples? Is this typically what the whole portfolio of FWA investigations comprises?
That is correct. And I think the slides that I've previously indicated to say we had to develop velocity report, early warning report, link practice report, and also member refund. And these are typical cases that actually we are seeing, and this is our experience from a GEMS perspective, to say we have an issue with a syndicated type of fraud FWA, and specific one or two individuals who would mainly commit this thing. So this is just a demonstration, so one of those cases. And I must indicate that also this matter is with the Commercial Crime Unit.
Permission. This example 5 may also give another context to why certain things may have happened. And one you have referred to is the fact that 2013 to 2017 you pay, then suddenly you say, no, maybe we're not supposed to have paid. There is a period also in the healthcare and fire industry where the Regulation 8 was a big issue, and it relates to the issue of payment of PMBs at cost. And at various times, as the whole issue of PMBs was evolving, within our environment, we can actually demonstrate over a period where PMBs constituted a certain percentage on the lower side, but over a period of 5 to 10 years, PMB claims went as far as 60% to 70% of what you call. And the opportunity that this PMB Regulation 8 and interpretation that it presented for those who had an inclination to be fraudulent in their claiming is demonstrated here with this code F32, which is a PMB. So at any point in time, maybe, and I am saying maybe, Chair here, it's not necessarily a fact, but I'm trying to put a context to what may have happened, is where you find that realizing that it's a PMB, it is within the scope of practice, I will claim for it, and the medical aids are forced to pay. And we were also, there was a period where the regulator said it's It's, in terms of Regulation 8, you have to pay at cost. And there is some of these claims which increase the PMB element, but they could have been fraudulent. Now, then lastly, why would we have been paying? We pay because we are trying to comply with the Act, and then our systems then evolve to realize that, no, maybe we are paying too much, and then that's hence the clawback that happens some years down the line. And that's a plausible explanation for why certain things could have happened during that period.
I also ask you something, I mean, given your seniority in the organization. I mean, if we accept two premises, the first one being that the names we've looked at from 2018 and 2019 are predominantly black, whether it's 90% or 95%, it doesn't matter. Let's say they're predominantly black. We also accept what has now also been said, that this is the typical practice. In other words, the 5 examples we have demonstrate or illustrate the kind of practices. Will it be James's conclusion or contention that the 99%, 90%, let's say, of black doctors are fraudulent?
That wouldn't be the conclusion, Chair. We are going to address this later. However, maybe I'll answer. What we realize in this whole allegation is that, and I think you did ask that question when you were saying you know the race. You can't say you don't know that the doctors are. We were asking my colleague that earlier on. But that was not the trigger.
He accepts it, but I'm just saying on the assumption that he is right in accepting my proposition that by looking at the surname, you know the race. And then he makes another point, which is that these 5 examples they've given us are illustrative of the bigger group. It seems to me then that James must be contending that that 90%, which is black, is committing fraud, and that's just a representation of the facts. I mean, why are you reluctant to accept that?
No, Chair,
Let me just tell you, it doesn't matter whether that was a trigger or not. The point is the outcome.
Well, I thought the trigger is important because the trigger says, and your bias is to investigate this type of, and we're using race here, black doctors.
No, you are right there. I mean, you are right on your point about the importance of the trigger. I mean, we're not disputing that. I think the point we're making now is that if you forget about the trigger, you just look at the outcomes. I mean, it has to be your contention, and that's what I'm putting to you, given your seniority in the organization. It has to be James's contention that if the 2 premises are right, that we've got 90% black doctors that have been identified for recoveries, and we have a contention that says that 5 example is representative of the whole, that it must be James's contention that black and Indian doctors are fraudulent.
Chair, if you will allow me,
And worse than that, actually, black and Indian doctors from KZN, because your colleague specifically said this is located in KZN. Well, not located, but there is a specific target about KZN.
Chair, I respect that you have introduced this now. I was actually going to address this in my conclusion. If you give me that permission in my conclusion.
No, feel free, and you might also have time to reflect on it and then refine your answer. That's fine. So be free to do that.
Okay, thanks.
I just thought I should use the chance now that you were on the floor. All right, let's do the following. Are you finished with your presentation? Because I want to give you a chance to finish.
Yes, I am finished. I was just going to conclude around
Yes, please conclude.
that these examples are just of cases where we have used Section 59. And, you know, it's a tool that we've needed to use in order to try and mitigate the risk to the members of the scheme.
Thank you very much. Look, we are in trouble with time. We just need to find a way of managing it. We are forced to break now. I mean, otherwise, I think most of us are no longer concentrating for reasons of nature. Can we take 30 minutes, no more than 30 minutes? How many presenters do you still have?
We basically have a short presentation, just 5 minutes or so by one, and then the rest it's 3.
3.
It
will be the legal from
it's legal, expert, and then closing remarks.
Okay, so it's the legal and the expert. So it's 2 substantive presentations.
That's right.
Okay, now I think we'll probably manage. So let's aim then. We thought we would finish at 4, but I think let's just adjust to finish at 5, if everyone is happy with that. All right, thank you. We will adjourn then for 30 minutes. I understand we have a short 5-minute presentation and thereafter followed by 2 longer presentations. So who is doing the short 5-minute presentation? Oh, it fell away. I see. So, okay, that's good. So it's Mr. Toy.
Okay, when the panel sent us the letter setting out the dates, etc., they gave us 4 questions to answer, which included the scheme's interpretation of Section 59.2 and 59.3, and then also our interpretation of Regulation 5 and 6. So we did in our full submission, which you guys have read, discuss consent and coding and Audi as well. I don't know whether you want me to go over it, or do you want to just ask me some questions from the submission if necessary? Then I'll stick to 59 and Regulation 5 and 6.
Thank you.
Okay. So I'm also referring to the bundle quite a lot. My slides are limited. Okay. Okay, so as a point of departure, we just wanted to, and the panel is aware, they've also indicated that they are aware, it is the ultimate function of the Board of Trustees to protect its members. And in the Arona healthcare matter, the court also said members are particularly vulnerable. And if their benefits are depleted or abused for some other reason, they can't have access to their benefits and they lose money because money comes off their salary and it goes who knows where. So we also then discuss briefly we indicate firstly that I'm not going to go into that the rules are binding, which the panel is also aware of. So it's binding on the scheme, the member, and any person claiming under that rules, which in our view includes the service provider. So we also discuss briefly the relationship between the scheme and its members. We have some case law indicating that the definition of a business of a medical scheme posits 2 contracting parties in a quid pro quo relationship, the scheme and its member. So we just try to show here that there's no actual contractual relationship apart from a DSP agreement between the scheme and the provider per se. I'm going to skip over that. That's just background. Okay, so now I'm going to come to Regulation 5 and 6 and 59.2. So I unpacked 59.2 to some extent, and I'll somewhat speak to that and flow into Regulation 5 and 6. These are the rules. Okay, I'll get to them. Apologies, my slideshow is a little bit different than my actual presentation. But if you follow the actual submissions on page 30, that's currently where I am. So specifically with Section 59.2. So it says, a medical scheme shall, in the case where an account has been rendered subject to the provisions of this Act and the scheme rules, pay to a member or a service provider a benefit paying within 30 days. So we are of the view, we've heard a lot of evidence from providers, and there were also questions put to various presenters as to why don't we pick up the FWA and or adjudicate claims in terms of Regulation 5 and 6, as opposed to going later on and trying to claw back and all of those things. So what we're saying is an account, and for purposes of Section 59.2, which speaks then to Regulation 5, the account that has been rendered. So we're of the view that Regulation 5 is merely tick box. Is there a number, is there a name, is there all of those things that are required, ICD-10 code, etc. So that is almost, for lack of a better word, automatically done. There's a system, check, 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 it's not there. So then ICD-10 code is not there, you'll get a rejection message saying no ICD-10 code, which takes you into Regulation 6.
But if there is an ICD-10 code but an incorrect one, what would happen?
In such an instance, you won't necessarily pick it up, unless it's out of discipline. But we can't, as a scheme, on a checklist basis, pick up something as small as that. That's why we also mentioned our claims earlier. If we now receive 200,000 rand, 200,000 claims a day, to pick those little nuances up is not possible. So that is why we say there should be an ICD-10 code. Like the Regulation 5 doesn't say it has to be correct. It just says it should be there. So if it's not there, we reject. Error message. Then we move into 6. So 6 will then, you now have 60 days to come back, give us the correct ICD-10 code, and we can respond in 30 days if we want to. So we're of the view, and we've been implementing it in such a manner, that you cannot detect FWA in the Regulation 5 and 6 process. Fraud, for example, is an intentional misrepresentation. A system cannot pick it up. If you want to adjudicate physically, humanly, 200,000 claims per day, that's not possible unless you appoint thousands of people. Even waste and abuse. So you're not able in 30 days to necessarily see that this specific provider in this specific discipline is currently submitting too much of this code. You only pick it up over a period of time. And then also, even if you now do, you see this provider looks a little strange, there's too many, as we had before, severe depressive episodes without psychotic indicators. Now you reject, but you can't reject on that basis in terms of 5. So what do you tell the provider? I'm rejecting because if you look at all these requirements, there's nothing there you can reject on that basis. And as I said, you only pick it up later. And we're of the view that, let's say, we are supposed to adjudicate all claims, including fraudulent claims, wasteful claims, abusive claims, within that 30-day period. What would the purpose of 59.3 be? Why would it be necessary to have a clawback provision if we are required to do it in terms of 5 and 6, out and out, full blown? So that is our interpretation of Regulation 5 and 6. When I want to go back to 59.2, where we also have a lot of case law in which it's also very contentious, especially when it comes to termination of direct payment. That it can pay the member or the provider, which is highly contentious, and it was the subject of case law. And
what is the reason why you say Regulation 6 should not be used for fraudulent transactions? Is it simply because the time period is too short?
Yes, well, it says 30 days. You must pick up, the scheme must basically pick up the error in 30 days. And then give it back to the provider and say, fix within 60. So if we receive, as I said, 200,000, we receive, 8 million claims a month. So in 30 days to pick up fraud, waste, and abuse, or fraud specifically, I would submit it is not possible unless you have.
I understand. So the point is that because the period is too short and the claims are too large, therefore Regulation 6 does not apply to fraudulent claims or
Fraud, waste, or abuse, yes.
No, I understand, because there are many instances where a law prescribes something, but pragmatically it's difficult to implement unless you readjust your system so that it picks up fraud at the stage of adjudication.
Yes.
So I'm trying to follow why you say it doesn't apply, simply because the period is too short and the claim volume is large.
Yes.
How would Regulation 6.4 then apply? So Regulation 6.4 anticipates a situation where the scheme cannot respond within 30 days.
And it puts the onus on the scheme.
Yes.
Yeah. So that is true. It does put the onus on the scheme. That's why we go to the provider and we quantify claims and we go to them and say, XYZ, please look at these, and we engage them. But then while we do that, And the onus is on us to say which claims are irregular and which is not. We still implement 59.2, the or. We still terminate because we have to stop the bleed. If you looked at those examples, I mean, we paid a hospital with 9 beds, by the way, 20 million rand in 18 months. 9 beds. If we don't plug the hole as soon as we pick it up.
So that's different. That's where you don't pay future invoices, but the clawback.
Our clawbacks are not as broad as some of the other medical schemes. Our clawbacks are usually either by discussion with the provider, where they admit to some coding errors and they either resubmit their claims, or they say, well, I do not have my claims anymore, but I think this was irregular, or where we have a modify example. We don't blanket just say, this was irregular, we're just doing a clawback. So, yeah, does that answer your question?
So you'd comply with Regulation 6.4 then?
Yes, we try to. Okay, so may I proceed to the termination of direct payment issue, which is also the member or provider. There's been a lot of debate, and it goes as far back as what I could see, what we have, to 2008, where this debate was raised for the first time. So I'm running through these matters very quickly. So we had Twala versus all care administrators. Judge Prinsloo held that the scheme are by statute authorized to decide whether to pay the doctor or patient directly in terms of the scheme rules. So our scheme rule says, if I refer to Rule 15.6, page 32, the scheme shall suspend payment when there is an investigation. The scheme may, in accordance with 17.5, decide to, the scheme has the right, this is now 17.5, to pay any benefit directly to a member concerned. So the all care administrator's case says, yes, we have the choice as long as they're in terms of the rules. Then we have the case of Tshwane Pharmacy with versus GEMS, coincidentally, where Judge Southwood said, subsection does not create an obligation for the medical scheme to pay the supplier. It clearly provides that payment is subject to the rules of the medical scheme, which state unambiguously that the respondent has the right to pay either the member or the supplier. Council for Medical Schemes, which was a matter before the Appeals Board, said without a specific contract, there's no debt owing to the service provider. Oh, you're going to drive for me. Sorry. Then we have the matter of Bumji. Sorry for regurgitate, but it's basically the same thing all the time. So Dr. Bumji was not entitled to insist that the scheme continue supporting his practice by accepting his claims directly. It was within their discretion to do so or not. Even if he enjoyed such a right, Dr. Bumji claimed and said, but you've been doing it for so many years. That's a tacit agreement. So the court said, even if you enjoyed these alleged tacit agreement, basically, such a right clearly did not extend in perpetuity and was capable of being terminated by the scheme. Then the matter of Margate Clinic. I have 2 more, and then I'm going to get to the contentious Sechaba matter. Margate Clinic. It is true that unless and until the service provider has in fact been paid, there is an amount owing to the service provider, but that amount is owed by the member, not the scheme. Then we have Bain and others. Payments which the medical aid was and is obliged to make to their member constitute the discharge by the medical aid of contractual obligations flowing from the contract concluded between it and its member. As such, they constitute res inter alios acta, and the health service provider cannot claim the benefit from them. Now, Sechaba Medical Solutions. So this is quoted by most societies and doctors when we decide to terminate direct payment. So Judge Willis in the SCA did say, yes, I am of the view that, okay, let me just give some factual background. This was a liquidation application. The liquidator accepted the claims from Mediclinic and said, sure, I will pay them. Then the scheme came and said, no, you can't do that. You must refuse to pay the claims and the hospital must go get it from the member. But in this case, there was pre-authorization. So there existed a contract between the scheme and the provider. So there's a nuance there. And then also, the validity of the claims was not in dispute at all. So it was accepted that they are valid. So Judge Willis ultimately said that if the member gives you the consent, you should pay the provider. And if there's pre-authorization, there is a contract. And just on that, he said just on that, the scheme would be obliged to pay. So we distinguish Sachaba from all the other matters previously. I have to mention that this judgment did not overturn any of the other judgments. So we say we didn't pre-authorize, firstly, when it comes to these termination of direct payment claims. We do not pre-authorize, so we don't have a contract with the provider. And we dispute the validity of the service. That's why we terminate you. We're saying, listen, we're not sure. So go get the money from, render the service to the member by all means. We will reimburse you. So we're of the view, and we've been applying it as such, that there's that nuance. This was argued before, it was James versus Refillware as recently as 2019, where we submitted the exact same argument I'm submitting now. It was before the appeals board, and they said it is common practice that members pay the providers and then submit their claims to the scheme to reimburse them. And they ultimately held in our favor there. So that's our view on
Is there anything about the fact that GEMS is a government medical scheme?
So GEMS, just because they're the government employees medical scheme, does not make them a state entity. They're not in Schedule 3 of the PFMA, nor do they exercise a public power. This is actually a matter that will be argued in front of the Supreme Court of Appeal. So we're
stakeholder engagement is a very big part. Submissions. If we knew that it's such an important part, we would have demonstrated that we have a plan of engagements with the doctors, the healthcare providers, where some of the things, we discuss those things that they put on the table. And at the beginning, you did ask us, why haven't you addressed this thing about racial profiling? And the answer was, we engage so much. They never put it on the table as the healthcare providers that we had. We would have addressed it. So it was introduced only because it became a matter of public discourse. So that's...
What I'm interested in, and you can address it later when you make a supplementary submission, is around the fair administration of the powers of the scheme under Section 59. There is a lot of talk about, legalese. The fact of the matter is that we've now sat here for more than 8 months. We've listened to people breaking down because the way that this Section 59 is implemented is a blunt instrument. The impact it has on families is enormous. If you are expecting a scheme that cares, it should be GEMS. And so to now hear exactly the same sort of thing that we've heard before, just sits uncomfortably with me. That's why I'm putting it to the leadership to consider it. You may say I'm wrong, fine, I'll accept that.
That is noted, Chair.
In that supplementary submission, if you could just expand, then your lawyer has indicated that Regulation 6 is applied, 6.4 in particular, which requires the scheme to prove the amount that's owing. So if you could include how you do that, what is the process, the administratively fair process you use in order to prove your claim back from the service provider?
Okay.
An interrogation of how you can improve. I've read your submission. I've read even your recommendations. Even there, I get disappointed because I don't see anything tangible that says there is going to be a massive behavioral change. The one area of improvement that does not require any more monies to be spent is setting out an administrative protocol on how to implement Section 59.3, which is linked to whether you have duties under PAJA or you don't have duties under PAJA. It's irrelevant if you're a government scheme because you can design a fair process. You've heard about these complaints since 2013, but it looks like there's just been no movement. The focus has been how do we save money.
Thank you, Chair. I think the message is very clear. It's almost like when you talk about ethics, there's the law, but there's something about the ethics. And I think the message is very clear. It's something that we are going to be looking into.
Thank you, Mr. Toy. Do you still have any? We've read your submission.
I just want to add on what they said then regarding your question that you posed on, don't we have something that's setting out our process and adjudication, etc., which I don't want to speak about Discovery or MedScheme because I don't know their processes, which maybe can set us apart from the rest. So we have with MH, there's requirements. You must engage the provider on this level. Then if he comes back to you, you must look into it. Then you must engage him again. And you must engage him again, you can come back. Then it goes to our sub-forum. And then we fight about it. And we say, we're not sure. Go back to the provider. So we give them a lot of opportunities to respond and put their case. We meet with them. And, they ventilate what they have. We have frank discussions. We say they have the floor. And on a lot of instances, we come to, okay, we hear what you're saying. You're right. We don't terminate. So we do attempt to a great extent to give them sufficient audi and to not make arbitrary decisions. That's why we also don't have 1 or 2 people making those decisions. We have 10. So, yeah, it's just I know it's not a perfect process, not necessarily, and it's changing. Like we have a new fraud, waste, and abuse policy, which was assented to in August 2019. So we are growing as we go. But one thing that is certain is our engagement with the societies and the providers. Everybody's got Ishmael's number.
Can you just tell me, we were told that someone is going to respond specifically to the complaint of Ndubane. Yes, Dr. Ndubane.
Ishmael can quickly address that.
And I've been looking at your submission and I can't find where exactly the response is.
something. Or who knows?
Thank you, Chair. If I may direct the panel to our submissions, I think it's page 309. If you have located it, I will proceed accordingly.
So these are just according to practice. Oh, yes, there.
A further investigation was conducted into the second practice, 124, for the period 1 June 2016 to 30 October 2018. Findings of the first practice. On 3rd of July 2015, a retrospective review letter was sent to the provider requesting the practice detail and information was not forthcoming. From 4th July to February 2016, the complainant could not be reached for comment, so the length of the investigation, despite numerous attempts, and also failed to respond to the concern raised by the James in writing. In the finding of the investigation, it was noted that the complainant performed large restoration on teeth without performing X-ray. A dental advisor who is a qualified dentist was consulted and advised that it is recommended an X-ray be performed when performing this last restoration. The complainant further routinely submitted the exact same treatment plan for the different patients on different days, and a total of 289,000 was paid in respect of this claim. And we sought input from our dental advisor with regard to the above observation, who confirmed the pattern anomalous. We have tabled the result to demonstrate such observation, and we give the truth. But what is important is on paragraph 13. The investigation was presented to the Claim Reserve Forum, which I have previously alluded to, on 25 February 2016, during which the Reserve Forum requested that the complainant's claims be placed on hold. And this was done on 2nd of March, until the complainant responded to James. It was requested that this case be referred to field investigation to interview members for further information. A letter of suspension was sent to the complainant via registered post 31st March 2016 to inform him of James' decision. You must remember he was not cooperating. After consultation with members, the field work team confirmed the following anomalies. Members received gold inlays, which is an exclusion to the scheme. James should recover 459,749. They would have received affidavits from these members. We have the case report. On the 21st July, James received information from the provider, purportedly regarding the anomalies identified on one practice, which I have mentioned, and I just want to make sure that this is the one that we looked at, which did not address the anomalies identified. And the second practice, a new practice was registered in 30 June 2016. This was deemed by James as an attempt by the complainant to circumvent the sanction imposed on the first practice. During February 2018 and May 2018, 2 whistleblower reports were received wherein members disputed services on this new practice. And the dental advisor also found following additional anomalies in provider's day. The complainant performed fillings on a member in full quadrants during the same visit. Fillings will normally be placed on the left side of the mouth, thereafter the right side, and it's not common for fillings to be placed on the left and right of the mouth in one visit. The claims herein were not paid. In the case of panoramic X-ray were taken 7 February, maybe if you allow me. So during this investigation, 30 members, if I may go to section 20, and I think it's important to hear what the provider has said.
Paragraph 20.
Yeah, paragraph 20. We have confirmed, I think, paragraph 20, member one stated in writing, I received an SMS that I've consulted with the dentist on 2nd July, of which I did not. I am to reverse the claim. The claims is 2,280. The benefit paid in respect of the disputed claims was 2,122. It was paid in accordance with what was available. Second member states the following. I would like to dispute the payment from this practitioner dated 3rd June 2016, amount 2,189. Please consider the claim to be invalid as it was not authorized and no service rendered. The benefit paid in that respect was 2,189. Member 3 went on to say, on 11 June, I received an SMS about dental claims that I did not know about on the system. It appears that I have consulted and I've never consulted this doctor for dental services. I would like James, please return all the claims concerning these claims. I do not know about, and to please deal with the doctor legally. Doctor's name is, and he mentioned the person. The benefit paid in respect of those claims was 2,271. The complainant responded in November 2018 to the member dispute by stating the following. The member in question we claim or process in error as I explained to one who called and asked question or queried those claims. I explained that those claims were processed in error and that is why some of them were reversed. I just feel pity for such mistakes, so apologize for this. When I checked, I find that first, receptionist missed a number due to medical leaves, which was old and numbers not clear, and due to you, that you find a name and you don't have on the system or anything. I'm quoting this verbatim. If the committee can allow me to say, it's a long explanation, but the gist of this complaint is that all due process was held. The committee requested to say, do you do further investigation? So we have demonstrated that there was an initial investigation that was done on this matter. The provider did not respond. We contracted a field investigation panel who went and interviewed members and obtained information. And I think on the second instance, that amount where the provider now responded, because he opened a second party to circumvent the initial sanction on the first one. But behavioral pattern did not change at all. And actually, if I would like, also this one, we also followed the claim risk process. Now, I think we have also demonstrated, we never called this provider in, and our response, that GEMS has a zero tolerance for racism, and we don't tolerate bullies, so we don't bully. So that is, I think, our response, which the principal officer has done on the specific case.
Thank you. I think that was the point to whether you've responded. I mean, I think you've given a comprehensive response. Yeah. Thank you. Mr. Toy?
What I want to address is the list. And then also, then if you have any queries on consent or coding, maybe I can assist there. But otherwise, after the list, I'm done. Okay. So just as a little bit of background, as discussed previously, the preamble to the medical scheme said we must protect the interest of members. In terms of our own values, member value, integrity, and collaboration is key. So it was for the above reasons that GEMS made available the list to its members. It was to enable them to see whether if they obtain, they are allowed to obtain services from these providers. They are not prevented from doing so. It's just, if you go, you must pay up front, we will refund you. Sorry, Lynn? Oh, okay. So we didn't exclude the services from the, them from obtaining services from those providers at all. And also to ensure that our member knows, if you go there, you might be out of pocket. You might have to pay and then get your reimbursement as soon as you come and submit your claim to the scheme. So one of the reasons was that, the vulnerability of our members, because there was instances where doctors didn't tell our members, listen, I'm not on direct payment currently, and accordingly you're going to have to pay up front and then you can go claim. So they didn't tell them anything.
Are you talking about the blacklist? So, I mean, I know...
I would just call it the list.
Yeah, that's fine, but that's the list that was handed up to us by, I think it was
yes.
Dr.
Gumede.
Yes. Why does that list comprise only of black names?
We don't know.
Is that a serious answer?
At that stage, it was what it was. We didn't look, I don't know whether Dr. Stan also wants to jump in, but it was 2013. We decided our members are at risk. So we didn't say fraud and waste and abuse. We just said, this is the list of the people that are currently not being paid by GEMS directly. And that's it.
You don't know why it's only black names?
No, I don't know why.
Chair,
Do you want to say anything more on the issue of coding, if there's an
No,
aspect you
I
want to
think
cover?
coding was dealt with properly. Advocate Asim had some engagement with Ishmael and so on coding.
I thought you had two more topics. I don't want to stop you if you have not
No,
yet
no,
finished.
no. Coding was dealt with, and then consent. I heard it was raised yesterday, so I don't know whether you want me to address you on it or whether you are satisfied with the current status quo, if I can say it like that.
Well, if you can very succinctly explain what GEMS's position is on consent.
Okay, firstly, GEMS does not request confidential information in the sense that I want to read your whole file. We don't do that. We might say, listen, can we please see your diary? We just want to see what time did you spend with a member? Do you have a file? Just show me there is a file, and show me the time spent. So we don't request detailed information, but for us to validate services, we need to sometimes see records. For examples, if you're a pharmacist, they have to keep records of their scripts. So they submit the detail of the script to the scheme and claim on that script. So then we have field investigators in certain instances that go and check those scripts. So our view on that is we do not actually request. Yes, do you want to ask something?
No, I'm listening to you.
Apologies, it looked like I want to ask something. So we don't request detailed, serious, confidential information. But our view is even if in instances we have to, we are of the view that we are entitled to it. I know a lot of schemes have pushed this as well. We have our consent clause, which is the consent saying any records may be provided to our scheme. And National Health Act.
Clause is in what? Where does that clause?
It's
is
in
it
our
the
membership
rules?
application
It's in the
form.
application.
It's in the application
It's what the
form.
member signs when they become a member.
Yes. So that's the written consent. So it complies with the National Health Act, Section 14 and 15. It's a written consent that may be provided. The other acts that I also considered actually was the Mental Health Care Act, which refers to specifically mental health care, which also says if you're able to give consent, and you do, it can be provided. I also did an analysis because there was a lot of talk about the HPCSA guidelines and certain doctors that say, okay, but there is consent, but in terms of my own rules, I can't give it to you. So I don't know, I went through the ethical guidelines and it's quite contradictory in certain instances.
May I interrupt you just to ask a
Yes.
point of clarification? How do you respond to the argument that you can't give blanket consent for records which have yet to be created? So your membership application form, I presume, I'm not sure if you've supplied us with the wording, but if you haven't, please
It's
do.
in the submission.
Thank you. The counter to that is for medical records which are highly personal to the patient can't give blanket consent for a future record which is to be created. That's unethical. How do you respond to that?
I hear the argument, but where does it come from? It's not in an act.
It's a principle of informed consent.
Yes, but informed consent, I would say, applies to instances where there's a procedure that's going to be, performed on you. You're going to have an operation, they're going to remove a kidney. That's informed consent. Then you sign and say, okay, I know that is going to happen. So I don't think the two walk hand in hand necessarily. The HPC...
I have some serious concerns that the schemes are being too glib on this issue, considering the highly personal nature of the records at stake. You can hardly get more personal information, and I think we have to take these claims very, very seriously.
I take your points on that. So on that line, I again indicate that GEMS does not seek the whole full record. And also, one should bear in mind...
So just to understand that then, do you ask for records to be emailed?
Lynn?
Yes, we do. In certain
Can you turn on your mic?
Sorry. Yes, we do in certain circumstances.
And so how does that marry?
Knows this, but we must bear in mind that a lot of the clinical private information is already furnished to the scheme upon submission of the claim. It contains your ICD-10 code, which is your diagnosis, and the procedure code. So it can say this person has severe depression, and I'm treating him in a mental health care facility for the next 3 weeks. So that type of information is already with the scheme. Otherwise, the scheme can't pay. So in some instances, when we then ask for, listen, just show me your diary that this person came or this person didn't come, or just show me in your file the time you spent. I don't want to read your whole assessment. I just want to see, because they have to, in terms of the HPCSA ethical guidelines, indicate how much time they spent. So that also assists us. Basically, our submission on consent is, we're given consent by the member, and when they give it, they know what it says. They sign it. And as I said, we don't request detailed records, just to validate services, not for any other purposes. And yes, and just as an aside, I know POPI is not in effect yet, but just to see, maybe to think about where the legislator might be going whenever it comes into effect, is POPI actually says that all medical information relating to a person claiming from a medical scheme has to be provided to a medical scheme. No consent necessary. Just as a, I know it's not in effect, but yeah, just as a side note. So if I may read that specific portion of POPI, or shall we keep it aside?
How does this link up with the fact that the information is not actually requested by the scheme, it's requested by Metropolitan or Med Scheme or some other investigator? It's not as if it's requested for purposes of settling a claim, but it's requested for other purposes.
Well, it is.
It's not requested from the member, it's requested from the service provider.
Yes, but the member in the blanket consent, which is contentious, do say any provision, any record relating to my claim or so can be provided to the scheme or the administrator. Actually, the consent clause is here. You agree that the scheme and its administrator may process you and your dependents' personal information for inter alia the following purposes: to assess the process for this application, membership form, for the administration of your health plan, and then it's a long list. It basically covers, let me find the specific one on, just go there, there's another one, sorry. If I'm accepted as a member, I must both now and in future give GEMS all such information and evidence as it may require from time to time for purposes of my dependents and my membership of GEMS. For this purpose, I authorize GEMS and or its agents, which will include the administrator, to obtain from any person any information that they may require concerning me, for any purpose which directly relates to our medical scheme membership, or which is authorized in terms of the Act, the rules, or any other legislation. And then it continues, but it's the just.
Yeah, this is why I asked my question originally, because I see the clauses and I've read them. But again, if you look at 12, it says, I hereby authorize any medical doctor or other healthcare provider who's attended to me or my dependents in the past, or who will attend to me or my dependents in the future, to provide GEMS and or its agents with such information as it may require. It doesn't say anything explicit about health information or patient records. So when a member signs that, I'm not sure they're aware that they're signing authorization to allow future disclosure of their personal health records, which haven't even yet been created. I'm not sure there's awareness in the member's mind when they sign that.
Well, the awareness, I can't necessarily speak to the awareness. It is in there and they sign it. So whether they are ultimately...
Is it explained to the members when they sign?
There I
Do
see
you go
Dr.
through it in
Stan
detail?
wanting to say something there.
Chair, thanks, Chair. Through you, just to address what Advocate Williams has just alluded to in terms of what is the purpose of that broad permission that the members gives us. And Chair, you also said the information that you are requiring is not for the purpose of paying claims. It seems to be for other purposes. So that requirement is to allow us, the officers of the scheme, to do everything that is necessary for us to be able to act in the best interest of the scheme. And I know that sounds philosophical, but I'm going to explain it. All we are saying, if you take the example of where we were in 2016, in terms of our strategic focus, there are certain things we didn't do, but we immediately implemented certain things that are based on information that we could access based on these permissions that allowed us to do something that turned the scheme to become financially sustainable. So this example of what we could do because we are allowed to access all this information is basically indicating that while that permission is broad, it is intended to do good as opposed to doing malice. And I think that really is the crux of how we use that permission that the members do give us. It is just unfortunate that the way it has affected the healthcare providers, it is in a space where professional healthcare providers are they guard it very jealously, and it is understandable. Confidentiality is very important in the healthcare space. But in this instance, as a medical scheme, there are certain things we have to do on behalf of our members to ensure that we safeguard their funds.
As a doctor yourself, do you accept that a medical scheme is that you are required to hand over patient records to the medical scheme when it's requested of you?
To the extent that they are used for the proper purpose, that, like I've just explained. In fact, we share healthcare funding also in its nature. And I'm going to use a specific example of how over the years we have dealt with HIV, right? Okay. HIV, the doctor will actually initiate the treatment only after they have enrolled a member on a program. And to be able to do that, the doctor has to share information with the medical scheme. And that is in the best interest of the man. That information is not used for malicious intent. It is used to assist. So in that context, it is appropriate to share information between the doctor and, but within what is allowable from an ethical point of view.
Thank you. Mr. Toy, I take it that concludes your presentation.
Yes, unless there's any other questions.
No, thank you. So that means it's Mr. Getz and Professor Fati.
Chair, can I just state that both Mr. Craig Getz, who is an actuary, and Professor Paul Fati, who is an expert in statistics, are submitting this part of the submission as independent people. So we have asked them to independently review Dr. Kimi's report, and this is their independent submission, which they are submitting as independent. Thank you, Chair.
Thank you very much. You can decide which order you're going to follow. I'm not going to prescribe. So.
So to begin with a synopsis of the report and the way which we've understood the report, the experts have considered the proportion of black practitioners who are flagged as possibly guilty of fraud, waste and abuse, and compared that to the proportion of non-black practitioners who are flagged as possibly guilty of fraud, waste or abuse. To the extent that the proportion of black practitioners flagged as possibly guilty of fraud, waste and abuse exceeds the proportion of non-black practitioners flagged as possibly guilty of fraud, waste and abuse, the experts deem there to be racial bias. A few key points which are...
Can I just ask one question on this? Why do you
Sure.
use the phrase possibly guilty of FWA? As I understand it, the data was guilty of FWA.
So I think perhaps not to be overly legalistic, but they haven't been found to be guilty of fraud in a court of law. or
Right, okay,
to
so
that
that's the only
effect.
reason for, but we're all on the same page
Yes.
that there were
Yes.
FWA cases
Sure,
as determined
certainly.
guilty in inverted commas by GEMS.
Certainly.
Thank you.
Can you just explain what is the data that you used?
The data which we used was the same data that was used by the experts appointed by the panel. So we received the data set which they used for their analyses, and we simply used that data, nothing more,
You didn't
nothing
create
less.
your additional data or
No.
ask for additional information?
No.
All right.
So where we have referenced additional data sources, I will mention that specifically as we proceed through the presentation. So it is acknowledged in the report prepared by the experts that there is no definitive registry detailing the race of healthcare providers. So that necessitated the development of a proxy method to infer the race of healthcare providers. That method involved looking at the surname of a healthcare provider and making certain determinations based on surname. So simply put, a list of so-called black surnames was constructed. If a provider had a surname which matched that list, they were deemed to be a black provider. If the provider did not have a surname which matched that list, they were deemed to be a non-black provider. So
Can I just check something in relation to your mandate? So you weren't mandated pre the production of Dr. Kimmy's report to assess whether there was racial bias based on
No.
GEMS FWA cases.
No.
So this is a ex post facto, it's purely a critique of the Dr. Kimmy report.
Yes, exactly that.
Well, I mean, there is a further question. Did you investigate whether or not GEMS does engage in racially biased practices?
No, that was beyond our mandate. We considered the report.
You have not investigated GEMS itself.
No, we've considered the report and the merits of the report. So the robustness of the report hinges on the merits of this methodology. Simply put, if the methodology is able to identify black and non-black practitioners in an accurate and consistent fashion.
Sorry, I'm not going to stop you any further now. But if you accept that you did not investigate whether or not GEMS's practices are racially biased, you cannot actually give us a view about whether GEMS's practices are racially biased.
So I think we can give a view as to whether the report...
No, I'm not asking about the report. I'm asking about an independent view on whether GEMS's practices are racially biased.
So I think to confirm, our scope isn't to confirm whether GEMS is racially biased or not, but is to confirm whether the report has been constructed, does suggest or does prove that GEMS is racially biased or not.
That's a different question, which is what you are going to deal with. I'm just asking a different question, which is, you cannot yourselves, as the actuaries, tell us whether or not GEMS engages in racially biased practices.
Sure.
Can I just add a comment to that? Dr. Kimmy's report specifically said that there was no evidence that there was racial bias in the assessment of FW.
Extent to which the report can be trusted to draw conclusions.
No, that's fine. I appreciate that. I mean, I just wanted to know, to get the premise right. Thank you.
Okay. So as I mentioned, the robustness of the report hinges on the merits of the methodology to identify black and non-black practitioners. A quick summary of the results which were presented in the report. The report suggests that black practitioners are approximately 78% more likely to be flagged as possibly guilty of fraud, waste, and abuse than non-black practitioners, and ultimately the authors of the report use this fact to suggest that GEMS is guilty of racial bias. We are of the opinion that the report is subject to a number of significant flaws and a significant number of flaws in relation to the interpretation of results, and by implication, that conclusion cannot be drawn. I'll speak to the technical flaws in the report prepared by the experts as we perceive them, and I will speak to the matters of interpretation as well in the subsequent slides. Starting off with the technical flaws, we believe there to be 4 significant technical flaws in the report. Those relate to exposure, the inclusion of corporatized and state practices, the inclusion of group practices, and classification errors. And I'll speak to each of those in detail as we proceed. In terms of the first flaw, relating to exposure, if you can please indulge me, I'll give an illustrative example as to what we mean by exposure and why it's important and why we believe the experts that prepared the report did not sufficiently account for this. So in our illustrative example, assume that all GEMS members reside within a region where there's only reasonable access to black practitioners. In that case, we're going to see GEMS members only consulting with black practitioners, and in turn, only black practitioners will have an opportunity to perpetrate fraud, waste, and abuse simply because they're the only practitioners being consulted. The inevitable consequence of that is that only black practitioners will be flagged as possibly guilty of fraud, waste, and abuse. There will be no non-black practitioners flagged as possibly guilty of fraud, waste, and abuse because those practitioners were never consulted.
Can I just ask why, it's not clear if this is an assumption or if this is a fact, but why should we assume all of this? Why do you say black practitioners will have an opportunity to perpetrate FWA whilst non-black healthcare practitioners will not?
So this is an illustrative example to depict why it's important to account for opportunity to commit fraud, or as we've put it, exposure. So essentially what we're saying is in our example...
Have you tested this?
Yes, we have, and that's in the subsequent slides.
With the data?
What does it mean
yes.
when black healthcare practitioners have an opportunity to perpetrate fraud?
So what I mean by that, apologies.
Yeah, sorry, I've stopped. Let me give you a chance to...
Okay. So what I mean by that is if non-black practitioners are not consulted, they don't have an opportunity to commit fraud. They're not seeing the patients. Simply put, a practitioner needs to have some interaction with a patient before they can commit fraud with that patient. So this, of course, is a hypothetical example. We're certainly not suggesting for a moment that GEMS members only consult with black practitioners, but we're using this to demonstrate the point that the more black practitioners are consulted with, the more opportunity there is to commit fraud.
No, that's why my colleague's question is relevant. If you have tested the hypothesis, you see, because why should we assume that we are dealing with a scenario where black practitioners are the only ones that are accessible and therefore the only ones with the opportunity to commit fraud?
Yeah. So I guess we're just asking for a moment of latitude to make this sort of assumption to demonstrate the point. But in the subsequent slides, we actually do show the figures. And what we do show is that black practitioners are more regularly consulted or interacted with by GEMS beneficiaries. And by implication, there is more opportunity as a result. So we're using this extreme...
That's fine. I know that you want a chance to explicate your thesis. So I'm not going to ask you again until you come to that point.
Okay, thank you. Okay, so in this particular case, given that only black practitioners were consulted with, only black practitioners will be suspected of fraud, waste, and abuse. Of course, the converse of this would also be true. If there was a region where only non-black practitioners were accessible, only non-black black practitioners would be suspected of possible fraud, waste, and abuse. The difficulty which we have with the report prepared by the experts is that they don't account for exposure. They don't account for the number of interactions which members have with black and non-black practitioners. And if the report in its current form had considered the hypothetical scenario which we've presented, the inevitable result would be that a greater proportion of black practitioners are flagged as possibly guilty of fraud, waste, and abuse than non-black practitioners, and by implication, GEMS as guilty of racial bias. And of course, in this extreme example, one can see the difficulties with reaching such a conclusion. Exactly to the points which the panel asked, how does this bear out in reality? So in broad terms, 4 out of every 10 practitioners are black, 6 are non-black. Having said that, 6 out of every 10 interactions which GEMS beneficiaries have are with black practitioners. So black practitioners are responsible for the majority of interactions in the GEMS environment, and by implication, there's more opportunity or exposure associated with black practitioners than non-black practitioners to either perpetrate fraud, waste, or abuse, or be found possibly guilty of fraud, waste, or abuse. So we believe that
There is at least a 60% on your version, at least a 60% opportunity,
yes,
but not a 99% opportunity.
no, certainly not.
So what accounts then for the 39%?
So certainly, if perhaps I could ask for a little bit of indulgence to proceed through the slides.
All right, fine.
Thank you. Okay. So we believe that exposure or opportunity should be accounted for. The next technical flaw relates to corporatized and state practice.
No,
Mr.
but
Gitz, you
you've
are
left-
dealing with lawyers here. You're going to have to slow down before you go on to the next technical
Apologies.
flaw.
No, you've now left this portion. I thought
Yes.
you wanted us to ask you
No,
questions
apologies.
just before you leave this question. Just explain to us, why do we have to make the assumption instead of dealing with real facts?
So the assumption was the 100%, just to illustrate the point, but the real fact is that 60% of interactions are with black practitioners rather than non-black practitioners, and so the real fact is that there is more opportunity or exposure associated with black practitioners.
But
So
the
we-
100% assumption is irrelevant because you've got a 60%
Complete-
data from which we
completely
must work.
agree.
Yeah.
It's simply an extreme example to illustrate the point or introduce the concept. So our point
Just
is...
hold on 1 second. Can I just ask a question on this?
Yes.
Have you tested that if you are a black practitioner who is seeing more black patients,
Yes.
there is a higher opportunity for fraud?
So we've tested that, and we've accounted for that in a revised set of results, which we come to in the subsequent slides.
Perhaps you can explain to us how you tested that.
So what we, well, perhaps to reword it slightly or to clarify slightly, what we have tested for is to say, in the results presented by the experts, they considered the proportion of black practitioners who are possibly guilty of fraud, waste, and abuse. So simply put, they said there's 50 black practitioners, 10 are possibly guilty of fraud, waste, and abuse, so that's 20%. What we're saying is that that ignores the fact that black practitioners have a disproportionate number of interactions or engagements with GEMS members, and by implication there's disproportionate opportunity. So we're suggesting adjusting for that in the underlying methodology. And the adjustment from a technical perspective is relatively simple and straightforward, in that we're just saying consider the fact that the 6 out of every 10 consultations are with black practitioners.
Yes, I mean, I understand that, but I mean, I see that in page 6 of your report, you deal with this issue of the geographic spread versus the actual encounter, and your focus is on the actual encounter. And there the difference is 60-40. But I still say it's not 90-10.
Yes, agreed.
So what do we do about that 30% that shows a disproportion?
Yes. Certainly, it is not 90-10, and I think there are other technical flaws, though, which contribute towards the results which we are seeing, as well as some matters of interpretation in the results too.
I'm working on your data.
Yes.
On what you have produced, that we have a 60-40 situation.
Yes.
In a perfect world, what we will see is 60%, if only exposure was required for fraud, it would be 60% fraud by blacks and 40% fraud by whites.
Yes.
What we know for sure on GEMS is 90% fraud by blacks.
Yes. So certainly, even when we do revise the results, we do see an increased propensity for black practitioners to be flagged as possibly guilty of fraud, waste, and abuse, as opposed to non-black practitioners. What does change is the extent of the difference. So
I understand that, but we can
Yes.
debate the
Yes.
difference, whether it's 2% or 3%. But what I'm really debating now is that both you and Dr. Kimi, in fact, do not disagree on this fundamental premise, that even if you use your own or you use his own figures, what you find is that there is a disproportionate exposure or not disproportionate effect when it comes to the investigation or the instances.
Yes.
So then what on earth is this about, this adjustment for exposure? If you ultimately agree on the fundamental premise that GEMS is more likely to flag black practitioners for fraud, waste, and abuse.
So I think there are two caveats to that. The first caveat is the revised results which we present, which directionally are the same as the results which Dr. Kimi presents, are still based on the surname classification method which Dr. Kimi has utilized. And we have serious misgivings or concerns in relation to that methodology, as we'll speak to in subsequent slides. So whilst we arrive at results which are directionally consistent, we put a significant caveat next to those results to say we cannot fully trust these results because they're reliant on a surname methodology which we cannot fully trust. I think the second point is that although directionally our results subject to that caveat are in the same direction as Dr. Kimi's results, the absolute quantum changes, and the quantum is important. The reason it's important is we see significant differences between our results and that of Dr. Kimi's based on the changes which we've already made, and perhaps further changes to the methodology, such as refining the surname classification, could change the results further and might lead one to a different conclusion.
All right, thank you very much. You can proceed.
Okay. The second concern that we have relates to the inclusion of corporatized and state practices. So the experts appointed by the panel included corporatized and state healthcare practices in their analyses. Corporatized and state practices do not have surnames. So, for example, a hospital will have a name but not a surname. By implication, the racial classifications associated with these practices were based on their practice name as opposed to their surname. And the majority of corporatized and state practices were deemed to be non-black. The reason being that a black surname was not contained within the practice name. To give one or two examples of this, but there are of course many others, Tygerberg Hospital and Polokwane Hospital, which are both state hospitals, were deemed to be non-black by virtue of the fact that a black surname is not contained within the words Tygerberg Hospital or Polokwane Hospital. And this we believe to be a significant flaw with the current methodology. Additionally, from an intuitive perspective, a corporatized or state practice cannot be assigned a race. If we think about a hospital will employ multiple healthcare practitioners, and the race of these healthcare practitioners would presumably be varied. So to deem a hospital to be either black or non-black is problematic.
Can I ask a question on this? Why didn't you pick a random sample and check if his classification was correct?
It's not random.
Apologies.
Please answer the question.
Why did you pick the 800
So
most prominent?
Okay, so I haven't quite gotten to that particular section yet.
Sorry, we've read the report, so we're jumping ahead.
Okay, no, sure. Okay, so simply put, those are the most significant practices in the GEMS context in terms of the number of interactions with members. So those are the ones where we'd want to start our investigations when checking.
So you handpicked them?
Well, we picked them according to the number of
Yeah.
interactions, yes. Okay.
And is there a reason why you didn't randomly check? Doesn't it affect the results?
So I can't be certain because we didn't pick a random sample. But having said that, there's no reason to think that if there's problems with the largest 800 practices, those problems aren't sustained through smaller practices as well.
Is that the section under 3.4 that you are dealing with?
Sure.
I mean, you still have group practices.
So yes, that would be after the group practices section. Yeah. Okay. So, as I mentioned, corporatized or state practice would typically employ multiple healthcare practitioners. Those would be of varied race, and it would be problematic to define a corporatized or state practice as being exclusively black or non-black. We have identified those disciplines commonly associated with either corporatized or state practices, and we believe that there is no choice but to exclude these practices from the analysis, given the concerns which I've spoken to. I'll just briefly run through the list of practices we've identified, or disciplines we've identified. Acute hospitals, ambulance services, blood transfusion services, clinical technologists, day clinics, drug and alcohol rehabilitation, group practices, hospitals, hospice, mental health care facilities, nursing agencies, pathologists, pharmacies, public hospitals, radiologists, rehabilitation facilities, subacute facilities, and unattached operating room facilities. Okay. The next technical flaw speaks to group practices. So the experts appointed by the panel included group practices in their analyses. Group practices comprise of multiple healthcare practitioners as opposed to solo practices which comprise of just one practitioner. A group practice cannot be assigned a race, the reason being that there are multiple practitioners and those practitioners may be of varied race. Additionally, the practice name associated with the group practice does not necessarily reflect all of the providers who participate in that practice, and so there is little way of knowing whether the practitioners are in fact black or non-black. The next technical concern we have relates to the classification of practices. As was already mentioned, what we did is we looked at the practices who were assigned as being black or non-black after excluding the corporatized and state practices and group practices which we referred to previously, and we did an audit. The audit which we performed was a desktop audit, which meant that we did research on the particular practice as best as is possible, but certainly thorough research. We audited 800 practices. Of the 800 audited, we believe there to be fault with 104 of the practices, which translates to 13% of the practices, or more than 1 in every 8 practices. And we believe this to be a significant result. I think to tend to a few possible questions, why 800 practices and not 8,000 or 50,000 practices? And the simple answer to that is it's extremely resource intensive to perform these desktop audits, and we do not have the resources to go through more than 50,000 practices and determine whether they are in fact black or non-black using a very labor intensive process such as a desktop audit. Our point really being is that with an error rate of 13%, it brings into question the results. And a full
I think the question is whether there is in fact an error rate of 13%. I mean, that's really the point, which questions the selection of what goes into the desktop analysis.
So I guess our view was that it is not inappropriate or biased in any way to select those practices which are largest in the GEMS context for review or audit. It's not that we purposely selected these practices, it's simply that these were the practices which are largest. We've got no control as to which are the largest practices in the GEMS context.
Wouldn't the results have been more accurate if you'd done a random sample?
We could have performed a random sample, but I guess we chose to focus on those practices which were most relevant to GEMS.
And that affects the outcome.
Well, any practice will affect the outcome.
There's a big difference between selecting practices and doing a random sample, I think. You must accept that.
I certainly accept that, but I guess my point is that the manner in which we selected practices was not biased. The manner in which we selected practices was based simply on which is the largest practice in the GEMS context.
Subject to human flaws. Sorry.
Would that have included corporate practices?
No,
and group
we've excluded
practices?
corporate practices, we've excluded state practices and group practices. So it's of the remainder.
Anyway, despite your...
Chair, may I ask
Sorry,
a question?
okay, yeah.
I understand your submission that it's not biased, but is it statistically sound?
Let me comment on this. What it certainly could be unbiased in a statistical or biased in a statistical term. What incorrectly classified practices from the non-black group in our final analysis. And so it's sort of a conservative thing. There must have been far more practices that were incorrectly classified as non-black, and therefore it's a conservative thing. We just subtracted only those that we actually identified. The other ones that were possibly in error, we didn't include. So.
I mean, despite this, whatever the criticism is against what you did, the fact is that you still came to the conclusion that Dr. Kimi is 87% correct.
Yes. I think also to add one or 2 points, there is also a sense of pragmatism as to why we focused on larger practices. Certainly it is easier to research a larger practice than it is a small practice, in that information on those practices will be more readily forthcoming. I think secondly speaking, there's no reason to think that if there are errors in large practices, there are no errors in small practices.
Another expert, I'm told, has found that Dr. Kimi is 95% correct. So on your side is 87% correct, and someone else says it's 95% correct on the classification by race. Today we had evidence here. You had the factual witnesses just by reference to surnames, and you can count them yourself. You can see 99% black. So I don't know if this is taking us anywhere. Maybe you should just carry on with the rest of your... is that the last technical flaw?
Yes, it is.
Thank you.
Okay. So certainly I won't go through the specific surnames, but I think suffice to say, what we did find is that many of the surnames which were deemed to be non-black were African but not South African. And that was a function of African surnames which are not South African being excluded from the black list of surnames We have provided a revised assessment. That revised assessment accounts for several of the changes which we recommend. Those changes allow for adjustments for exposure, the exclusion of corporate, state, and group practices, and the rectification of the 104 practices which we believe to be misclassified. I do want to stress the point, though, that we only have adjusted for the 104 misclassified practices which we've identified. There may be others, there almost certainly will be others, and we have not adjusted for that in any which way. And ultimately, further adjustments may change the results further. So we can't say with absolute certainty that this is a fair reflection of the results until the racial profile of all of the practices is in fact verified. So what we do see is the risk ratio reduces from 1.78 to 1.47. Practically speaking, that means that rather than black practitioners being 78% more likely to be flagged as possibly guilty of fraud, waste, and abuse, we suggest the revised results point to a 47% differential.
And why do you then say that there's no racial bias if they're 47% more likely to be flagged?
Okay. So, to our view, the report shows that there is a difference between black and non-black practitioners. A difference, though, doesn't immediately point to racial bias. Certainly, racial bias is one of the possible reasons for that difference. But it's not the only possible reason. There are a host of extenuating factors which could explain that difference.
Sorry, I mean, before we get to the extenuating reasons, I think let's just get to the hard facts. Let's not shy away from them. I mean, on your own, once you start with that 60-40 that you drew at the beginning, on your own findings, 47% is a disproportionate number.
On our own findings, we find a difference, but that finding is subject to the caveat that there needs to be a full review, or at least a more comprehensive review of the surname classification. We've corrected 104 errors. There might be many more.
You stand by the 1.47 risk ratio or not?
We stand by the fact that that is the correct number, subject to a review of the surname classification.
Let's assume we disagree with you on the surname classification. Can we continue with the questioning on that basis? You asked us to make an assumption at the beginning.
Sure.
Now, can you assume we disagree with you on that?
And there's not going to be another investigation now. We are working on what you have found. You had more than enough time to interrogate Dr. Kimia's findings. You came to 1.47. You've put it in your report. You've given it as part of your testimony. So if this is so, it's clear that it's disproportionate if you work off the 60-40 split that you drew at the beginning.
Yes, I can. So certainly, I guess to reaffirm, the 1.47 is our revised result, and that does indicate a difference between black and non-black practitioners, but that difference is subject to shortcomings around the surname classification methodology. Our audit, given the laborious nature of the audit, only allowed for a review of 800 practices, not 50,000 practices. We simply don't have the capacity to audit 50,000 practices.
But I mean, you know, it's either your report has value to us or it doesn't. If you're saying that because you only looked at 800, not 50,000, it's valueless, then let's reject it now. If it has value, then we must accept your number of 47% as a disproportionate number, which means that blacks are still, on your version, more likely to be investigated for FWA.
The value is that we demonstrate that the result changes significantly by virtue of the adjustments which we're recommending, and by virtue of the fact that it changes significantly, it could change further, and significantly so, if further adjustments are made, and if those further adjustments could entail a more comprehensive review of the surname classification.
Even that could be problematic statistically, couldn't it? Because what you're doing is you are taking a body of work that's been done and then introducing factors after the fact to try to, as opposed to the sort of ex post facto analysis, as opposed to doing an a priori analysis of whether there is racial bias?
I guess we're correcting errors in the current report, and we're reviewing the current report. And
No, but I'm saying that even we accept that, that's what you're doing, and I have no problem with the mandate you've given. It's a narrow mandate, but even despite that narrow mandate, you still came to the conclusion that on GEMS's own data, blacks are still 47% more likely to be targeted for FWA.
So I think there is a nuance there. What we're saying is that the result was 78%. We're saying by virtue of the limited corrections which we've enacted, that's moved to 47%. We're highlighting the need to consider further possible corrections, and we're noting the fact that that 47% might stay the same, perhaps it would increase, but perhaps it would decrease. We don't know.
Do we accept your 47%, and can we work with that or not? Not.
So we shouldn't accept this 47% you've put here.
We can accept that the adjustments indicate that corrections to the report make a significant difference to the final result, and further corrections may significantly impact the result further.
Oh, sorry. I understand you keep on putting this qualification. Should we accept the 47% or not? It's your figure. It's not our figure. Sorry, Professor.
Yeah. May I comment on this? If you remember, the original report, Dr. Kimmy's report, said they tested the accuracy and they found it was 99% or more accurate. But that was the classification of the ones who'd been classified black. And they found that they were correct generally. What they didn't classify, didn't check, is the ones that were classified non-black. What this analysis has done has said, let's subtract those ones which in this limited sample from the population, those 104. There will certainly be more. And if we've subtracted more, then that ratio would reduce from 47% maybe to 40%. It would go in the one direction, down. It wouldn't go up.
No, it would go up if you looked at more than 800.
If I may disagree with that,
Yes.
Because remember, it is the incorrect ones are the ones it's the non-black ones that were misclassified, and they should have been more black. There would have been more black, and then the ratio would have come down.
Professor, can you just explain? Maybe you can help us here. Should we rely on this 47%, yes or no?
I would rely on it that it's an upper bound. It's an upper. It could be lower. It could be.
Because, I mean, we have to make a decision at the end of the day. We have a 78% that's been identified by our expert. The GEMS's expert is pointing to 47%.
Yeah.
So we have options to make. What do you suggest as the expert view? Should we rely on this?
My suggestion is that we consider it as an upper bound. As it could be smaller, and I think what comes out in the rest of the report will possibly.
So if we accept it, whether it's an upper bound or not, if we accept that, it still shows that on GEMS's own, your own analysis of GEMS's practices still shows a disproportionate impact on black practitioners, whether it's intentional or not.
That is correct, and that's in fact the conclusion we come to.
I see. All right. Thank you.
And just, sorry, one more question, Professor, on what a remark you just made. If the findings, if the result was that those who were classified as non-black were incorrectly classified and that there may be more black practitioners, would that not strengthen Dr. Kimmy's findings?
No, it's the other direction. Remember, if I can use a mathematical term, it's in the denominator. The number of black or non-black practices are in the bottom line. And it's the ratio of them. So we are possibly increasing. We suggest there would be actually more black practitioners, and that ratio would go down.
I mean, you told us that the proposition I put to you is in fact consistent with your own conclusion. Yeah. Yes. All right.
And are you willing to share your data with us as we did with you?
Certainly, yes. So I think perhaps two further comments, just to reinforce, I think what has already been said, is the proof of the pudding is in the eating. And by that I mean we've made adjustments and that pushed the result down. It narrowed the gap between black and non-black practitioners. So we can debate the hypothetical merits of whether further adjustments would change the gap and in which direction it would change the gap. But what we can say with certainty is that the adjustments that we've made so far have narrowed the gap. So that perhaps provides a real-life scenario as to what impact those adjustments do have. I think the term upper bound is exactly what the 1.47 means. In the absence of any further corrections, 1.47 is a better, and by better I mean more accurate number than 1.78. Is it the most accurate number that can be achieved? Certainly not. A full verification process would yield a more accurate number.
I think we interrupted you earlier as you were explaining that the racial bias was not necessarily the only explanation for this, but there were numerous confounding factors, as you put it. Could you tell us what those might be?
Yeah. So I think exactly to that point, what we believe the report suggests is that there is a difference between black and non-black practitioners. What the report does not demonstrate is that that difference is invariably the result of racial bias. I think it's fair to state that it's an assumption on the part of the experts who prepared the report. They didn't offer any proof that it's the only possible cause for the difference.
I think the question is, what are the factors that you say account for the disproportionate impact on your own findings of black doctors by GEMS?
Okay.
It's not whether or not there was an assumption on the part of Dr. Kimi. You've said there are extenuating factors. What are they?
Okay. So I think to answer that question in a twofold manner, the first perhaps that does still speak to the point which I was mentioning, is that what isn't contained in the report is proof that that difference is indicative of racial bias. It's an assumption. There isn't any statistical...
You really aren't answering our question.
Sure. But to speak to the second point then, in terms of potential extenuating factors, I think, to be quite honest, it is a matter of conjecture, in that one can hypothesize as to why such differences exist. But in terms of the data and the data available to us at this point in time...
So, Mr. Getz, you don't know?
No.
All right, so let's move on then.
Okay. So I think perhaps to just emphasize the point is we don't know. But I don't think the experts who prepared the Section 59 investigation panel report know either. I think it is something which requires far more significant research.
Did you ask GEMS? I mean, once you found that you had a 47%, which, as the professor agrees, also illustrates a disproportionate outcome, you should have asked them. Did you ask them what accounts for it?
So certainly, I think that there is a discussion and debate which can be had further, but I think, to be perfectly frank, it's not something which any medical scheme perhaps would be able to answer conclusively, because those studies and research which are needed to answer that question conclusively have not been performed to my knowledge.
See, the problem, Mr. Getz and Professor Patti, is that we started off this inquiry with schemes denying racial outcomes. We now have, on your version, evidence of racial outcome. Of course, you say there's something else to be done, but on the figures you've given, the racial outcome is clear. Then later on, you said to us, oh, well, the problem is Dr. Kimi is that he omits extenuating factors. And I say, well, what are these factors? We say nobody knows. We've got an unanswered case of racially biased outcomes, both from yourself and Dr. Kimi. We've got a scheme, we've asked these members of the scheme to show us the figures of 2018 and 2019, which clearly show racially biased outcomes. You complain about surnames, I accept that. But at the end of the day, even once you have done your adjustments, you still leave Dr. Kimi's report unassailable by 87%. So now what you want us to do, because your client is here, we are also here, and what you ultimately come with is, well, I don't know what explains the racially biased outcomes.
So, sure.
I think the word is that we contend is biased. What we don't say that there's not a difference between black practitioners and non-black practitioners in FAW. But what we are, and I think what the rest of the talk will also emphasize, is that there are that there isn't bias per se. There's no. It might be a reality. I think if we can go through the rest of the talk, I think it might illustrate that.
Yes, now let me just clarify the issue of bias. I don't mean intention when I say bias. What I mean is outcome. Look at the figures on what you have produced. You know, you may differ 78 and 47. Look at the figures, what you call reality. You see, the figures clearly show that there is a disproportionate effect on black practitioners.
Yeah.
And you may not have had the benefit of hearing all the evidence around this, but there's been much debate about this. It's clear that it's not intention, it's outcomes that we're concerned about.
Yeah, and as I said, we see it's really what we find is, yes, there's a difference. It's beyond our expertise to be able to explain why it is. We suggest, and I think if we can conclude, finalize our talk, then what it could be. It could be other correlated factors which we are not aware of.
I'd like to hear what those are.
Yeah, we also.
So in terms of the extenuating factors, so now we'll move through the first slide quite quickly because I think that really has been covered by the discussions which we've had. But I think suffice to say, the point which we wanted to stress is there is a difference, but there does seem to be a jump from there being a difference to there being racial bias on the part of GEMS. And we do not believe that the data in its current form necessarily proves racial bias. It proves that there is a difference. And I think to add the caveat which I did mention before is that that difference, of course, is based on the current results, which may or may not change further if there was further work done on them. I think what is of particular interest is this slide here. So GEMS, is, as you will be aware, has several different ways of identifying providers who are possibly guilty of fraud, waste, and abuse, be it analytical work or be it tip-offs. What we looked at over here is what happens if we consider only those practices who are identified as possibly guilty of fraud, waste, and abuse via tip-offs. So the tip-offs in the GEMS context is referred to as the Vuvuzela hotline, and that hotline is administered by a third-party service provider. So it's not something which GEMS has control over or can influence which providers are tipped off as being possibly guilty of fraud, waste, and abuse.
You know who administers this hotline?
I'm not sure of the particulars around the service provider.
In your report, you say that it's unequivocally unbiased. I don't know where you draw that from.
So perhaps to clarify that then, what we mean by that is it's reliant on members phoning in and suggesting which providers they believe to be guilty of fraud, waste, and abuse.
You get the actual hard data of the calls received?
No, we've worked on the statistics in terms of which providers are listed as possibly guilty of fraud, waste, and abuse. But I guess to
Who generated that?
The service provider responsible for managing the hotline.
But that's what I would have been interested to see, to understand how do we move from that 60-40 to 1:45, which is the 45% more like a greater likelihood, is whether or not we've got the hard data of the calls as they come in, because that is the best test, as opposed to processed information.
So no, we didn't perform an audit on the record keeping of the Vuvuzela hotline. So we've assumed that the providers who have been recorded as possibly guilty of fraud, waste, and abuse are a true and accurate reflection of members' inputs.
But you see, the problem, and I must put this to you so that because we're having a conversation, I'm not criticizing anyone. The problem, you've listened to the evidence about how that hotline works. So someone phones in or sends an email or whatever. Then it's processed. And then at a certain point in time, a decision is taken whether an investigation should be conducted. And once that investigation is done, it only comes to GEMS really at the last stage when a decision has to be made about a sanction. The problem is nobody knows what happens at entry through the processing stage. Only if we had a proper record of all the calls and all the emails, that we would have a better sense of whether the complaints are disproportionately against black practitioners, or whether in the process of dealing with them, there is human intervention that may account for the racial difference.
So I think our results would be premised on the assumption that the practitioners who are flagged via the hotline are a true and accurate reflection of the practitioners who are reported by members. As I said, we haven't audited that particular process. So on that premise, what we believe is that the Vuvuzela hotline is essentially the voice of the members and the beneficiaries. It provides them with an opportunity to report those practitioners which they believe to be possibly guilty of fraud, waste, and abuse. GEMS has got no ability to influence its members to say, report this specific provider, or report black providers or non-black providers. It is an unbiased observation of which providers are possibly guilty of fraud, waste, and abuse. And by unbiased, I mean it is not influenced by GEMS. When we conduct the same exercise that we conducted using all providers flagged as possibly guilty of fraud, waste, and abuse, but this time we limit only those providers who are flagged via the Vuvuzela hotline, we arrive at black providers being 1.45 times more likely to be flagged as possibly guilty of fraud, waste, and abuse, which is almost precisely consistent with the overall GEMS results of 1.47, of black providers being 1.47 times more likely to be flagged as possibly guilty of fraud, waste, and abuse. This then leaves one with a number of conclusions. One of the conclusions would be that if a higher ratio immediately indicates racial bias, then even the call center, even the members, even the beneficiaries are guilty of racial bias. And that's a very significant assumption or statement to make. It's far more palatable to think that there are perhaps extenuating factors, which, as we noted, we cannot explain, which are responsible for the difference.
The logical conclusion of that, not that black practitioners are more likely to commit fraud, waste, and abuse.
No, so I think that would be well beyond our ambit and not what we're suggesting. What we are suggesting is there are
But
perhaps...
what could be the other explanations if it's not racial bias?
Certainly, I think if I can just add one comment before handing over, there are perhaps extenuating factors such as the size of practice, such as the modality of practice, and perhaps there are differences between black and non-black practitioners which neither ourselves nor the experts appointed by the panel have identified or have considered. And maybe that's leading to the difference. The short answer is we don't know what the difference is, but we're not suggesting that there's a fundamental difference between black and non-black practitioners. We're suggesting that there are perhaps extenuating factors which neither party has identified, which result in the differences which we're seeing.
Well, at the beginning, you showed us on your version the 60-40 split because you said the basic problem is failure to adjust for exposure, but I'm tempted to accept that is a factor that one must adjust for exposure. But once we adjust for exposure, we get to 40-60. But then we still cannot account for the 1:45, and we still cannot account for the 1:47. And that is why Advocate Hassim is right when she's asking you that you must then accept that the logical outcome of your statement is that blacks are more likely to commit FWA than whites.
I just add my comment to that. I think the simple-minded one is exactly yes. What you say is that either black healthcare providers are more likely to be perpetrators of FWA, but statistically, there could be other factors correlated with race that is responsible, or that are responsible. But that's as far as we can go. We're not sociologists. So the question of what that factor could be, we can't comment upon. So,
Professor Fatty, can I ask a question just to take you back a bit? I hear what I take your submission on that, and I suppose the role of lawyers is different from sociologists. We rely on evidence. So, can I just take you to page 11 of your report? Because I'm still grappling, I mean, we only received this report yesterday, I think. I'm still grappling with your assertion that on the revised results, there will be a decrease in the risk ratio. So can I take you to page 11 of the report?
yes, we just
So as I understand it, you said, look, if you handpicked or you went through all the practices and classified them according to the methodology you're proposing, the risk ratio would decrease further.
Yeah.
Okay. But here in your revised results in figure 5, in the year 2017, in fact, the risk ratio went up there on your revised results. So I don't understand how you can say with certainty that it would decrease.
Remember, we're talking about the overall one over all those from 2012 to 2018 was it? Yeah. Again, the point I made is that possibly the way we handled the misclassifications was to just take off those 104 non-black classified practitioners, taking them out, taking them out of the analysis. In fact, and accepting Dr. Kimmy's result that the classification of black practitioners was pretty accurate. It's the default classification. If it wasn't, they weren't classified as black, then they were automatically classified as non-black. So it stands to reason that we just took from that relatively that sample and that biased sample in terms of size, we took away the 104. There would, I imagine, have been more black practitioners who'd been incorrectly classified as non-black, and that would have increased the denominator of the total number of black practitioners, and of course the interactions too as well, and so that would have reduced that number further. So that's really.
How do you explain that increase in 2017?
Well, it might well have been the case. It might well have been the case. I wouldn't be able to explain it. I couldn't explain it.
Okay.
So where do we end with this thing? You see, because I think where we stand, we just need to get some clarity about where we stand with this. You have some criticism over the methodology. One of the major criticism is failure to adjust for exposure, which I understand. And you say there's something about misclassification. But once you have done your exercise, you come to the conclusion that there is still a disproportionate impact on black practitioners. You say that it's not necessarily because of racism on the part of GEMS. It may be because of extenuating circumstances. You say you have no idea what those extenuating circumstances are. But on the fundamental question, are black practitioners more likely to be investigated for FWA? You agree with Dr. Kimi, your adjustment is on the percentage.
Yes, I think so. It's just the reasons behind that.
All right, thank you.
So I think to that point, if we just run through our conclusions, I'll run through it quickly because I think a fair bit of it has already been discussed. To start off with the technical considerations, we do believe there are several fundamental flaws in the analyses which have been prepared so far. Those flaws relate both to the interpretation of results as well as the technical nature of the work which was performed. The technical shortcomings relate to a failure to account and adjust for exposure, the inclusion of state and corporate disciplines, the inclusion of group practices, and incorrect racial classifications. The technical shortcomings materially distort results. And as I said earlier, the proof is somewhat in the pudding in that we do see the gap between black and non-black practitioners narrow when these corrections are made. Certainly, the results might change further. We're at a point where the difference is 1.47, but that difference could decrease further if there is a full verification process. We cannot be certain exactly how or to what extent the results would change, but they almost invariably will change. And based on what we've seen so far, the gap is likely to narrow further. In terms of the interpretation of results, we do see the difference, but at the same time, we believe that the experts jump from there being a difference to there being racial bias on the part of GEMS. And nothing from a statistical perspective or nothing contained in the report prepared by the experts suggests that that difference can only be an indication of racial bias on the part of GEMS. There are other extenuating factors which are possible, and we do believe that more comprehensive research is needed to determine the potential impact of those extenuating factors. And on that basis, we do not believe that the report suggests that GEMS is guilty of racial bias. Thank you.
Thank you very much. What is the way forward?
Chairperson, we would love to make conclusions. I'm aware of it's 5 o'clock. I will summarize it.
Feel free. I mean, I think we can stay for another 15 minutes.
Okay,
but,
thanks.
Feel free.
We'll do our best to conclude within that 5 minutes. Chairperson, I don't know if I should wait for the presentation to be swapped again, and then we go to
Dr. Mulabi, while you're swapping slides, can you speak to us about what now that you've got the report from your experts,
yes,
which show that black doctors are more likely to be flagged, and there's been discussion about what the reason for that is.
yeah.
What are you going to be doing about that as GEMS? Now, surely you must now accept that that is a reality.
And that reality, and I have noted the question. I'd love to start with the reality that you're saying. The reality, the way it is expressed, I think it's very important in terms of saying, was there an intent? And the chairperson did mention intent earlier on. In the report, Dr. Kimi's report in the conclusions, it basically says there's evidence of racial bias. However, and I don't know what the chairperson and what the panel would make of this. Once the report was released, there was a public statement that was made. There was a conclusion that was flighted, and the first line was saying there's no evidence that the processes that are followed are racially biased. The second statement then said the outcomes show racial bias, which sounded like a contradiction. When you read the actual report, it doesn't say that. So I thought that's very significant, and I think one of the things that the NABOF part, while we do see the 78% possibility that the outcome will be biased towards black doctors in terms of fraud, waste, and abuse, and then it is reduced to 47% in this expert report. What it shows what is defined as racial bias. However, there is no intention, and I think that is the point that, from a GEMS point of view, at no point in time in terms of that work that we do, did we say we are going to target.
But are you going to ignore the outcome?
No.
The reality?
No. We actually, in our conclusion, Chair, there is a slide that, it's a slide that basically says the necessity of this inquiry and the fact that we will welcome the outcomes. We do state it very clearly, to the extent that there are some things that we've already noted even from some of the discussions that we had earlier in. So while we have made submissions like we don't identify doctors on the basis of their race when we compile a database. We have made that statement because we have used CMS. But we have also said earlier on, when we come into contact with the doctors, we see who they are. That was the point that was made when the question was asked. Would you say you don't know these are black or white doctors because now you are entitled? The fact that the reality is we find when we interact with them that the majority are black doctors. However, the trigger was not, we are going to look for the black doctors who are committing fraud, waste, and abuse. And that is the nub of our, I wouldn't want to use the word rebuttal, but this is really our position to say we cannot be accused of intentionally targeting black doctors. The reality that exists out there is that we find that when we do the fraud, waste, and abuse initiatives, it happens that we find that, and that's the reality. And I think the issue of the reality was mentioned earlier on. And I just want to close by saying, before I say, that, when we read the report for the first time, I said to my colleagues, if our history as South Africa is such that we used to have malnutrition in the population, and then we have criteria for malnutrition, and then we say, we're going to, just based on your weight, let's use weight. Weight, if your weight is like this, you are malnourished. We go and find those people who are malnourished based on weight, and we find that more of them are black. Does it mean that we targeted blacks? No, we find the reality. You can't change what exists out there. And I think this is the reality of what has happened in this instance. So the question that you asked, Advocate Hassan, is that are we going to do something about? I have indicated that in our conclusion we have said we will welcome the findings, and we will obviously act on them based on what will happen.
You don't have to commit too much to us at this stage.
Yes.
I think just give us your concluding remarks. I mean,
so
all of this information is fresh. It needs to be processed.
Yes.
And you need to get time with your executive to reflect really on what we now know is just the hard truth, which is difficult to accept, that even on your own experts report, there is a problem of racial distinction between white and black, which you say is not intentional.
Yeah. And Chair, I'm now going to go through a quick conclusion, but the point that you have just made, we basically saying in a conclusion that Section 59 and the application thereof is a complicated topic. Now, you have just said we shouldn't commit too much to what you say. And I think that's a point I wanted to make, this point, that we noted earlier on where, Chair, you were saying you're disappointed in terms of administration of justice in how we're dealing with Section 1559. And at that stage, we did say, yes, we do look at it. But we can demonstrate also to you that we have to be prudent in everything we do. If you look at our history in terms of what we wanted to achieve in terms of access to health care, we did not underwrite, which is what the law, the Medical Schemes Act allows us to either underwrite or not to underwrite, which was not to because we wanted to promote access. To put it mildly, we got blooded around 2016. So the intentions that are good in terms of leading the industry in a certain way can be there, but we still have to be prudent in ensuring that we safeguard the funds of the member. And it's a balance that we need to strike between going just in terms of the requirements of the Medical Schemes Act and doing more than what you are required as a basic minimum, because sometimes when you try to do much more, you end up having a situation like we had in 20. And those are the considerations when we welcome, we'll be looking at striking that balance between maybe where we may have been blindsided and saying we can do better than we did based on what we have received. So, Chair, basically, we also saying in terms of what we have submitted, we are a large organization. We basically have demonstrated a 40 billion contribution income medical scheme, and we have to act responsibly all the time and prudently to ensure that we make sure that those members who are paying for insurance cover can at least get the insurance cover. We don't have any motive whatever to discriminate against black healthcare professionals. We try to follow the legal route as best as possible and adhere to the Medical Scheme Act. We do not incentivize recoveries in a fraud and waste environment. And we have stated now that our fraud, waste, and our posture with regard to fraud, waste, and abuse is that we would love to engage with the healthcare professionals who are found to be engaging in this and rehabilitate as best as possible. And I think that talks to the very emotive issue of punishment versus what is it that we can assist those who may have committed fraud. And I think that is our posture. It is demonstrated on that slide. This next slide has been spoken about quite a bit in the past. I don't think I'm going to talk to it. Suffice to say, I think the intention here was to say, if you look at the last column, the one that says 45% of those, and I need to be, so when you look at the vuvuzela is not influenced by anything except a member who thinks the fraud may have been committed against them. And it seems to show that there is a 45% chance that those doctors against whom our members phone in will be black doctors. It seems to be a reality that is found out by a whistleblower line that is influenced by no intentions of saying I'm going to target black doctors or not. And I think that is the point.
The only problem I was trying to explore with your expert there is what exactly is that 45%? Is it calls received or is it just data recorded after being processed? And it looks like what they received was just recorded data after being processed. What we don't have is whether or not this is an accurate picture of the calls as they come in and emails as they come in, or whether somebody tests the information first.
Yeah. Okay, so what I think we can try and do in our supplementary submission, we can address that and try and explain exactly what is it that they used versus the actual, and what my understanding is that you want to have a clear indication of what is this 45% that is being expressed in that column. And I think we'll do it in our supplementary, the explanation in our supplementary submission. Chair, we have several recommendations which you did indicate earlier on that you have read them, and the other members of the panel have indicated that they have, I think these are very important, but albeit it's 22 of them, I'm not going to go through them line by line, but I'm going to try and summarize each section of but they have been submitted as part of our supplementary submission, so that is what should be on record. We have expressed that we acknowledge the importance of this inquiry. And I think the one thing that I cannot live here without saying is the fact that we cannot move away from our history as a country. And a lot of these things are also influenced by our history. I think it's a broad statement, but it's a reality. And a lot of the accusations that GEMS is racially profiling black doctors, and then all of this, it's also playing out in terms of the social dynamics of where we come from as a country. So we think it is necessary sometimes that we do have to take a pause, look at the things that we've been doing and see where we can improve. And it is with that spirit that GEMS has made submissions to this inquiry. So, Chair, there is the recommendation that relate to and Chair, number 2 on that slide, there's a note that is missing there, a very crucial. GEMS submits that the bearing in mind the facts, the panel that GEMS is not involved in any not it's missing in the actual supplementary. The note is there, but I need to draw attention to that and put on record, Chair. This is very important.
Confirm. Many a true statement is made in jest.
Yeah, okay. Chair, and then with regard to Section 59, I think there was a long discussion. I have indicated that it is a complicated interpretation matter. You did indicate that in terms of administrative justice, sometimes just applying the law may have some unintended consequences, like some of the sufferings that you've spoken about in terms of healthcare providers and all that. And I have said we need to look at this. You know, the basic thing in terms of our environment, we are a regulated environment. We say we have to stick to the law, and then above that you can do other things. But I go back to sometimes it can have unintended consequences. So, but we have noted what we have said in terms of administrative object. The other point that I was questioned on earlier on, and we make it in the next submission with regards to the recommendations, which basically indicate that some issues are related to lack of understanding, difference of interpretation. For instance, the issue of codes, where codes are blamed for submitting erroneous claims, and then we then interact with those codes at the level of what are the rules, what are the policies, and then we apply them, and then you find that sometimes there could be suffering, whether it be with healthcare providers who are expecting payments, who are making a living on that. So the issue of education here talks to both the responsibility of even the healthcare providers themselves. I cannot just start a practice and then not try to learn how am I going to claim from medical schemes, and then when I'm not paid for 6 months, and then I start blaming medical schemes. They have a responsibility to ensure that if I am going to start a private practice and I'm going to claim from medical schemes, I have to make sure that I learn how to claim from medical schemes. There's a Medical Schemes Act, and there's rules. All of those things influence this whole thing. So we have several submissions that we are making and recommendations in terms of how healthcare providers themselves can learn. Can learn. So that was that. I was talking to that slide, so I didn't change it. So, Chair, this slide basically talks to recommendations that relate to the challenges experienced in the regulatory environment. And the health market inquiry also makes this point that maybe some of the things that happened in the healthcare funding industry were as a result of challenges that relate to regulation, if I can put it broadly.
I mean, the specific problem seems to be at the HPCSA level. I looked at complaints lodged since 2016. Just no progress has been made whatsoever.
Exactly.
People, if they're not guilty, they should
So, Chair, and it's one of the sanctions is that we report healthcare providers and expect progress, and it doesn't happen. And thanks for that point. And this is the last slide, but one comment that I'm going to make. So in terms of some of the things that we think are important to sort out some of the problems that led to Section 59 investigations, it's really the interaction between us as healthcare funders and the healthcare providers. We have stated and that we need to engage more, and there's also needs to be engagement with other stakeholders like the SAPS when it comes to where we think there's been criminal activity. So it's really various engagement with the various stakeholders that interact with GEMS.
Tell me, these bodies that came here at the beginning of this inquiry, Dr. Gumede, isn't there a platform where you will speak to them regularly?
Chair, at the beginning, Dr. Guni actually did mention something. We have met them, and we have said to them, we want to meet regularly so that we don't have to be fighting in the public. We meet them. We also bump into each other in conferences and things. And sometimes what we see in public platform is not exactly what we see when we interact. So, and you did ask earlier on, is this true? And we're talking under oath. What we are saying, it's true sometimes. So I talk to them, if actually, Dr. Gumede, and you've mentioned Dr. Gumede several times, that's the NHCPA. These are people at the GEMS level. And I don't know if there is time. If you look at one of the triggers of this whole thing, which was the SABC show, there is actually where one of those doctors says, no, GEMS is not a problem. We're looking at the other individuals. But if you can go and review it, it would actually, that statement actually comes out of there. So the platforms are there, Chair, and we committed to ensure that we interact with healthcare providers because we are the second biggest funder of healthcare in the private sector, and we have a responsibility to ensure that we do our best to reach out, and that is still open.
I mean, it does appear that if these protocols on how to deal with Section 59 could be not necessarily bargained, but there could be basic principles in these meetings that are agreed by them as well as the organization. So if there's basic protocols on how to deal with Section 59 aspects, are things that could be agreed, perhaps in a way similar to a collectively bargained deal, as it happens in the employment sphere. Just basic principles which can then be applied by each schemes. The impression I've received is that there is a high level of acrimony, and people speak through the Human Rights Commission and through the Section 59 panel, whereas this is your industry, not our industry. We are outsiders in the industry.
Chairperson, as I conclude, in terms of the submission, really, that's what we have submitted. It's in our submission. My concluding remarks is really, I want to ask for your indulgence, which is not part of the record. But we started the day today with an oath, and it says, "So help me God." And Chair, the big part of this whole thing is about racial classification. We have moved from where we used to have Europeans, non-Europeans. During this, we are now having black and non-black, which is something that never used to be there. But we had to use some of these terms, Chair, because they were part of our explanations. However, Chair, will conclude by saying there is actually only one human race. And that's how I end it. Thank you, Chair.
Thank you, Viva Sobukwe. I also want to thank you as the leadership of GEMS for the time you've taken to respond to our questions, to prepare for the inquiry, to come and present. It's sometimes been tough, but it's always been collegial. Thank you. There will be further inquiries. They will be directed in writing. And again, if you don't mind indulging us further in responding to our questions. We are adjourned until tomorrow at 10.